Good morning, respected dignitaries, esteemed faculty, and dear delegates. On behalf of Association of Physicians Solapur and Solapur Obstetrics and Gynecological Society, it is a privilege to welcome you all to today's joint CNA scientific program. Today's sessions are thoughtfully curated to address real-world clinical challenges in pregnancy and women's health, helping us translate knowledge into better patient outcomes. We now begin our morning scientific session.
I invite Dr. Sunil Hirapure to deliver this important session. I request our chairpersons, Dr. Anita Bandichore, Dr. Jayant Golwalkar, Dr. Snehal Pawar, to kindly grace the dais. Dr. Hirapure is a consultant hemato-oncologist at Ashwini Hospital, Solapur, with MBBS, MD Medicine, and DM Clinical Hematology. He served as Assistant Professor Hematology in KEM Hospital and has won a distinction in pathology.
So, coming straight to the point, when we think about platelets disorder in pregnancy, we think of thrombocytopenia, and very rarely we think of thrombocytosis, like platelet count more than 4.5 lakhs. The most important cause being in our country for thrombocytosis in pregnancy is reactive cause, rule out iron deficiency plus. Infections are the second most common cause, and third but last rarely we may having been dealing with MPNs, myeloproliferative neoplasm. So that topic I have not covered today, thrombocytosis. So we are mainly dealing with low platelets disorders in pregnancy. So what is thrombocytopenia? Everybody knows, less than 1.5 lakh. Thrombocytopenia, second most common after anemia. Incidence is 6 to 12% in third trimester of pregnancy. So what are the causes of thrombocytopenia in pregnancy? So these are pathophysiologically associated with pregnancy. Most common being your gestational. Second most common, preeclamptic thrombocytopenia. Third most common, HELP syndrome. And rarely you may get acute fatty liver of pregnancy. More common in pregnancy and during labor, puerperium. Mostly DIC, rarely TTP and HUS. We call it as a thrombotic microangiopathies. And our common myth, thrombocytopenia pathophysiologically not associated with pregnancy, occurring in a pregnant as often as in non-pregnant patients, common being ITP, spurious, or we call it as a pseudothrombocytopenia, rarely congenital thrombocytopenias associated with viral infections, bone marrow infiltrative disorders, and not to forget vitamin B12 deficiency thrombocytopenia. So what are the incidents? So as I talked earlier, the most common pregnancy specific, 70 to 80% of your thrombocytopenia in pregnancy is gestational. Not pregnancy specific, primary ITP means there is no underlying cause, amount for your 5% of cases. Secondary, less than 1%, and other rare being drug congenital thrombocytopenias like von Willebrand disease, Bernard-Soulier, Glanzmann's, and third ones with systemic disorders. The second most common cause, severe preeclampsia, 15 to 20% cases, HELP and AFLP, rare less than 1%. And not to forget the other autoimmune disorders which are more life-threatening, thrombotic microangiopathies like TTP, HUS, SLE, APLA, and rarely we may have splenic sequestration in a case of liver disease with portal hypertension. So why to refer such patients? Because we have three major challenges. To identify when is maternal thrombocytopenia is a health hazard, is life-threatening disorder. To obtain an adequate platelet count for your challenges of delivery, either normal or LSCS. And last but least, we forget, help to evaluate the risk of thrombocytopenia in a baby, that is neonate. So coming to the causes, we will first deal with the most common cause, that is gestational, followed by most complicated or difficult in our practice, ITP, by case basis. Certain are hypothetical cases, certain are real cases. So coming to the case 1, she is 23-year-old prima 7-month pregnant, platelet count on routine examination 65,000. Here crux is no previous reports were available. Refer for thrombocytopenia to hematology. So no previous history of bleeding. Other like anemia and platelets are normal, evaluated. No previous history of bleeding, CBC, platelet count 65, rests are normal. So why I have shown this slide? Because peripheral smear examination is much important in such case. It is a case of pseudothrombocytopenia as shown is in this diagram. It is a EDTA induced platelet clumping and there is no need of any intervention in such cases. Why this happens? Because in certain genetically predisposed individuals, EDTA causes conformational change in platelet. It exposes your GP2B receptors on your platelets and certain individuals have antibody against that receptor and it causes pseudoplatelet clumping and your normal machines will not give an exact value. If see, this slide shows the pseudothrombocytopenia, but what will happen if smear is like this? It is showing reduced platelet with giant platelets, or we call it as a microplatelets. So other possible causes can be your ITP and rarely your congenital thrombocytopenias, Bernal Solier or your Glanzmann's. So coming to theory part. So when to suspect gestational? Patient asymptomatic, normal prenatal platelet counts, generally occurs late into second trimester and third trimester, normalizes 2 to 4 weeks after delivery. Patient have mild thrombocytopenia. Rarely patients' platelet counts are below 50,000. Usually they are more than 70,000. Why it is important? It is a diagnosis of exclusion. We have to exclude other diagnoses and then label it as a gestational. Recurrence rate may be 50% in second pregnancy, occur in 5 to 8% of all pregnancies. 80% of your pregnancy associated thrombocytopenia are gestational. We call why it happens because the mechanism is still not clear, but hemodilution, accelerated platelet turnover and destruction at the level of placenta are the postulated causes. And maternal hemorrhage risk in gestational thrombocytopenia is not increased, fetal not increased, so no need for any intervention in gestational. So coming to important topic of discussion today, ITP, when we call ITP less than 1 lakh after excluding all other causes. So when to suspect ITP in a pregnancy? Any trimester can happen, but especially likely to be immune thrombocytopenia if platelet counts are less than 50,000, occurring in a first trimester, and there is a previous history of any autoimmune disorder. So management during gestation is an important part before 34 weeks of gestation, say before 8 months. A therapy, if platelet counts are maintaining above 30,000, in absence of any bleeding or comorbidities is not required. Only monitoring. If platelets are less than 20,000, we have to treat. But after 34 weeks, it changes. More frequent monitoring, say 2 weekly. If platelets are less than 80,000, which is cut off for your epidural or neuroaxonal anesthesia, we have to treat the patient. Then how to treat? Your first line are steroids given in a dose of 0.5 to 2 mkd. We have to wait for say 4 to 5 days to see the response. Maximum response happens within first 2 weeks. If no response to prednisolone, we can try other drugs also, but there is a, if see there is an emergency, a patient is having to go for delivery within 48 or 72 hours, we have option of IVIG. But keep in mind, it is only used for the rapid platelet correction and in life-threatening bleeding. It is not routine in pregnancy. Dose and side effects we have to keep in mind. The most common being aseptic meningitis, nephrotoxicity and rarely thrombosis. But problem with IVIG is that it is a transient response. The platelet remains increased only for 2 to 3 weeks. So to summarize, first line steroids, if no response IVIG. Third line, that is when benefit outweighs the risk, we can try azathioprine, anti-D and newer thrombopoietin agonist, we call it as L-Thrombopag and romiplastim. Strictly contraindicated are your MMF, cyclophosphamide, vinca alkaloids and danazoles. So why is ITP important? because your maternal risk is increased for maternal hemorrhage. When platelet counts are less than 20,000, risk of spontaneous bleeding. Less than 20,000, it is an emergency, ITP with pregnancy, we have to act. More than 50,000, aim for normal delivery. More than 70,000 is okay for your epidural anesthesia and induction of your labor. The most thing we forgot in case of ITP is baby. It is due to transplacental transfer of your maternal IgG antibodies. 10 to 20% have a platelet count of less than 50,000, but 5% may have less than 20,000, and then we have to treat. Because if you are not treated, patient may have life-threatening bleeding. The options are IVIG, prednisolone, and generally it goes away after 4 to 6 weeks. So coming to the second case, we are coming to second case, 35-year female, G3, P3, L1, one history of IUD, 7 month, presenting with headache, edema. On examination, there is a pedal edema. BP is on slightly higher side, 160 by 100. What are the causes and how to work up? Because this patient have a low platelet count. We are coming to the hypertensive disorders of pregnancy, preeclampsia, HELP syndrome, acute fatty liver of pregnancy, and last but least DIC. So everybody knows what is PIH. Platelet counts only mildly decrease in such cases, say around 80, 90, 1 lakh. Platelet function is good, no difficulty with hemostasis, and no evidence of coagulopathy. More than 140 by 90 after 20 weeks, severe, we call it as eclampsia with end organ dysfunction. Generally platelets are less than 1 lakh, and these are the two criterias we might be knowing everybody. So second most common after preeclampsia is HELP and AFLP. Why I have shown this slide, severe thrombocytopenia is infrequent in AFLP, but severe coagulopathy and encephalopathy are more common. So prompt delivery is needed to prevent the rapid progression AFLP regardless of any gestational age. So when to intervene in hypertensive emergency? If there is a severe thrombocytopenia, any coagulopathy, patient is actively bleeding, or should be taken for any surgical procedure or delivery. So management, obstetric management, everybody knows treatment is a prompt delivery after 34 weeks, lung maturity, steroids, hematological. Supportive care with blood products if there is no contraindication to platelet transfusion. And if a patient of HELP, AFLP is not improving after 48 to 72 hours of delivery also, then we can think of other causes or try therapeutic plasma exchange if patient condition is worsening or renal failure sets in. So coming to the third most common cause we encountered in our practice for the thrombocytopenia is autoimmune causes and microangiopathies. This is a diagram, peripheral smear of a patient who is developing microangiopathic hemolytic anemia. So what is that? We will see in further cases. So this one presented to us with 7 months of pregnancy with petechiae on bilateral lower limb, BP on higher side. See, this investigation shows a low platelet count, ALT, your liver enzymes have raised. The crux here is coagulation is within normal range. PT, APTT is normal. So peripheral smear, again, we may get cystocytes, NRBCs, small microspirocytes, but diagnosis in this case is HELP syndrome. But coming forward, same lady, 8 months of pregnancy, she is not feeling fetal movements since last 2 weeks, fetal heart sound absent, sonography IUD. The picture changes, here coagulation profile get deranged, APTT deranged, INR deranged, platelet goes down, D-dimer high. So she is a DIC secondary to your IUD. So these are the important causes of thrombocytopenia in our day-to-day practice. It has varied causes, the most common being infection, return products, septic abortion, and last but least preeclampsia and HELP. So how to treat DIC? The treatment is controversial, but the foremost important is identify and eliminate the cause. Mild DIC, self-limited, asymptomatic, only abnormal test, don't treat. Blood component only to be given if patient is actively bleeding or have to be taken for any procedure or delivery. How to give FFP 10 to 15 ml per kg, may be repeated 12 hourly. We forgot to replenish the fibrinogen concentrate in patients. So look for the fibrinogen level also. If it is less than 150, try to give cryo 1 bag for per 10 kg. Nowadays, we are getting fibrinogen concentrates also. So we can use that also. And what about platelets? So we have to maintain platelets above 50,000. So platelet transfusion 3 to 6 units to be given. In all of these conditions, a delivery of baby is most important intervention to be undertaken. So coming to the microangiopathies latter part, she is a real case, 25-year female, resident of Kalburgi on mixed diet. On 7 months, presented with fever and decreased urine output. Fever was low grade. For above complaints, received 2-point PCV at local hospital, remain asymptomatic, but after day, she is complaining of altered sensorium, headache, drowsiness and altered. On examination, pallor, icteric, echomatic patches were there. So what comes in our mind? Can be a sepsis, can be a DIC, or rarely can be a TTP, that is thrombotic thrombocytopenic purpura, or hemolytic uremic syndrome, or very rarely atypical HUS. So these were her investigations. HB was 5.8, retic was elevated, platelets less than 20,000. Here crux is peripheral smear showing the evidence of microangiopathic hemolytic anemia. As shown in this diagram, classical cystocytes, microspirocytes and NRBCs, LFTs, indirect hyperbilirubinemia, create was deranged. So somebody will ask me, sir, why it is not DIC? DIC also shows picture like this. Here crux is PT, APTT, TT were normal. Why it is not a hemolytic anemia? DCT is negative. So in a case of suspected TTP, always we will do PT, APTT and DCT. And if you confirm with any of these fever and microangiopathic hemolytic anemia with suspected TTP, don't wait for any neurological sign or nephrological signs to appear to call it as a TTP, because it is an emergency. We have to urgently refer such patients, because a classical pentad of TTP only seen in 10 to 30% of patients, and termination of pregnancy in TTP does not always guarantee a cure. So the TTP is a diagnosis of exclusion. The full pentad I have told earlier, less than 1/3 of patients, this is a full pentad, but for us, fever, thrombocytopenia, evidence of microangiopathic hemolytic anemia is enough. So some will ask, sir, whether to give platelets in TTP. No, it is absolute contraindication. Unless and until patient is bleeding, or if you have to put a central line and platelets are less than 20,000, then only we will give platelet transfusion in such cases. Otherwise, it will be like adding fuel to the fire, because the basic mechanism of TTP is a strong platelet activation due to your large increase in the large VWF multimers. So if you giving platelets more, it will call again strong platelet activation, and cascade will go on, and it will cause a widespread thrombosis into the body. So why to refer a TTP patient on emergency basis? 1 in 25,000 occur major in late trimester or during puerperium, 10% only occur in first trimester, because without treatment there is a 80 to 90% mortality in such cases. So with advent of plasma infusion, therapeutic plasma exchange, steroids and rituximab, we are able to save 90% of such cases nowadays. And in say last 5 years, we have treated 8 to 10 such cases with the help of gynecology and Dr. Kiran Joshi sir. We are able to save all the TTP patients with the therapeutic plasma exchange, rituximab and other immunosuppressions. So I will not go into the details of management, but basic management relies upon plasma exchange, steroids, in refractory cases, rituximab and other immunosuppressants. So to summarize, if you have platelet count of less than 1.5 lakh, rule out your medical disorder, see for any drug history. If there is no history of ITP, drug ingestion, medical disorder, examine the peripheral smear. If it is pseudothrombocytopenia, no need to intervene. If thrombocytopenia associated with cystocytes, evidence of MAHA, that is microangiopathic hemolytic anemia. Look for your preeclampsia and HELP syndrome. If that is ruled out and if patient is presenting with fever, with focal neurological signs not like that ki patient may have seizure only or coma only. It can start with your mild headache, confusion, altered sensorium to your seizures and encephalopathy. So probably we are dealing with more major life-threatening disease like TTP or HUS. And last but least, only thrombocytopenia. We forgot to do a common basic test, that is your viral infections, HIV, HCV and HBV, and ANA profile, apply if indicated. If normal and platelets are more than 75,000, follow up monthly. If less than 20 to 30,000 before 35 weeks of gestation, treat for ITP. If less than 80,000 after 34 weeks, we have to treat. So this is a summary. Exclude first the preeclampsia syndromes, excludes non-pregnancy related medical issues, when to refer a known case of autoimmune disorder or ITP, unknown cause and platelet count is less than 1.5 lakh in first and second trimester and less than 1 lakh in third trimester. Otherwise, monitor CBC monthly till 8 month, bi-weekly in 8 and weekly in 9 month. So, clinical history as always important, the basic timing of onset of thrombocytopenia, whether it is occurring in first trimester, most likely to be ITP, whether it is occurring in third trimester and platelets are 70, 80,000, more likely to be gestational if other causes ruled out. Pre-gestational platelet count, we have to look at exposure to certain medications, concomitant symptoms suggesting infection has to be ruled out, and last but least, family history of any inherited thrombocytopenia has to be taken into account. Physical examination, we all know if patient is having extensive bleeding, wet purpuras, that is emergency with hypertension, think of preeclampsia. Patient is having arthritis or serositis, case of secondary ITP with autoimmune disorder, patient with thrombocytopenia with lymphadenopathy or hepatosplenomegaly, concern for more hematological advanced diseases like leukemia or lymphoma. And last but least, thrombocytopenia with neurological findings, concern for TTP or severe preeclampsia. So always review the blood smear because that is the starting point of your all the diagnosis. Can be a plain pseudothrombocytopenia or can be a microangiopathic hemolytic anemia. Consider the clinical setting and history. Ask for additional test only if consistent with above findings. So this is not related to pregnancy, but I want to discuss this case because we all are giving heparin in day-to-day practice for n number of things. So this was the case, platelets were 3.5 and after giving heparin for 6 days, on 6th day his platelet count falls below 1 lakh, that is 92,000. Smear shows low platelet, no abnormal cells, no evidence of microangiopathic hemolytic anemia. Day 9 platelets were 15,000. So was given heparin, no bleeding at any sites, decision HIT. So what is HIT? The most common is type 1 HIT, incidence is 20%, it is self-limited, non-immune mediated, no need to do anything, just monitor CBC and it is within 2 or 3 days it will recover. We can continue the heparin. But type 2 HIT is more concern, immune mediated, incidence is very rarely, we are mainly see in orthopedic surgeries followed by cardiac surgeries and lastly medical patients. Incidence is 1 to 3%. How to suspect? It is a major clinical diagnosis. When your platelet goes by 50% from baseline within 4 to 10 days of starting heparin, we have to suspect a HIT. Why we have to suspect? Because if not treated, 80 to 90% will have a fatal thrombosis. So how to manage? We have to stop the heparin and start newer anticoagulants like lipuridine, argatoban, danoproid, fondaparinux and bivalirudin. So out of this only we will have an option of fondaparinux. So after we have treated with fondaparinux, what to do? So anticoagulation is the must, should be continued for 3 to 6 months post your HIT episode. If not continued, 25 to 50% of patient will have a fatal thrombosis. So that is the crux I wanted to discuss in this case. So I have told earlier when to suspect, 4 to 14 days after exposure, but early hit can also happen if a patient have received heparin within last 100 days. Clinically, how to suspect in a case of Apla syndrome, most of the gynecologists might be giving LMWH in Apla syndrome. So look at the skin site at which you are giving heparin. In generally hit patients, the skin lesions at injection sites happens. It becomes like gangrene type, blackish, Ishar type. So that may be the first sign we are dealing with hit, and acute systemic reaction after bolus administration of heparin. So the last and rarest causes in pregnancy also, we may get a hereditary thrombocytopenia. These are very rare disorders, but always have to be kept in mind. I will not go into the details of this hereditary thrombocytopenia. Thank you. Thank you for patiently listening.
Thank you, sir, for that insightful session. I request the chairperson to felicitate the speaker.
Any questions from the audience?
Hello. Since you have pointed out use of LMW by gynecologists in pregnancies, do you have any specific method? Because in current practice, I have seen without any documented proof or evidence to use heparin, many gynecologists are putting just for a single missed abortion. Many gynecologists are putting the patient on low molecular weight heparin. Do you have any message for gynecologists to whether to use it or not use indiscriminately?
Actually, I don't have any message regarding that particular question, but if you have proven APLA, then definitely it is indicated LMWH prophylactically 0.4 or 0.6 OD depending upon weight with low molecular with aspirin. But if it is not proven APLA, then I think there is no need to give LMWH. It has very, as I earlier discussed, a patient may land up into hit, patient may develop osteopenia or osteoporosis, other side effects also. Then why unnecessarily put a burden on patient's health and expenditure? Yes.
So in that case, what manual counting is needed?
Yeah, manual counting is needed. Machine is not a problem. The certain genetic factors in such patients is the problem. In certain patients, due to genetic predisposition, EDTA exposes the platelet receptors, and the certain patient have antibody against that platelet receptors, and due to that the platelet clumping happens.
So correction of that is
Manual platelet count, or we can do a repeat CBC in heparin or citrate.
Okay. And second question is, if the patient of gestational thrombocytopenia needs to be taken for caesarean section, for some indication which is there from an obstetric point of view. So the platelet count, say if it is less than 20,000, then we need to definitely treat that patient with platelet transfusion.
No, if patient platelet count is coming less than 20,000, it is not gestational. Yeah,
So
we
if
have to
it's
look
ITP,
for other diagnosis.
if it's ITP,
It's never goes below 50,000. He might be having another diagnosis.
regarding platelet transfusion in that patient, if the patient needs to be taken for
Yeah, we have
PSS,
to give. We have to give. We can't wait. Less than 20,000 is an emergency. We have to arrange HDPs, look for other causes, and we have to treat like any other autoimmune disorder or ITP or anything might be she is having. She might be HELP, she might be DIC, she might be TTP, but definitely not gestational.
because many times they have a dilemma that when we do an LACS, the patient's platelet are going to get consumed. So if we are in the gray zone of say 50 to 70,000, sometimes they say that let the
See,
anesthesia.
I have earlier also discussed the gestational or ITP. We label it only after excluding all other causes. So thorough workup is needed. If you are damn sure it is gestational, don't give any platelets. If you are not sure, work up and treat accordingly.
Thank you.
Due to time constraints, we will have to move ahead.
Thank you.
I request the chairpersons to felicitate our speaker.
Just one point to add. As you had correctly asked for correction of platelet count. If it is real emergency, then okay, you have to arrange for platelets. But if you can wait for 2 or 3 days, and if a patient is affording, IV IgG can be a good option for you. With IV IgG, you can usually the platelet count recovers for 72 hours, and you can get a good count, and then you can proceed. Again, the choice of anesthesia, as everybody knows, has to be a GA. Epidural and spinal are contraindicated. And then subsequently, when the patient comes out, you can put the patient on steroids. One more point I would like to add, as Dr. Hilalpur has told, that there is no role of platelet transfusion in TTP. Similarly, there is no role of platelet transfusion in ITP also. In ITP also, please don't give platelet transfusions. And please be bold till the counts are more than 30,000. Your patient is not going to bleed. Okay, I must congratulate Dr. Hilalpur for covering such a big topic in a very good way. Thank you.
I request Dr. Swati Golwalkar and Dr. Basavaraj Kolar to felicitate our chairpersons. I request Dr. Basavaraj Kolar and Dr. Swati Golwalkar to felicitate our chairpersons.
Good morning. Thank you for giving me this opportunity to interact with all of you on this important and a bit difficult topic. I learned certain new things while reading latest literature about pregnancy and kidney, and I would like to share it with you. Topic given was AKI in pregnancy. I changed it to pregnancy and kidney, but majority will concentrate on AKI, important causes, how to recognize, and certain new concepts about preeclampsia which are clinically important for treating physicians as well as MD students. Look, what happens in pregnancy, GFR increases by as high as 50%. If my and your GFR is 100, in pregnancy it goes up to 150. Then what happens? The clearances increase. Clearance of many drugs increase. Clearance of urea, creatinine, uric acid increase. So, if in normal female, upper limit of creatinine is say 1.2, in pregnancy, same limit drops to 0.8. More creatinine is excreted in urine because GFR is high. Proteinuria, in normal females, males, except in children, up to 200 milligram of proteinuria is normal in 24 hours, while in pregnancy, upper limit is 300 milligram, or PC ratio is 0.3. Okay? Similarly, uric acid, in healthy adults, especially males, we consider normal up to 6.5. Over here, normal range is 4.5 because of increased clearances. So, any minor rise in creatinine, say pregnant lady comes with persistently with a creatinine of 1.1, it is abnormal, indicates significant decline in GFR. It should be thoroughly investigated. Yes. Pregnant urinary tract, how does it differ from a non-pregnant urinary tract? Because of hormonal effects, there is a urethral stasis, there is a glycosuria which is normal in pregnancy. This predisposes pregnant lady to develop UTI. So, and these UTI tend to get complicated because of the stasis. So, asymptomatic bacteriuria must be tested in all pregnant females. Make it a routine, just like you test for sugar, blood group, uric acid, blood pressure, test for asymptomatic bacteriuria. Culture needs to be done and it has to be treated with appropriate antibiotics for minimum 7 days, because if untreated, as high as 1/3 will progress to acute pyelonephritis, leading to preterm labor and maternal sepsis. And this is one of the important causes of AKI in pregnancy in second trimester. So this is the one aspect which is often missed. Asymptomatic bacteriuria should be tested in pregnancy and it should be treated. These are standard IDSA guidelines. Another condition where we treat asymptomatic bacteriuria is before any invasive procedure like cystoscopy or your RIRS, PCNL, to avoid the risk of sepsis. Otherwise, we don't treat asymptomatic bacteriuria. Yes. What happens in normal pregnant lady? The angiotensin level RAS system is very much activated. Angiotensin, as name suggests, it tenses, constricts the vessels, leading to hypertension. Angiotensin 2 receptors are present in all blood vessels as well as placenta. But what nature has done, it has made pregnant blood vessels resistant to the hypertensive effect of angiotensin. Even though angiotensin levels are high in normal pregnancy, vessels don't listen. Blood pressure is normal. In fact, it drops a little bit. Placental perfusion is excellent. Baby grows. But this loss of resistance is a hallmark of preeclampsia. Your spiral arteries, SFLT, the cytotrophoblastic wave of invasion, everything is, say, anatomical. But if you look at the physiology and biochemistry, this is the most important change. Loss of resistance to angiotensin 2. So in PIH, even though angiotensin levels are low, the pregnant female's blood vessels are so sensitive that it leads to intense vasospasm and sudden spike in blood pressure. Look at this. Another new concept in preeclampsia, there are autoantibodies which are known as angiotensin 2 receptor autoantibodies. These antibodies, they act like angiotensin. Just they go to the blood vessel where these receptors are present, they act on behalf of angiotensin and constrict the blood vessels. Already sensitivity is more. These autoantibodies add fuel to fire. And it has been found that these angiotensin 2 receptor antibodies are present in up to 50 to 75% cases of preeclampsia. And this may have potential therapeutic target in future. You may use IVIG, you may use plasmapheresis or some other drug to suppress these antibodies. Okay? And these all antibodies lead to vasoconstriction, hypertension, proteinuria, increased risk of IUGR. Look. The blood pressure in pregnancy, hypertension in pregnancy or preeclampsia, it is not only rise in blood pressure. We see so many patients, essential hypertension, secondary hypertension. Our CKD patients roam around with BP of 200 by 110, 120, unaware of the existing hypertension. But they are by and large stable. I don't get press in such patients. But pregnant ladies, there is an exaggerated pressure response. Hypertension is extremely labile. You can't use commonly used drugs that you will use in non-pregnant ladies or in males. So you have very limited drugs to counter this high blood pressure. And in preeclampsia, even a normal stimulus will lead to sudden spike in BP, such as RT insertion. This can lead to sudden spike in blood pressure, leading to press, convulsions, eclampsia, placental abruption, and stroke. So, managing hypertension in pregnancy is really a difficult task. Yes. You can see It leads to end organ damage very fast as compared to essential hypertension. End organ damage reflects in various organs. In liver, presents as a HELP. In kidneys, presents as rise in creatinine, proteinuria. Blurring of vision in eyes. In placenta, presents as a IUGR. So you have to pick up that critical window while monitoring patients who are pregnant, who are at high risk of preeclampsia, when this angiotensin II resistance converts into angiotensin II sensitivity. You have to follow them up very aggressively. Okay? This key pathophysiology is this, and this transition period has to be picked up well while following up the patients in OPD. Right? So the preeclampsia in hypertension requires different approach, focus on systemic effects and early detection so as to avoid further complications. Earliest marker of preeclampsia, even before creatinine rises, proteinuria appears, even before BP is high, is uric acid. Upper limit is 4.5. Rather than concentrating on absolute systolic or diastolic value, look at mean arterial pressure. It has been found in various studies that mean arterial pressure more than 90 is one of the earliest markers of preeclampsia, even before your systolic and diastolic blood pressure rises. Another experimental parameter which indicates early preeclampsia is rising SFLT1 and placental growth factor ratio, but this is not available on day-to-day basis. Yes. If you do biopsy in preeclampsia, what you will find? The lesion is known as glomerular endotheliosis. Glomerular has a lot of capillaries. There is endothelium. In normal lady, endothelium is like this. You can see. It is wide open. RBCs can roam around very easily. These are the podocytes which are very well spaced out. While in preeclampsia, endothelial cells are swollen. You can't see the lumen. There is a lot of resistance to the blood flow. There is a subendothelial deposits, glomerular basement membrane is thickened, the foot process effacement takes place, the fenestrations are lost. So even though you give little bit of fluid in this severe preeclamptic patient, it can't traverse the glomeruli. This leads to a lot of back pressure, pulmonary edema. This is glomerular endotheliosis. This is the main culprit in HELLP. And what is the clinical counterpart of endotheliosis that you see on day-to-day basis? In kidney, there is a breakdown of filtration barrier leading to podocyte injury and proteinuria. Reduced GFR because glomerular capillaries are occluded. GFR is reduced, creatinine rises. If the glomerular capillaries are involved, same capillaries are there in liver, retina, brain. So all organs are involved at the same time. That's why you see preeclampsia is a systemic disease. There is transaminitis, blurring of vision, there is headache, patient will have vomiting, press, convulsions and eclampsia. And typically these lesions, these changes are reversible. As SFLT levels drop after delivery, everything reverses. But in an affected patient, kidney is just tip of endothelial icebergs. All other endothelium is also affected, and you have to look into these things. Do uric acid, do SGOT, SGPT, PTINR, look for fundal changes for early detection. And not only that, if pregnant lady delivers, she recovers, blood pressure is normal. Tell her to monitor herself, go to a physician regularly, because preeclampsia is a long-term cardiovascular risk factor. There is a fourfold more risk of future hypertension, cardiovascular diseases, cardiovascular mortality. So preeclampsia is an early warning sign of future cardiovascular disease. These women need lifelong cardiovascular surveillance. In fact, pregnancy acts as a cardiovascular stress test. It's a nature's stress test. If this patient develop hypertension during pregnancy, these may develop hypertension in future, and there is a more risk of stroke, myocardial infarction. So don't leave them. Tell them you need to be monitored for rest of your life, not 1 or 2 years or only during next pregnancy. Look, now we will come to causes of AKI in pregnancy. First trimester is septic abortion. Second trimester is the least common trimester where sepsis, mainly pyelonephritis predominates. Why we have seen? So treat asymptomatic bacteria of pregnancy, test it. Third trimester, it is most confusing. Each causes, look at preeclampsia and HELP. This is endotheliosis. Obstetric related complications are antepartum hemorrhage, sepsis, and thrombotic microangiopathies. Postpartum is 1/3 each, sepsis, hemorrhages, endotheliosis. And other confounding factor are TMAs, HOS and TTP. Overall, most common cause is endotheliosis, second most obstetric hemorrhage, third is sepsis. This is most confusing. As Sunil Hilalpure sir told us, HELP, HOS, TTP, which are immune mediated, and sepsis DIC, all present with MAHA, microangiopathic hemolytic anemia and thrombocytopenia. It is many times difficult to differentiate. Many times it is very much confusing. Previously, septic abortion was the leading cause, but because of excellent obstetric care, nowadays what we see is endotheliosis and obstetric hemorrhages as emerging causes of AKI in pregnancy. This is the real life case I encountered more than a decade ago, referred to me by one of the obstetricians. Young lady presented with abruption, septic shock, AKI, creatinine 8, oligoanuric. She had very rapid onset anuria with few hours. She was dialyzed, supportive care was given. Even after the end of 4 weeks, she was oligoanuric. She didn't open up. Creatinine was stuck up at 5, which is the most appropriate investigation in this case. Previously, we used to do kidney biopsy. But in a recently delivered lady who had a lot of complications, anemia, hypertension, is high risk biopsy. So what we did was contrast CT KUB. What did contrast CT KUB reveal? These are the 2 kidneys. You can see this is the real life CT of that lady. I will tell you another very classic case from literature. This also tells you the same story, but this tells more beautifully. This case belongs to one of my colleague who now works in Jipmer, Pondicherry. Look, we have given contrast, did CT in a pregnant lady who didn't open up. You can see kidneys. At periphery, there is a white trim. In center, there is a white material which is a contrast, while middle, the black area is sandwiched. The central white area is a medulla, which has accumulated contrast, which is not excreted because of kidney failure. The peripheral cortex is supplied by renal capsule, so it is enhanced, while whole cortex, the black, has undergone necrosis. This is bilateral diffuse acute cortical necrosis. Western setting, this is not seen. It is a rarity. If you see literature, everything comes from India and other Asian countries. There are only 2 causes of diffuse bilateral acute cortical necrosis. One is pregnancy-related complications like placental abruption, severe sepsis. Second cause is vasculotoxic snake bite. So Western population, Western doctors don't see this. And what is the clinical implication of this is, this leads to end-stage kidney disease. This doesn't happen in any other situation, such as dehydration, sepsis. It leads to only acute tubular necrosis. If you look at the kidney, this is the cortex. All glomeruli, proximal distal tubules are in cortex. It is metabolically demanding area. And in pregnancy, it is a prothrombotic state. There is a severe DIC in pregnancy-related sepsis. There is endothelial injury in preeclampsia we have seen, everything leads to extensive microvascular thrombosis. This is not seen in dehydration. This is not seen in common garden sepsis. This is seen in pregnancy. This is seen in vasculotoxic snake bite. Whole cortex is necrosed. No glomeruli are left. No tubules are left. This is end stage kidney disease. You can see, if pregnancy and AKI progresses to this thing, lady is left with only two options: to be dialyzed for rest of life or get herself transplanted, which are very costly affairs. So pregnancy in AKI in pregnancy needs to be addressed very carefully. We see such kind of complication at least once in a year. Absolute anuria is one of the indicator of diffuse bilateral ACN. You don't say absolute anuria in nephrology. It is seen in very few conditions. Otherwise, patient will always pass some amount of urine, 100, 200, 300 ml. Absolute anuria in pregnancy, apart from obstructive uropathy, is ACN. Yes, we have seen this. There is a confusion between differentiating between HELP, TTP, HUS and sepsis. Just I will have few slides and end. I will skip these slides. You can see it is very difficult to differentiate. These are subtle pointers. In HELP, OTPT are more elevated as compared to HUS TTP. HUS TTP, OTPT are elevated, not markedly. LDH elevation is there in HELP, but in HUS TTP it is very significant, more than 1000. Less OTPT, more LDH elevation, TTP. More OTPT, less LDH elevation, HELP. Look at the ratio. LDH to AST ratio or SGOT ratio, less than 22 is HELP, more than 22 is HUS TTP. In HELP, AKI is present. In HUS, as name suggests, uremic syndrome, AKI is very significant. TTP, very little AKI. Sepsis DIC is variable. You can't differentiate much. Coagulation profile. In HELP, usually PTINR is normal or slightly elevated. APTT is normal. Fibrinogen levels are normal. While in sepsis DIC, it is a consumptive coagulopathy. PTINR are markedly prolonged, APTT is prolonged, fibrinogen levels are very low. This is the most important factor which differentiates between sepsis DIC and pure HUS TTP. We will skip this. Response to delivery, HELP will be cured, HUS TTP will not be cured. So persistent or worsening thrombocytopenia with kidney dysfunction in spite of delivery is HUS. Yes, last one slide. Young lady who presents with new onset hypertension during pregnancy, early in pregnancy, in first trimester, albuminuria is 3+, urine is full of RBCs, proteinuria is there. Creatinine is slightly elevated. Look, this is not PIH, is less than 10 week, urine is full of RBCs. This used to be one of the favorite entrance question for DM nephrology. One of the feature that excludes preeclampsia, 4 options are given. Answer is urine which is full of RBCs excludes preeclampsia. In preeclampsia, you don't see significant microscopic hematuria. So I request you to do not only urine albumin, but proper microscopic examination in all your pregnant ladies to look for urine under high power field. This is lupus. It needs to be treated with immunosuppression. The clues were hypertension onset in first trimester, urine which is full of RBCs. It is lupus. And last slide, red flags during pregnancy or take-home messages, serum uric acid more than 4.5 is canary in a coal mine. Always smell the future danger. Minimal rise in creatinine in pregnancy signifies significant renal compromise. Early onset hypertension, extrarenal features of SLE such as joint pain, arthralgia and prior unexpected fetal loss points towards something other than preeclampsia, mainly lupus. Significant microscopic hematuria rules out preeclampsia. We have seen diffuse acute cortical necrosis as an outcome of AKI in pregnancy. So treat AKI aggressively. So early referral is not only life but kidney saving. It is a teamwork to be done by gynecologist, hematologist, nephrologist and physicians. Thank you.
Very well covered difficult topic of kidney injury in pregnancy. Pregnancy itself in this part of the world is an most challenging treatment of this complicated kidney injury is thrombocytopenia. Good job, Kiran Joshi. It's always nice to hear Kiran in such a detailed topic covered in a short time, very nicely, lucidly. And to the non-nephrology group of doctors who are here. So I think it's very well covered. Well done. Any questions?
Dr. Kiran, as usual, a very lucid talk, but I have just two questions to ask you.
Yes, sir.
One is regarding continuous follow-up of patients who suffer from preeclampsia or eclampsia. Okay. Till date, we only know that the echocardiography changes reverse. It takes at least 6 months for these patients. So these patients who have suffered from severe preeclampsia or eclampsia, their echo should be done at the end of 6 months to make sure that she is suitable to undergo next pregnancy. Now, as you said, this preeclampsia patient needs a lifelong follow-up. When do you think that they would be fit to undergo next pregnancy?
Sir, maybe at least 1 year. If her blood pressure is normal, there is no persistent renal dysfunction, there is no proteinuria, around 1 year duration is sufficient. If she is otherwise physically fit, she can undergo.
Those who are labeled as preeclampsia, they usually become normotensive by the end of 6 weeks. By the end of
yes.
So when do you think they should be fit for next pregnancy?
I think at least 1 year.
Okay. That's one question. Second question is regarding the best antihypertensive drug for these preeclampsia patients. When we were students, alpha-methyl dopa was the drug of choice, which is no more available. Okay. Then came nifedipine, and then came labetalol.
Yes.
Okay. But then one of the cardiologists commented in one of the conferences that labetalol is a hype. Okay. So he prefers to use nifedipine over labetalol. Your take on this?
First choice is nifedipine. But if BP is not controlled on nifedipine, you are left with very few choices. One of them is labetalol, and nowadays we are using hydralazine also. It is available in tablet form. You don't have much choice now.
Yeah, so just the message that I want from you, the first drug of choice should be nifedipine.
Nifedipine.
Thank you so much.
And as far as possible, try to avoid sublingual nifedipine. It causes precipitous fall in blood pressure. And as we have seen, BP drastically coming down in a seconds from 200 to 110 is not good for any organ in body, especially placenta. This is one of the causes of stroke and placental abruption. So don't use sublingual nifedipine. We never use it. Use orally or start with labetalol drip, because we have very less options, sir. Only 3 drugs.
Thank you so much.
Even diuretics are relatively contraindicated. As far as possible, don't use them.
Kiran, the labetalol dose, we underuse it. It should be 1 gram. We use 100 to 200 milligrams.
Yes, that is true.
It should be 1 to 2 gram per day.
As physician also, we don't have much experience with labetalol, very frankly.
When we use heavy doses, and why we prefer labetalol, it can continuously control nifedipine, suddenly hypotension occurs, tachycardia occur, and the cardiac status is compromised.
Correct.
So we prefer labetalol in high doses.
Yes, that is a good information.
We should be the drug of choice, antihypertensive drug in lactational period.
Sir,
And if the patient continues to be hypertensive even after 6 weeks, or up to 6 weeks, she is lactating,
Yes.
at that time, which should be the drug apart from nifedipine?
Sir, we can use every drug, maybe except AC inhibitors and ARBs. Ramipril, telmisartan, they may cause renal failure in newborn sometimes. All drugs are fine, right?
One of the, Kiran, one of the things which, since it's a nephro-obs topic, I think Malu is here as well. We used to, for patients who are hypertensive or even planning second pregnancies, especially who have suffered from preeclampsia, our teachers used to ask to monitor the flow through the placental circulation right from the first, second and third trimester. People who had interrupted or notching in the placental blood flow were the ones who landed up with renal dysfunction and AKI in future pregnancies. And regarding also one of your important questions, there is a significant 20 years data about patients with preeclampsia. About 1/3 of these patients land up with CKD in future, which Kiran has rightly pointed out about the cardiovascular disease. But 1/3 of patients who had preeclampsia landing up with CKD in future is a reality. And about labetalol, which Dr. Rudrakshi sir mentioned, is an excellent drug precisely for the matter that it acts for 4 to 6 hours. Duration action is 4 to 6 hours, and it gives you multiple, like 100 to 300 milligram per dose. So for controlling blood pressure in a short point of time, it's an excellent drug, if you look at from that point of view, rather than a long term. Okay. Madam.
Recently, the FOXI is recommending the use of injectable nicardipine in cases of severe hypertension where we want immediate control by using injectables. We are using labetalol right now. What is your experience, and have we used this molecule before?
No, I don't have any experience. Injectable nifedipine, right? Nicardipine. No. We don't have any experience.
So at that time we can take all the rapid fire questions for the panelists. Thank you.
Thank you. Thank you.
Thank you, sir, for simplifying a complex and high-risk condition. I request the chairpersons to felicitate our speaker. I request Dr. Deepa More and Dr. Sandeep Holkar to felicitate our chairpersons. I request Dr. Deepa More and Dr. Sandeep Holkar to felicitate our chairpersons.
If anyone has any questions, they can write them down on a chit and we will take up the questions during panel discussion. With rapid technological advancements, robotic surgery is redefining precision, safety, and recovery in modern surgical practice. Understanding its scope is essential as we move towards minimally invasive excellence. I invite Dr. Rohit Deshpande to enlighten us on this evolving field. I request the chairpersons, Dr. Mahendra Joshi, Dr. G.R. Sharma, Dr. Aboli Velankar, and Dr. Sandesh Kare to grace the dais. Dr. Rohit Deshpande is a fellowship-trained robotic surgeon and uro-oncologist. He completed his MBBS from Seth Chase Medical College and KM Hospital, Mumbai, MS in General Surgery from LTMMC, Sion, and MCH in Urology from PGIMR, Chandigarh. He has also completed a Urological Surgery of India accredited fellowship in robotic surgery and uro-oncology with over 4,000 minutes of robotic console experience and multiple national and international presentations and publications.
Thank you, respected physicians and gynecology colleagues for keeping this talk on robotic surgery. So the evolution of minimally invasive surgery has always been from open surgery to initially laparoscopy and now robotic surgery. So the goal has always been that of lesser morbidity, faster recovery, and also better precision as we evolve towards more minimally invasive techniques. So robotics is not a replacement for any surgical skill, and it is basically an advanced tool. So definitely training is required for robotic surgery. And this is a short video depicting the robotic procedures, basically the template procedures for robotic surgery. The robot basically is attached to ports which are initially placed via the laparoscopic technique. And the robot is basically controlled by the surgeon who is sitting at the console. So the movements of the surgeon are translated into the movements of the robotic arms. So basically in deep pelvic surgeries or in surgeries where it is difficult to reach laparoscopically, the robot is especially useful so that the arms can have 7 degrees of freedom and we can move the arms according to our wrists. So this animation is depicting basically a radical prostatectomy wherein we are sparing the nerves and the neurovascular bundles, and the specimen is then taken, it is put in a plastic bag and then it is taken out from the body via a 3 to 4 centimeter incision. Comparing robotic versus laparoscopic surgery, as far as the visualization is concerned, it is a 3D high definition and magnified vision. There is a 10x magnified vision which you get with robotic surgery compared to laparoscopic surgery. As far as the instrument dexterity is concerned, the instruments in robotic surgery are wristed instruments. That is, they function according to the human wrist. So there are 7 degrees of freedom in robotic surgery compared to laparoscopic surgery, in which there are 3 to 4 degrees of freedom. As far as the precision is concerned, there is tremor filtration and also motion scaling. So haphazard movements of our hand, if there are any, they are filtered by the robot, and there are smoother movements along with the robotic arms. As far as the surgeon ergonomics are concerned, in laparoscopic surgery, the surgeon stands at the bedside, and ergonomically it is much difficult as compared to robotic surgery, wherein the surgeon sits at the console and he can adjust the console according to his ergonomics and then operate. The control of the camera in laparoscopic surgery is entirely dependent on the assistant as well, and in robotic surgery, the surgeon controls the camera. Basically, in complex reconstructive procedures, in laparoscopic surgery, it is a technically demanding task, but in robotic surgery, it is much easier to suture and also to reconstruct genitourinary organs, especially, or any other organ in robotic surgery. This is a short video which basically depicts the use of robotic surgery in my field, that is uro-oncology. This is a robotic radical prostatectomy. Initially, we are proceeding with the posterior dissection, then the pelvic lymph node dissection. This is the obturator nerve, these are the iliac vessels. Then we are proceeding to the bladder drop. This is the median umbilical ligament which we are taking down. This is the bladder, this is the prostate, and we are initially cutting the anterior wall of the bladder. Then we are delivering out the median lobe of the bladder. This is the median lobe. So we are then proceeding to dissecting out the posterior wall of the bladder. So the seminal vesicles and vas are delivered out. We are separating the prostate from the rectum. This is the posterior dissection which is then continued. We are separating the neurovascular bundles. Then we are taking down the dorsal venous complex which is situated just anterior to the prostate. These tasks are all quite difficult in open surgery, like suturing of the DVC and the vesicourethral anastomosis. This is the urethra, this is the bladder. We are separating, this is the prostate, sorry. We are separating the prostatic apex and taking out the prostate. After bagging the specimen, then we will proceed to the vesicourethral anastomosis. This is the Rocco stitch which we typically take before the vesicourethral anastomosis, just for the support of the anastomosis, and then the actual anastomosis which is depicted here. We are using a barbed suture here, which is a V-lock 20 suture. Then the anastomosis is complete. So the next surgery is a robotic partial nephrectomy for a small renal mass. Initially we do 3D modeling of the renal mass, and then we also use an intraoperative ultrasound. And then according to the margins which we identify on the ultrasound, we proceed for tumor cutting after clamping the vessels. So this is the margin of the tumor, and we are basically preserving the rest of the renal parenchyma. This is a type of enuclear resection which we are doing for a renal tumor. So the tumor is basically resected out, preserving the renal parenchyma. Then we will proceed for the renography. Also the pelvic ileal system which may have opened during the surgery, we close it using Vicryl or PDS. Then we remove the clamps, and then after achieving hemostasis, the surgery is done. So this is a robotic cystectomy with intracorporeal ileal conduit. Especially in a female patient, the entire specimen gets delivered out from the perineum. So there is no abdominal scar of the cystectomy. The vertical midline scar which is typically associated, there is no abdominal scar. And this is the part of the ileal conduit creation. It is done entirely intracorporeally. So this is the intestinal anastomosis, side to side anastomosis using intracorporeal staplers. After that, we'll be doing the ureterointestinal anastomosis. These are the small holes done in the intestine, and this is the spatulation of the ureter. So we'll be joining the ureter to the intestine. This is the ureterointestinal anastomosis, basically. And after the anastomosis is, of course, done over a stent. The anastomosis is done using a Stratafix or a monocrel suture. These are the iliac vessels nearby. This is the insertion of the stent through the ureter initially, and then into the segment of the ileum. The redundant part of the ureter is excised. The anastomosis is then completed. This is basically a video of a robotic pylolithotomy wherein the indications have been extended to even the benign indications like large staghorn stones or large stones in the renal pelvis. So basically robotic surgery has a multidisciplinary use, not only in general urology or uro-oncology. It is now well known that robotic surgery is also used in gynecology, gyne-oncology, surgical oncology, as well as cardiothoracic surgery and surgical gastroenterology. Also there are some limited indications in ENT, that is otorhinolaryngology. So there are multiple surgeries which can be done robotically, as in general surgery, the inguinal hernias, ventral hernias, fundoplications. A lot of bariatric surgery is being done along with the use of robotic assistance. There are dedicated centers now which are doing exclusively robotic bariatric surgery. Splenectomies, cholecystectomies and rectopexies are also being done. In surgical oncology, basically all the intestinal resections and anastomosis can be done robotically, as well as total mesorectal excisions and abdominoperineal resections are also done robotically nowadays. Also in hepatobiliary and pancreatic cases, robotic assistance is extensively used nowadays. In urology and uro-oncology, all the benign as well as malignant surgeries intra-abdominally can be done via robotic assistance. And also in gynecology and gyne-oncology, all the hysterectomies as well as surgeries for pelvic prolapse and tubal reanastomosis can be done via robotic assistance. In CTVS, ENT and pediatric surgery also, robotic surgery is being widely used. For example, in CTVS surgeries for CABG, thymectomy, mediastinal mass excisions or pulmonary wedge resections or any intrathoracic surgery can be done robotically nowadays. And also in pediatric surgery, dedicated robotic instruments are now available for doing pediatric robotic surgeries through 5 ports. So we are even going towards more miniaturization as far as pediatric robotic surgery is concerned. So as far as the learning curve and training pathway is concerned for robotic surgery, there is a shorter suturing learning curve as compared to advanced laparoscopic suturing techniques. And of course, there are various modalities of training. One is the simulation-based training, which is available at various intuitive centers in the country. There are 2 or 3 intuitive centers in the country which provide simulation-based training. Other is a more formal or a fellowship-based and proctorship-based training. They are available in multiple 1-year courses throughout the country. These are at dedicated robotic centers with a high volume of robotic surgeries. And basically team training is essential. So it is not only the console surgeon which is taking part in the surgery, but also the bedside assistant who is playing a vital role in the surgery also. So as far as fellowship training is concerned, at a dedicated high volume center, it is not only about performing the surgery on the console, but also it involves a lot of assistance. So basically console time, a fair amount of console time is considered to be one of more than 3,000 minutes. And along with the fellowship training, we also have to publish many articles and presentations at conferences. So basically after completing the fellowship, we get a certificate of a training equivalency as a console surgeon, which then can grant us rights to train other surgeons. Basically fellow surgeons who are interested in robotic surgery can be trained. So in the Indian scenario, as far as the growth and access to robotic surgery is concerned, and the future trends for robotic surgery are concerned, there have been a rapid increase in robotic installations over the last decade. There are now multiple platforms which are now available. So the initial platform which was available was the Da Vinci platform, and it had a monopoly for a fair amount of time in the even worldwide. But as soon as the patent expired, then multiple platforms have been available, but none have actually quite lived up to the mark of Da Vinci. So it is still considered as the benchmark. There has been growing adoption of robotic systems by multidisciplinary hospitals. So since it is always a multidisciplinary and collaborative team effort, so multidisciplinary hospitals or multi-speciality hospitals are increasingly adopting robotic systems. Also, there has been an increasing patient awareness in multiple tier 2 cities also. As far as the cost considerations are concerned, there is a definitely higher capital investment. There is a per case cost increase compared to laparoscopic cases, but some people argue that it may be offset by the reduced hospital stay which the patient needs in robotic surgery. Thank you.
Excellent talk, Rohit.
Thank you, sir.
Any questions from the audience before I make our comments? Yeah, Manik.
Yes. Yes.
So, whether any company is available, instead of purchasing, whether they can rent. And you said Da Vinci. There are some other companies like Mantra, etc. I already talked with you.
Yes, yes.
Guide on.
Sir, basically Da Vinci robot is definitely available on a rental basis. But also it depends, but when we take the robot on a rental basis, we are required to commit them that we will surely perform so many number of cases in a limited time period. So that commitment has to be from our side. And also there have been multiple robotic platforms which have been launched recently. But as far as I can name a few. There is SSI Mantra, there is Medbot 2My. But SSI Mantra, some people have even sold it off already. Even after purchasing SSI Mantra, they are not happy with the machine because continuously there have been hiccups in the operation and everything else. So Medbot 2My is a machine which is reasonably well and better than SSI Mantra. It is considered to be 90% that of Da Vinci. So if there are reasonable cost constraints, then Medbot 2My is a good option. Is the second best option, I would say. Also in Da Vinci, there are multiple models, right from SI to, then SI was launched initially in 2009, then came XI, which was launched in 2014. Then there was a hybrid version between SI and XI, which was launched in 2017. That was the Da Vinci X. And this is the latest in, the XI is the latest in the Da Vinci. Yes.
Yeah. Rohit, you have summed up everything beautifully.
Yes.
And what was very good was you showed two surgeries which according to me are the best when it comes to use of robo in surgery. That is radical prostatectomy, because most of your slides showing the incisions as well as everything were related to radical prostate, and partial nephrectomy.
Yes.
Technically, a person also has to stand near the patient, though the main surgeon will be away from the sitting at the console.
Yes.
Because a good assistant is still a must in robotic surgery. You
definitely.
cannot do without that.
100%.
And Rohit, have you realized that this has been one of the most extraordinary days in your life?
Yes.
Where your parents, in-laws and wife all are sitting and not asking you any question and interrupting you.
Yes. Yes, sir. Yes.
You are very fortunate.
Yes, sir.
Yeah, Raghavendra. Yeah.
So basically, as far as the instrument cost is concerned, there are 3 or 4 arms of a robot. So depending on whether we use 3 arms of a robot, the actual cost boils down to the usage of the instruments, that is 60,000 rupees. And if we use 4 arms, it is 90,000 rupees. But considering the AMC or CMC and other maintenance cost, the cost rises, but it's still in a city, in tier 2 or tier 3 cities, it can still be facilitated by further reducing the cost. So somewhere it should be around 1 to 1.5 lakh rupees.
Raghavendra, I will add to on his behalf. It definitely comes to around 1.5 lakhs. Now, most of the times robotic surgery is mentioned that the higher cost of the instruments, and also Da Vinci had a locking time code. This is offset by early discharge. Now, this is not so relevant in Indian scenario. And other than the 2 classical surgeries, I can talk only about urology, that is radical prostatectomy and partial nephrectomy. Most of the other cases, the hospital stay doesn't vary much as compared to even laparoscopic surgery, robotic or open. But see, it's a new frontier. Few years back, when I was doing my MCH and Hulmium laser had come, people said laser in urology, it will not survive. Now you ask any newcomer who has started his practice in urology, he will say that without laser you cannot do surgery. So it's a new technique. As clinicians, we should be aware that when you have a new hammer, everything cannot become a nail. But at the same time, we have that clinical intelligence to understand where to use it and when not to use it.
I would like to add is that this robotics is not the future, it is the present.
It is the present, yes.
Okay, it's already here. And the Da Vinci company, which was quoting robo for 18 crores, has come down to 13 and 10. Okay, and the other robos which were available are now for 5. And you have, like for multi-speciality hospitals, you can take it on installments. So definitely we have ways to reduce the cost. The competition itself, like mobile phones, is going to reduce the cost. The recurring cost is also coming down like crazy. So it is already here, and I'll just give you an example of one hospital where I work in Abu Dhabi. The owners were not convinced initially because of the cost. Then all the departments, we all met that we will use one day. And initially we thought that, okay, the robo will lie idle. But now, past 1 year, we all were fighting against each other to get the slot for surgeries. So the hospital is buying 5 robos. So you can imagine what is going to happen in the future. All hospitals, this is the typical story of Dopplers, laparoscopy, everything is here to stay. Robo is also here to stay.
I think with everybody's efforts, Solapur will soon get converted into the next Abu Dhabi. Economically.
What I'm saying is, see, why I am saying this, because I was involved in training for laparoscopy. We used to get 100 students who come to laparoscopy, only 10 could perform good laparoscopy. That is because the laparoscopy is opposite of your actions. Like you have to do opposite action to get something. If you want to push something, the instrument, the fulcrum is at the abdomen. So you have to do opposite way. So many people did not learn. While robotics, it is at the wrist. So it is open surgery laparoscopically. The instrument you want to push, you will push. So if 100 students will come to learn robotics, 80 will do the robotics. So that's why robotic will be accepted by everybody. So don't compare it with laparoscopy. Oh, we could not learn it, we could not do it. It's not like that. It is open surgery laparoscopically.
Thank you, sir, for that futuristic perspective.
Thank you.
It highlighted how innovation is shaping the next era of surgery. I request the chairpersons to felicitate our speaker. I request Dr. Girish Kumtikar and Dr. Ranjit Kadam to felicitate our chairpersons. I request Dr. Girish Kumtikar and Dr. Ranjit Kadam to felicitate the chairpersons. I request Dr. Girish Kumtikar and Dr. Ranjit Kadam to felicitate the chairpersons.
I request Dr. Ranjit Kadam and Dr. Girish Kumtekar to felicitate our chairpersons. Hepatic disorders in pregnancy, though less common, carry high maternal and fetal risk and often present diagnostic dilemmas. Timely differentiation between various conditions is key to appropriate management. I invite Dr. Akshay Chalani to share his expertise. I request the chairpersons, Dr. P.R. Joshi, Dr. Suhas Karkamkar, Dr. Madhuri Dabde, Dr. Satish Pawar to kindly come on stage. Dr. Akshay Chalani is a distinguished intensivist with qualifications including DNB in General Medicine, FNB in Critical Care Medicine, FCPS, FICCM, and MNAMS. He serves as a medical advisor and lead in critical care at Apollo Hospital, Navi Mumbai, and has led leadership roles in Indian Society of Critical Care Medicine.
Yeah, thank you for the kind introduction, and first of all I thank you Dr. Vinay, Dr. Gundele, Association of Physicians of Solapur and Solapur Obstetric and Gynecology Society for inviting me to give this talk on the hepatic disorder in the pregnancy. So as I rightly said, the previous first and two speaker, they have already mentioned few slides which might overlap actually, but I'll dwell upon some few topics when really there is an issue, when most of the things are very clear cut, HELP or acute fatty liver of pregnancy, life is quite easy. But when there is a confusion, when there is overlap, what obstetric or what medical, what gynec decision you just need to take, I'll talk about that. So why it's important, basically jaundice in pregnancy varies globally, but more common in developing countries. Most of the countries So already developed, the occurrence is less. So whatever the literature we have, it's not too much from Indian setup, but whatever we have, I'll just try to put it across. It's an important indirect cause of maternal mortality. In addition to the maternal issues, when you develop additional factors or additional comorbidities, additional infection or other things that can contribute for the death. Mortality in India is around 1 in 1,000 pregnancies actually. So what I'm going to cover basically these 2-3 topics: pregnancy-induced liver disease, hyperemesis gravidum, obstetric cholestasis, acute fatty liver of pregnancy, preeclampsia and HELLP syndrome. Already we talked about that. We are very clear, once you see this, you terminate the pregnancy, patient should be fine. Sometimes there is a coincidental disease like viral hepatitis, drug-induced jaundice and tropical fever. I'll dwell upon this tropical fever 2-3 slides in detail actually, because sometimes we are not very clear. Patient comes after 34 weeks, 35 weeks, liver enzymes are haywire, there is no history of fever, but still you don't know whether you need to terminate or whether there is some scrub typhus, dengue or other infection, you just need to wait for termination. And pregnancy superimposed on chronic liver disease. Either already the patient has a chronic liver disease and cirrhosis, and on the top of that she become pregnant, then there is a problem. But fortunately, what I feel, God is not cruel enough. Pregnancy-induced liver disease resolves spontaneously following the delivery, which is not case in other conditions actually. I'll just give this example. I'll start this 20-year-old lady, primate, twin pregnancy, irregular ANC. BP was normal. Whatever history we have, the BP was absolutely normal. No hematological diseases. She had a jaundice, yellowish sclera, and delivered outside around 2 to 3 weeks back. And now referred because she was not good. She is sick. She is tachypneic, hypotensive, and she has obvious icteric. On arrival, BP was around 80/60 and heart rate was 122. So this is postpartum lady actually. These were the scenarios when she came to your hospital actually. On day that is almost around after 2 weeks, bilirubin was 12, direct bilirubin was 7.8, indirect 4.4. Enzymes initially was quite high, but now it's settling down. And the counts were 35,000. Obviously she received medication, other things, secondary sepsis and all that. This was a liver picture and this was a hematological picture actually. Hemoglobin on day 1 when she came to 11.1 and subsequently gone down to 7.8. Counts were a little high but settled down in second week. Uric acid was initially high but again it's normal. And platelet count in between dropped, after treatment it came up. So this is a classical picture you see in any obstetric ward or obstetric ICU. That point of time then, how do you approach? I'll just talk about those conditions. First of all is viral hepatitis. 2-3 things I wanted to tell about the viral hepatitis. B and C will not create too much of problem for a pregnant lady, but somehow hepatitis E will create a problem. And hepatitis C has an enteric transmission to mother and it has a vertical transmission also. During the delivery, there is a fecal route. So you need to be more careful when you treat viral hepatitis, particularly in the context of the pregnancy. By and large, you don't have to offer too much of things, but if there is a viral hepatitis A, you can give a immunoglobulin. For B and C, vaccination is there. For C, you don't have to do too much. But viral hepatitis, once we know the status, once we diagnose, the only treatment is supportive. So don't fiddle too much, just give a supportive treatment. And by and large, patient should recover actually. Another thing I wanted to tell you, now A, B, C, D, everybody knows, but sometimes patient comes with deranged liver enzymes, high bilirubin. Suppose you see typical cutaneous lesion or suppose you see a rash on the patient, little unlikely because of viral hepatitis, you need to rule herpes simplex hepatitis because mortality is pretty high. Suppose you diagnose herpes hepatitis, the mortality is pretty high. In the pregnancy, it's almost around more than 40%. You need to start the acyclovir as early as possible. Life can be saved. And this group of patients, to confirm that, you can do HSV PCR or you can do the CTA abdomen. Generally, pregnancy, there is little problem. But if you can pick up microabscess on the liver, on the sonography or on the CT, the patient can be saved. But please remember, there is quite high mortality with herpes hepatitis. Now things are pretty clear when you deal with the preeclampsia and eclampsia. When the BP was 140/80, diastolic more than 90, you see a proteinuria. And if there are seizure, there is eclampsia. Liver involvement is uncommon because SGOT, SGPT only rise around 10 to 20 times and bilirubin is less than 5. The problem comes when there is a HELLP syndrome. It's already, it is a complication of preeclampsia. It's not a separate syndrome, but variety of severe disease can occur as an antepartum or postpartum. and there is sudden deterioration of maternal and the fetal condition, there is a high risk of recurrence. Once you recover from the HELP, you terminate the pregnancy. As I rightly said in the previous talks, you need to be more careful when you plan the next pregnancy. And as a triad C in the HELP, basically there is a hemolysis, elevated liver enzymes, and low platelet count. Clinical features, rightly said, there is a pain in the abdomen, right upper quadrant plane. There is bleeding gums because of low platelets. Microangiopathic hemolysis, you do ask for the bilirubin, and the indirect bilirubin is a little high, elevated liver enzymes, and the low platelet count. This is classical classification when we wish to diagnose the HELP syndrome, this Tennessee classification and this Mississippi classifications. Now the problem comes when there is viral differential diagnosis. When the things are very clear, black and white, you know this is a HELP, this is acute fatty liver of pregnancy, you terminate the pregnancy. But there are certain conditions when things mimic like the acute fatty liver of pregnancy, things mimic like the HELP. What are these? These viral hepatitis, acute fatty liver of pregnancy, colitis of pregnancy, TTP, and secondary dengue shock syndrome. Now this is an important slide. As previously said, sometimes the things are not very clear. There may be overlap of preeclampsia with HUS. Note that TTP and HUS are not a part of preeclampsia, but they can occur at the same time. HELP can occur with the TTP, HELP can occur with the HUS. Same thing, sometimes the AFLP can overlap with the HUS. So that point of time, you just need to use your clinical judgment and plan accordingly. Now ultimately for HELP, it is medical, it is an obstetric emergency. You need to plan the things. You give an antihypertensive, rightly discussed, either beta blocker, or either labetalol or magnesium sulfate. This is a multidisciplinary team, supportive treatment, like whenever indicated, you give fresh PRBCs, platelet transfusion, and FFP to correct the coagulation issues. If the things are favorable more than 34 weeks, you can do the induction, otherwise you just need to wait. This is a critical issue. Now suppose the patient not following with you preterm, patient comes to you after 34 weeks, patient had a fever, you do all routine investigation. Day 1, day 2, by and large, suppose you are able to do the PCR technique, you can detect the dengue. But please remember, dengue shock syndrome and HELP, they will mimic. The treatment for both the things is little different. For dengue, you just need to wait. For HELP, you need to do the induction. Now the issue is that how do you differentiate? Because both the conditions in the dengue shock syndrome, liver enzymes will be little high, bilirubin, maybe there will be cholestasis, there may be low platelet. That point of time, you need to differentiate. If patient, you know the history, you know that there is a fever and all that, that's fine. But sometimes it's possible the history is not very clear. You will not able to pick up whether there is a proper significant history. There is obvious history, that's fine. But that point of time, few things might help you. In the dengue fever, suppose you are able to pick up NS1 antigen, or you are pick up the IgM, IgG antibody. That point of time, it goes in the favor of dengue fever or dengue shock syndrome. Please remember, primary dengue will not create a problem. Secondary dengue shock syndrome will mimic like a HELP, and the treatment is totally different. Suppose dengue, you do the induction, by default on day 4, day 5, the platelet count will drop, patient might go into the HLH, acute fulminant hepatic failure, and then land up in the problem. And in the HELP, if you don't terminate, again there is a problem. So please remember, there are few things which will help. In HELP, by and large, there won't be a fever. In the dengue, there may be a fever. Hypertension may be there in the HELP. There will be hypertension in the HELP. In the dengue, by and large, unless and until patient gives the history that or patient is underlying primary hypertension, she will not have hypertensive. Sometimes it's possible the patient with the HELP comes to you in the 2nd week or 3rd week after the complication develops. So that point of time, you are not very clear because that hypotension or there is a normotension, it is because of septic, secondary sepsis or any other things. That point of time, the lab will help you. In dengue, by and large, there will be hemoconcentration, but a HELP, the hemoglobin will go down. In dengue shock syndrome, the hemoglobin will go high. There is a hemoconcentration on day 5, day 6. So that will help you differentiate whether this is not a dengue or HELP syndrome. And ultimately, when the treatment part comes for dengue, there is no option but wait and watch. Unless and until you are pushed to the wall, there is an obstetric indication to terminate the pregnancy. HELP, you need to terminate actually. So whenever you plan for the surgery, when the platelet count is less than 20,000, you need to give a platelet. More than 75, you can comfortably do the cesarean sections. Postpartum period, 2-3 things. Now the patient is recovering, but in spite of that, the last slide I wanted to, in spite of delivering after 72 hours, suppose the lab value don't improve. What you need to do, whether there is underlying TTP or HUS or there is underlying some any autoimmune hepatitis, that you need to rule it out. Patient does well at day 4, day 5, doing okay, you have ruled out the secondary sepsis, all the source is controlled, but still the platelet count is very low. Patient looks relatively stable, neither too bad, neither too stable, not able to shift out of the ICU, platelet count remains low, you have ruled out antibiotic induced, you have ruled out ITP. That point of time, just explore the option or just explore this thought whether in addition to that, because as already there is overlap syndrome, whether the TTP and HUS is worth to rule it out. Review after 12 weeks is recommended in the HELP syndrome. Higher risk to develop hypertension and preeclampsia in the future pregnancy. Please remember this, hypertension in the pregnancy is a marker for later coronary artery disease. So whenever you plan a future pregnancy, worth to rule it out whether there is underlying coronary artery disease. After that HELP, once you do a surgery or once you do a troubleshooting, please look out it because it has a complication, it has a potential to cause liver infarction, hepatic subcutaneous hematoma and hepatic rupture actually. Another point, once we deal with the HELP, there is an intrahepatic cholestasis of pregnancy. It is also called as obstetric cholestasis and ictus gravidarum. Most common liver disease in the pregnancy and present in the second half and subsequent pregnancies. Once in first time you develop intrahepatic cholestasis of pregnancy, it's likely that second or third time you also might develop that. Etiology, basically there is a high bile acid production in the system. Generally, the patient will present with continuous pruritus and you have ruled out other secondary infection, skin issues, dermatological issues, scabies and all that. You ruled it out because this is a diagnosis of exclusion. You can't, there is no test to prove or disprove prove this. You rule out other things which has a potential to cause a pruritus. And if the bile acid is more than 40, by default this is a cholestasis jaundice in the pregnancy. Mainly one of the exclusion and confirmed by resolution of the symptoms and biochemical lab notice, one the postmortem. Once the delivery is done, the symptoms will disappear. You found, when you asked for the investigations, you found that there is a high SGOT, SGPT, bilirubin is high, but not more than 5 actually. The bile acid is more than 40 micromole per liter. This is the hallmark of this cholestasis of pregnancy. And whatever you do, most of the time, this is not indication, but most of the time, it's very difficult to treat these patients because ultimately whatever you do, they don't recover. Once the termination is done, once the pregnancy is delivered, these symptoms will settle down. Antepartum, some people suggest you can use this uracolic acid 300 milligram BD, but this will only improve your symptoms, not the actual pathophysiology. Termination of the pregnancy 37 to 38 weeks, possibility of stillbirth from 37 weeks. The only way whether we can anticipate or whether we can judge whether these patients will going to land up in the problem, suppose at any point of time for any indication they took estrogen pills or OC pills, they have recurrent pruritus or intense pruritus, this group has a potential to land up in these problems. We need to follow them very closely. Another problem now is acute fatty liver of pregnancy. In which group of patient you will develop this? First pregnancy, male fetus, preeclampsia, maternal obesity and multiple pregnancies actually. You need to see, because if you see pathophysiology of acute fatty liver of pregnancy, there is long chain 3-hydroxyacyl-CoA dehydrogenase deficiency. There are some enzymatic deficiency in the mother. This will cause this problem actually. And how do you diagnose this acute fatty liver of pregnancy? There are certain criteria, the Swan's criteria you might come across most of the time. So more than 6 criteria are met, you think of this acute fatty liver of pregnancy. Biopsy is gold standard, but practically it's not possible to do in all pregnant patients. But by and large, more than 6, particularly vomiting, abdominal pain, polydipsia, hepatic encephalopathy, and you rule it out other causes. You have ruled out viral hepatitis, you have rule out other underlying autoimmune hepatitis, and that point of time, suppose the patient fulfills these 6 criteria, you can comfortably say that the patient has acute fatty liver of pregnancy. Certain biomarkers like soluble FMS like tyrosine kinase and all that, but that practically I think very rarely we do. Academic purposes we can do that. Acute fatty liver of pregnancy, they will present with jaundice and pain in abdomen, might be associated with hypertension, edema and the proteinuria. How do you differentiate this acute fatty liver of pregnancy from the HELP? Jaundice is always there in acute fatty liver of pregnancy. In preeclampsia, not that common. Liver failure, acute fatty liver, suppose you don't treat, this patient will land up in the acute liver failure. 2-3 things. If there is a significant hypoglycemia, you think of acute fatty liver of pregnancy. Not too much of hypoglycemia, you think of HELP actually. Because why you need to differentiate? Prognosis and the treatment is near about same, but the prognosis may vary. This is to put everything in a nutshell actually. HELP, AFLP, TTP, HUS and SLE. SLE, as rightly said as previous speaker, significant proteinuria, active sediment in the urine, you think of SLE. If there is a fever, by and large, HELP is unlikely. If there is significant proteinuria, HELP is likely. And timing, HELP and AFL after 20s of pregnancy, TTP at any time of pregnancy, postpartum also sometimes, persistent low platelet, you are not able to find it out because ADAM-T 13 will take around 1 or 2 weeks to get the report. Persistent low platelet, no other possible explanation, antibiotic has ruled out, please think of TTP and HUS. Abdominal pain, HELP will be there in AFLP by and large less. One more thing, hypoglycemia will be there in AFLP. Other things, hypoglycemia may not be that significant. Investigations already we have said, but resistant hypoglycemia and marked neutrophil leukocytosis in AFLP, it is a main differentiation point between the HELP and the AFLP. Maternal complications, fulminant hepatic failure, hypoglycemia and DIC. Ultimately, this EL-chat deficiency is there in acute fatty liver of pregnancy. The problem is that once, even if you manage, sometimes because of pathophysiology, these patients might land up with transient diabetic insipidus and acute pancreatitis. So coming to last slide, actually, whenever you see a pregnant woman with the jaundice, you take a proper history and physical examinations. Too much of nausea, vomiting, gestational age, first 1 week, you think of hyperemesis gravidum or acute viral hepatitis. Too much of pleuritis, that point of time, the second or third trimester, you again think of either viral hepatitis, acute fatty liver of pregnancy or preeclampsia. Also with the right upper quadrant pain, mild hepatitis, you think of again viral hepatitis or acute fatty liver of pregnancy. If there is a fever or other things, you rule out the other infective causes. But at any point of time, pregnant lady comes to you with altered sensorium, you think of fulminant hepatic failure or other things like cortical venous thrombosis and all that. Altered sensorium with fever with pregnancy is not very good combination. We need to more aggressive. That point of time, you have to be keep a very low threshold to diagnose HELP and terminate the pregnancy. So putting in this nutshell, this is my last slide actually. Unique to the pregnancy, first things are very clear. Patient has a high bilirubin, high liver enzymes. There are only 2-3 diagnoses, either acute fatty liver of pregnancy, HELP or acute viral hepatitis by and large. If there is first trimester, too much of vomiting, too much of high transaminase, you think of hyperemesis gravidum. Second trimester, 13 to 20 weeks, intrahepatic cholestasis pregnancy. And in the third week, by and large, if on the third trimester, in the third trimester, you see a patient with deranged liver enzymes, low platelet, you think of either HELP or acute fatty liver of pregnancy. That's all from my side, and thank you.
Thank you, doctor, for a wonderful lecture. But I have one query. During pregnancy, there is urticaria, and you have said that UDLU acts for it. So I have basic query that how it acts.
It's enzymatic action, madam, on the liver substrate. It works and it degrade that enzyme and works. Other molecule like cholesterol and all that, that's not indicated. But this will break that enzymatic action and decrease the bile acid production actually. Because that bile acid will go and settle down in the terminal nerve ending. So this will decrease the bile acid production and decrease the pruritus.
Whether we should do genetic testing for each and every patient for acute fatty liver? Acute
fatty liver of pregnancy, if affordable, you plan for a second pregnancy, then it makes sense, madam. Because acute fatty liver of pregnancy, even if the bachu comes, even if do survive, there is a chance that there is a lot of complications can happen with this bachu, with stillbirth and other things. So given if that pregnancy is over, that's fine. But next pregnancy, suppose your plan, it makes sense to do the genetic testing.
Thank you.
At least otherwise, you keep a very low threshold to pick up the things in the first pregnancy as early as possible.
Thank you. Thank you, doctor. So we can move for the next session.
Thank you.
Thank you, sir, for that comprehensive session. It has certainly enhanced the approach to these complex conditions. I request the chairpersons to felicitate our speaker I request Dr. Rohini Deshpande and Dr. Ravindra Gundeli to felicitate our chairpersons.
The role of biological rhythms in regulating metabolism is an emerging field with significant clinical implications. Disruptions in chronorhythm are increasingly linked to metabolic disorders and lifestyle diseases. It is an honor to invite Dr. Madhav Prabhu for this keynote address. I request our chairpersons of this session, Dr. Pradeep Singhal, Dr. Ketki Joshi, Dr. Vitthal Dhadke, Dr. Sadhana Deshmukh, and Dr. Sandeep Holkar to grace the dais. Dr. Madhav Prabhu serves as the Director of Clinical Services and Professor of Medicine at KLE's Dr. Prabhakar Kore Hospital and Medical Research Center. He specializes in diabetes, tropical diseases, and chronomedicine with over 18 years of clinical experience. He has served as principal investigator in multiple international multi-centric clinical trials, including dengue and COVID-19 vaccination studies.
Shall I? Right. Thank you so much. Thank you for the introduction. I'm going to speak something different from what I have discussed up to now. Basically, I come from Belgaum. I bring greetings to all of you. My tryst with chronorhythm started when I was treating COVID. In Belgaum, in KLE, we treated around 8,000 patients of COVID in a single center. And somehow, at 3 o'clock in the afternoon, we saw that many patients started getting serious and dying. It was surprising. One of the students brought this out, and he said, at 3 o'clock, sir, patients are going bad. We, in fact, got a publication on this, and then we found out with international studies that 3 p.m. was the time when the COVID virus was at its maximum peak. The RT-PCRs were always positive, and the vaccination was best given at 3 p.m. So there was some rhythm that was there, and this started my, let's say, inquiry into chronorhythms. Now, for us, we are a set of clinicians who are also researchers. Kannada Marathi मध्ये आम्हाला master म्हणतात. So there are, a good master is one who can make your student ask the right questions. I come today to the land of philosophers, to people around here. I have seen yesterday Pandharpur, Gangapur, so I mean Akkalkot. There are so many philosophers. There was some ancient knowledge that is there. I will try to correlate this ancient knowledge and try to see what we have learned in science today. This is what Charaka Samhita says. Happiness, misery, nourishment, emaciation, strength, weakness, virility, sterility, knowledge, ignorance, life, and death. All of these depend on improper or proper sleep. In the next half an hour, I'll try to tell you how it happens. Well, let us first, when we are doctors, we tend to use surrogates. So if you have heart attack, you need a surrogate enzyme. If you have HSCRP for a risk of heart attack. So for sleep, or circadian rhythm, we should also have a surrogate. So that surrogate here is going to be melatonin. How is it related? And why should we think of metabolism? This happened because there were certain set of patients who were penitlamized, and in those we found that there was increased insulin resistance, and these patients developed diabetes. How is it related? This is the question we need to ask. But before we go there, there was this shloka that my dad used to say, Vaidyo Narayano Hari. You must have heard of this, right? But I went and found out the entire shlok. The entire shlok is, Sharire jarjari bhute vyadhi graste kalebare aushadam janavi toyam vaidyo narayano hari. Can somebody tell me what is sharir? Anybody? Venu sir? What is sharir? Body? Okay, and what is deha? Same. Very good. So this was also what I used to think. But in our shastras, there are two different things. One is deha, which is derived from, grow. So it is an anabolic process. And sharira is something which is perishable. So we are, from some age, going from a deha to a sharira process. But Vedic knowledge says that these two are not mutually exclusive. There is a balance between deha and sharira. So when does this balance start getting wrong? There also there is a shlok. It is somewhere around the 4th decade of life. And today science has found that around 40 and around 60 is the maximum burst of aging. So we start aging at 40 and the next process at 60. So what's going wrong in this phase? That's the question we should ask. At around 40, your melatonin level starts going down. Your sleep starts getting disturbed, fragmented. Maybe that's going wrong. So there are these questions that are there. You see, there is a long history of mankind. We have evolved over billions of years. We started somewhere with this last common, universal common ancestor. This last common universal ancestor, what was swimming in the waters, had no skin, had no shell, nothing. But one day he decided that we have to change. I have to come out. I have to become something different. So that started where there was some endosymbiotic relationship that developed, and then we developed into either the eukaryotes or prokaryotes. But what is it got to do with the discussion for today? You see, the first thing that happened in our evolution was this great oxygen event that happened. There was excess of oxygen available in the atmosphere. A lot of oxygen. It forced all of us to use oxygen as a primary source for metabolic reactions. Now, when oxygen is used as a source of metabolic reaction, there are some adverse molecules that are generated. They are known as oxygen-free radicals. This is where life started going wrong. Somewhere around the line, there came this Cambrian explosion, where life started maturing into different types of organisms. Everybody started evolving. Now life decided कि यार मेरे को कुछ अलग करना है. So animals and plants started coming out of the water. Their metabolism started excelling. There was competition to survive. If they don't survive, they started getting extinct. So these are the extinct things that went on. But in the process, what happened is that we started having more and more oxygen species, reactive oxygen species. Now something had to take care of this. That something was the evolution of melatonin, and it started somewhere around this Cambrian explosion and somewhere in between that where the immunity and circadian rhythm developed. Now you have to regulate this. So there was this enzyme which developed in the mitochondria known as melatonin. This melatonin was easily available and could be coordinated with the circadian rhythm. Why? Because most of the metabolism was happening in the daytime. Oxygen species were generated in the daytime, and when we were resting, they had to be taken care of. So what would take care of that? Melatonin. So melatonin started coming up more in the night and was less in the day to take care of this reactive oxygen species. And that's why that rhythm was generated. Now it was easy. All the body rhythms started following the melatonin rhythm. And melatonin became the king or the master of all circadian rhythms. Eventually, pineal gland developed. because these animals did not have pineal gland. And melatonin started coming out of the pineal gland. So what happened is, initially melatonin was developed only as an antioxidant function. Eventually, it became a master clock for all the circadian rhythm in your body. Because it was related to your day and night cycle, because it was related to your antioxidant scavenging mechanism. Even today, melatonin has antioxidant properties. Don't look at melatonin, look at what melatonin is a surrogate for. It is a surrogate for sleep. So if you sleep well, you are taking care of all these reactive antioxidant species that are being generated. Let's go a little further. Humankind started hunting. We started hunting, the prey was not always there. Sometimes it was a morning, sometimes we used to get in the night. So whatever we got, we had to store. And we started storing everything that we ate, because we were not sure tomorrow whether we'll get good food or not. Then we started getting preserving and fire, and then all these things started evolving, and then we have come to the Homo sapiens. But what happened is, those genes that were there, which were meant to store the food, did not change. They remained the same. This was the basis for the thrifty genotype theory that we have. Even now we have those genes, and we still store, and that's why we are getting metabolically obese. What has this got to do with melatonin? It has now been proved that the thrifty genotype, the gene that is responsible for this, is possibly the melatonin receptor 1b gene. Again, the storage related to the melatonin gene, and that's why perhaps we are having metabolic obesity, because we are storing everything that we are eating. Melatonin and the circadian rhythm, now we know, is responsible for a lot of modifications that are happening in the epigenetic level. So histone modification, chromatin remodeling, pole to pause controlling, all these are happening at an epigenetic level, not just at a genetic level, and this is controlled by our circadian rhythm. The question is, why should I bring this here? That's because perhaps that sharir and the deha are related to the methylation that happens in our body. If you have bad things coming your way, there is more epigenetic modifications happening, which compared to good things that you do. So the balance between the epigenetic methylation and unmethylation is going to tell you whether you are going to stay in your sharira or whether you are going to stay into the deha period. That's where your circadian rhythm is coming into play. You have a good circadian rhythm, no epigenetic modifications happening, you survive longer. You have less metabolic disorders. I was told that there's going to be a lot of audience with gynecologists here. It's actually terrifying for us physicians, because the only place we face the gynecologist is when there is a maternal mortality. And that's when they scrutinize us. Today is a different phase. I'm happy for that. See, when there is sleep deprivation in a mother, there are disrupted maternal sleep, appetite is disturbed. I'll talk about the biome later. There's impaired placental functions. There is going to be a lot of problems that happen, including epigenetic dysregulation in the uterine phase, which has disturbing outcomes on the patients or the child that is born. I think it's stuck. Yeah. Now we know that a child, as soon as it is born, does not have a circadian rhythm. It is regulated by the maternal circadian rhythm via her breast milk, or when it is in utero, it is via the placental melatonin that is there. So if a mother does not sleep when she is pregnant, if a mother has disturbed sleep, shift work, there is going to be a problem with the child. If the milk that is given to the child is not in time, there is going to be a metabolic problem that develops. Now we have all this research that is coming out which shows that this is the sleep rhythm of a child. You see that initial disturbance that is there, baal zhopat nahi ratrabar, that's then going to settle down. It's actually related to the melatonin secretion that happens in the child with the development of the circadian rhythm. So that gives us a topic of chronolactomics, where in uterine it is the melatonin that the mother gives, and outside that the breast milk gives the child that is going to affect the. So this is how the melatonin level in breast milk goes on changing. If you see that at night time there is more melatonin, there is going to be less in the day, there is cortisol which increases in the morning. Where this is important is where we are giving ICU when you are giving expressed blood to a child. Now you are going to take out the milk, and give it to the child. Say if you store it and give the morning milk to the child in the night, there is going to be a circadian disturbance in the child. Possible. We often have milk banks. We have a good milk bank in Belgaum also, where we tend to mix the blood. So there is a pool milk that is there. That also causes this circadian disturbance. That could have a poor outcome in patients coming out of NICU, including the light that is given to a child inside an NICU. If there is more light given to a child throughout the day, there is going to be a poor outcome of a patient, which is there in terms of the weight gain of the child also, and the stay in the ICU. That's the debate versus the giving the child pooled milk or separated. Now this picture I wanted to bring to your notice. If all of you know, this is where Krishna is telling the mother about Subhadra about Chakravyuha, and she goes to sleep. Maybe it was evening time, she slept. This is what is the principle of Garbha Samskara. If you do it early in the morning, that's what they do. Perhaps it has a good effect. If you do it late in the night, it does not work. Maybe the child doesn't know how to cross the Chakravyuha. So this is also perhaps related to the circadian rhythm that is there. How do we sleep? We have different phases of sleep: REM sleep, NREM sleep. As the sleep cycle goes on, the more NREM sleep starts decreasing and the REM sleep starts becoming more and more. It is this stage 3 and stage 4 of NREM sleep that is most important to us in all forms of metabolic disorders. If this phase is disturbed, you are going to have metabolic disorders, and I'll tell you how it happens. Basically, these are rhythms that are set in the SCN, which are then which regulate everything inside the body, including the female reproductive organs. It influences the immunity of the person, including all the immune cells. Some of them are active within day, some of them are active at the night. But what we need to tell is that the sleep caused by nature of night is excellent sleep. It keeps one lively, nourishes them like a mother, and is called Bhudatri. You must have heard the concept that you should get up early in the morning just before sunrise. It's called Brahma Muhurta. That's because as your sleep progresses, the REM sleep is more and the NREM sleep is less. So the initial part of your sleeping has more NREM cycles when compared to the REM cycles. So if you get up early in the morning, you are reducing your REMs and getting more of NREMs. That could be a possible answer to that question. But then sleep changes the TH1 type of immunity to TH2 type of immunity to TH1 type of immunity. This is very critical for immune cells and also for metabolism, because if this does not happen, if the sleep is if you are deprived of sleep, there is going to be decreased TH1 and increased TH2. Natural killer cells are going to decrease in their activity, antibody production is decreased, antigen presentation is decreased, there is increased inflammation, and that produces lot of diseases, including metabolic disorders. Why I have come to this? Because we have come back to inflammation, where evolution started. So, sleep deprivation is now a pro-inflammatory state given to us by a surrogate known as melatonin. What happens with the gut? Nowadays, most of my research is also on the gut. We are having a lot of people who are saying you can do gut transplant, you can get this type of bacteria inside, you can do that type of bacteria. How does it influence us? See, most of these are anticipated things. The bacteria in your gut anticipates the nutrition that is coming to you. So it knows the time that you feed. So if you are feeding in the morning, in the afternoon, and in the night, they are anticipating. And related to that, they are going to release certain bioactive molecules that are there. And it will influence all the processes in your body. Same thing in metabolism, same thing in inflammation, same thing in metabolic disorders. If you are not sleeping well, or if you are eating at night, so if you have, say, 10 o'clock, 11 o'clock, your biome is not used to it. It is used to eating in time. It is going to disturb your gut metabolism. If you eat the wrong things, wrong time, it is all going to influence all these metabolic feedbacks that are there inside your gut. eventually it is going to cause all the wrong metabolic signals and lead to metabolic syndrome. Imagine this biome that is there, the symbiotic relationship between you and your gut biome has evolved over millennia. It is not now. That's why the entire subject matter that we are focusing on research right now is which gut biome is best for you. If you get the best gut biome for the best individual, you are going to have less number of metabolic disorders. So, if there is disturbance in the circadian rhythm, there is going to be disturbance in the intestinal microbiota, the intestinal biological rhythm is disturbed, there are these systemic effects that occur leading to metabolic dysfunction and metabolic syndrome. Hence, there are a lot of GI specific strains now which are there for all the disorders. So now let's come to our main topic, metabolic syndrome. Is there a link between metabolic syndrome and glucose? Yes, there is, but there is a lot of controversy in this, and I'll tell you what controversy is there. Which is the best model to study? See, for everything we require models. Now for chronorhythm, we cannot use animal models, but most of these studies are animal studies. You cannot use this because our circadian rhythms are a little different from animal models. So which is the best model? We can use this sleep disturbed or OSA model for our studies on metabolic disorders. Basically, patients who have OSA have intermittent hypoxia and fragmented sleep. So they are going to have all this sympathetic activation, oxidative stress, inflammation, disturbed HPA axis, adipokinesis. All this eventually is going to cause insulin resistance, glucose intolerance, and type 2 diabetes mellitus, which has been proved. Now we are using this model for getting our effect of melatonin on the metabolic syndrome. So now what we know that science says is that melatonin decreases lipolysis, it decreases free fatty acids, it increases the lean mass, and it decreases the appetite and food intake. It increases beta cell survival, it increases glycogen synthesis, and decreases glucose production. It has oxidative stress is decreased and nitric oxide is increased. It has great effects on the cardiovascular system too. There was this unified hypothesis of diabetes which was there a long time ago when we were students. It concentrated on basically the oxidative stress that is there and then resulting into genetic expression and epigenetic modifications. Today we know that all of this is related to the sleep. And the point where I brought in melatonin in epigenetic modifications, perhaps this is where melatonin finds a role. So we have also seen that melatonin has the potential to prevent diabetic complication or end organ damage. When I use melatonin, again I'm telling you, it's just a surrogate for good sleep. There is increased browning with good sleep. If you give melatonin, we see that there is more brown fat when compared to the other fats. There is hypertension. There is again, you can see that melatonin has a good effect and has a preventive effect on melatonin. It can prevent apoptosis, which can prolong life. So coming back, always there is a hero and a villain. Up to now, we have been targeting insulin resistance. We are giving our patients either enzymes or medicines to increase the secretion of insulin or perhaps to decrease the insulin resistance. There could be another type of story, something which is going to be an antagonist to insulin, and that perhaps is melatonin. So the action is daytime there is more of insulin, melatonin is more in the night, it has its own effect. If you go on interfering with each of these, if you eat more in the night, you're going to have problems. That's why there is this upas that we are doing. So what's the controversy? Even after you substitute melatonin to every patient, it does not decrease the sugar, it does not decrease the metabolic effects, it does not cause weight loss in many patients. Some of the studies that showed that it happened, some of them did not. So what's the problem? Because we are equating apples with oranges. See, there are different chronotypes of people that are there. Some of them are this lion type, dolphin type, bear type, bull type. So their sleep is different. We don't sleep at the same time. So if you give melatonin at different times, it will work. It will not work if you give the same dose of melatonin in the same time for all people, because we are basically different. There are certain morning people and then there are certain night owls that are there. These morning people are seen to sleep 12 minutes earlier to these night owls. So there is going to be a difference in the dosage of melatonin or the actions of melatonin. This difference also has difference in the metabolic syndrome. Those people who are these night owls, they can eat a little later than the people who are morning people. So these are the rhythms that are there. Again, coming back, after 40, all of us, ADA, AHA, all the guidelines say that after 40 you should be careful, you should check every yearly and all that. Perhaps something goes wrong at this age. But what we have found out now is that if you have an early dinner, you have good average sugars, normal triglyceride, you have normal fat, dietary fat, and you have less stress level, which are all problematic with eating late dinners. What we are doing is we are eating at the wrong time. All of us practice till late night, 9:30, 10:30. Even I get my patients late night. I go home, I eat my food at 10:30. Then what I do is I take my mobile, I start scrolling internet for Facebook and Insta. I see the reels for all that. There's a blue light which is cheating my brain. It is telling that it is still daytime and our metabolism is still continuing like it was continuing in the day. That's what is going wrong, and that's why we are having premature aging. So the catch in the melatonin treatment is that you should give melatonin at a higher dose. The dose that are commercially available are 2 milligram and 3 milligram. It should be given at 4 milligrams and it should be given at least 3 hours before bedtime. So if I sleep at around 10 o'clock, the right time to me for giving me melatonin is 7 o'clock. That's when you should stop eating your food also. So in the last 5 minutes, I will just focus on how we can change the administration of melatonin. We can now modify the release of melatonin to, just like insulin, we have long-acting insulins, we can now have long-acting melatonins, which can then secrete at a very different rate and a different time, and it can give beneficial effects. What I also wanted to tell you is that it should not sound as if I am advertising for melatonin pharma companies, so I'm going to bring in some traditional knowledge. The next speaker is a nutritionist, so I won't interfere in her lecture, but there are a lot of our traditional foods that are there which are rich in melatonin, lot of traditional medicines that are rich in melatonin. The Mediterranean diet that is there, which prolongs life, has high amount of melatonin. And this is the best, because for us, I think, curd rice is our staple diet. Shinga chutney and curd rice taste very good. But our mothers always told us, don't eat curd rice in the night. Why is that? Because curd rice has a high amount of tryptophan. Tryptophan is a precursor for serotonin, which then produces melatonin. So you should eat it in the daytime. You are giving lots of raw material for secretion of melatonin in the night, which is perfect. It also regulates your gut. It will bring in the best biome possible, and it will bring down rates of metabolic syndrome. So this is the best. That's why South Indians are said to be better off when it comes to their mental capacity when compared to others. So these are the conclusions that I have. Circadian rhythm could play an important role in the pathogenesis and therapy of metabolic syndrome. Epigenetic modulations controlled by melatonin could play important roles in disease process and its modification. Melatonin therapy needs to be tailor-made for every individual. Eat well, eat right in the right time, sleep well in the right time. I think these should be what should be the messages that we are giving for prevention of metabolic syndrome. Any lifestyle diseases, these are the lifestyle things that will come up. There is a lot of research that is happening. I am dealing with the gut biome and melatonin levels in my lab. We are the first center in India to test melatonin in urine. That is a spot test. Usually we have a 24-hour melatonin. So these are new researches that are going up. These are questions that come to me and I keep finding answers. My students are doing research on it. Maybe someday we'll have melatonin as a substitute for many of our metabolic disorders. Pray that we have good solutions in the coming times. This is another one that I should tell you. A healthy individual should wake up in Brahma Muhurta, that is 96 minutes before sunrise, to protect and improve one's health. Brahma Muhurta means knowledge. The time to seek knowledge is called as Brahmi Muhurta. So again, this correlates with the melatonin levels. Melatonin levels are lowest early in the morning and start rising in the evening. Perhaps if we start living in tune with our circadian rhythm, we are going to draw a lot of benefits and prevent metabolic syndrome. I end with this shloka, let the entire world be happy. Thank you.
So that was an excellent talk and definitely opened our mind towards approach to insomnia. I know that melatonin is being prescribed for jet lag. I myself used to consume it. I would like to know what are the melatonin levels and how do we collect it and how do we estimate it? Whether it's going to morning, night time, how do we do that?
So what research is going on right now, sir, is melatonin they are doing in serum levels. But that is not the right thing because we don't know the rhythm. Also, the second way of doing it is to collect a 24 hours melatonin level. There are no normalized values for Indian males and females. That's the study that I am working on right now. But what we have got, and this is in coordination with Professor Neelu Jain who works in Jaipur, we are of the opinion that if we take an early morning spot melatonin, that gives us the most accurate prediction of the melatonin levels that are happening throughout the night. So our study is in a primary stage. I have just got one publication on that. So perhaps in future, melatonin levels early in the morning, that is a spot first urine sample of could be the best test for melatonin. The normalized levels for males and females is yet to be defined.
In continuity to that, so are we as physicians safely can we prescribe tablet melatonin and how long can we use it?
Yeah, so yes, as far as I have prescribed melatonin, but again, as I am telling you, melatonin is, we have to take it as a surrogate for sleep. So we are just trying to induce sleep in a lesser time. So if you use melatonin, it can be safely used. It has been used safely with up to 5 milligrams and it has been used for at least 2 to 3 years, what studies we have. But the catch here is that melatonin has to be used, say, at 7 o'clock if you're going to sleep at 10 o'clock. So I don't find a lot of patients who can take a medicine at 7 o'clock and then think of 7 o'clock. Also, the dose has to be between 3 and 5 milligram. Right now, commercially, we just have 2 milligram and 3 milligram available with us. So these doses also need to be modified. Side effects are, as of now, we have not found major side effects. That's why I have brought in that nutritional thing. Perhaps if we modify our nutrition in its timing and the content, we will have good sleep and better melatonin levels.
One more question. Other than induction of sleep, do you advise melatonin in certain disorders routinely? For people like who are sitting here for this audience, what you recommend?
That's the gist of the lecture actually. Melatonin perhaps now could be used as an antagonist molecule for insulin resistance. And then the entire, because insulin resistance is the base for your metabolic syndrome. So perhaps it can be used as an antagonist for metabolic syndrome in future. That's where the next research is heading. For the kind information, the two researchers that I have met, one is Mr. Prayonil Basu. He has worked on jet lag and melatonin. So he is developing a chewing gum for jet lag on melatonin. And in COVID, Professor Narsim Verma ji has given melatonin in patients with COVID. Of course, the timing has to be seen. And he has seen better results when compared to normal this thing. So perhaps in future, there will be a lot of other indications, as you say, for melatonin, other than just sleep inducing. And that's the gist of this thing. I don't want to see melatonin as a sleep inducing this, but as a restoration of circadian rhythm. So the treatment in future is not going to be sleep, it is going to be restoration of the circadian rhythm. That's the timely and appropriate melatonin administration.
Thank you so much.
Thank you, sir, for that thought.
Sir, excellent talk. Difficult topic made very easy. with lots of images and shlokas. Congratulations, sir. Thank you.
That's the effect of Pandharpur, I guess. I was in Pandharpur yesterday.
Any questions from the audience?
Yes.
So what if people have a good sleep pattern, good circadian rhythm, still they are suffering from metabolic disorder?
Sir, that's the thing is, having good time sleep. So if you sleep for 8 hours does not mean you are having good sleep. Sleep could be disturbed. There could be fragmentation of sleep. There could be sleep apnea. These are the details in your sleep rhythm that we need to analyze. What we are doing is, a lot of patients must be coming to you also. They say, sir, bharpur zop lagte, ratra bhar zopto. But when you actually do a sleep study, you will find that there is a lot of fragmentation of these people. So perhaps that not just the timing of sleep, the type of sleep. Like I said, there has to be more NREM sleep when compared to REM sleep. And if there is more fragmentation, then they are not going to have the normal sleep pattern that is there. That needs to be analyzed in such patients.
So just
Sir. Correct. Most of the Ayurvedic drugs that they are using for PCOS are having good amount of melatonin in them. So that also has been observed. In fact, I think Shashank Joshi sir in Bombay is trying out Ayurvedic preparations as adjuvant to insulin resistance, for insulin resistance, decreasing insulin resistance. This is quite well known, sir. Yes.
So for every person there would be different levels and there would be different rates for every person. So on the basis of that, what you said about the wolf and the lions and all that. So if the classification of that would be possible in your study.
That's the catch in the study. That's what I was trying to say, that we cannot normalize for all type of people. Then what we'll have to do is, we'll have to classify patients on the type of people they are, early morning or late owls. Then we have to do their melatonin levels. What we are right now doing is, we are getting a standardized value. So if there are 500 people in this hall, all 500, what is their closest to normal? That's what we are doing. But as you say, actually if you have to measure melatonin, you have to classify these people into the night owls, the daytime people, then do their urine and find out what is their normal value for them.
Have we found, in your study, have you done a single patient 24 hours levels of a patient? And
We have not done. We have done just the spot urine. 24 hours rhythm is the best. It is done by intermittent urine sampling for this thing. But still, studies are not enough to give us the normalized values.
Maybe like a CGM, like per monitor you put in a patient.
Perhaps in future, yes.
Maybe even adding biological age to your study. I don't know, how do you estimate it? But whether biological age and then classify your study on melatonin.
So
levels.
one of the study that I am doing is on telomerase. And we are trying to find out the effect of inflammation on telomerase. So we have done HSCRP levels in telomerase. Perhaps we can add melatonin to that study and see that. That's a plan in future. We have seen that high HSCRP levels have low telomerase length that is there, which is of course related to aging. Now this we will have to correlate with melatonin.
Dr. Roni Deshpande had a question. Can you give her the mic, please?
You mentioned about REM and non-REM sleep, right?
Yes.
So how do we find out, like, what kind of sleep do we
You'll have to do your sleep analysis.
Sleep analysis.
Yes.
So that's how it is done.
Disturbance in sleep. We'll have to find out a sleep this thing.
Okay.
Sleep studies will be done.
And what does it involve?
Oh, there is the ECG, there is EEG leads, then there is saturation. There's a lot of instruments that are there. And then the patient has to be, the worst part is that you have to keep the patient under observation. So I don't know how many of them really get sleep. That's why what we are doing now is we are doing 3 days in a row. So it goes on to the entire duration of sleep. Quite a tedious procedure, ma'am.
Thank you.
That was an excellent talk. I see you have awakened a lot of doctors from their sleep. Excellent. Thank you.
Excuse me. Hello. Does it cause pigmentation? Because I remember this molecule.
Melanin causes pigmentation, sir.
Yeah.
Melatonin.
See, let me tell you.
Yeah.
See, this molecule was there in the market around 2004 to 3 years, and then it disappeared. I used to prescribe it, and they were promoting it for premenstrual tension syndrome and the perimenopausal symptoms. And it used to work well, but then it disappeared from the market with some reported side effects, and it has again reappeared just in
What was the dose, sir? What was the dose?
5 milligram, I remember.
Okay. So
Those were then 5 milligram tablets, and used to prescribe at bedtime.
right now we have not seen
Then
any.
few patients came back, sir, मी गोरी होते आता काळी झाले. So
Right.
I think it
Possible, sir.
it does
Maybe time
cause,
will tell us.
pigmentation
Yes.
over time.
Maybe.
I request Dr. Varsha Kirpekar and Dr. Bhaskar Patel to felicitate our chairpersons. Due to time constraint, we won't be taking any more questions.
Dr. Rudrakshi sir and Dr. Venu sir has an announcement.
Good afternoon. First of all, I thank all of you for attending in a large number. The same is going to continue, but one announcement, Association of Physicians Solapur and Cardiology Society of Solapur are going to arrange 2-day CME and workshop on artificial intelligence on 20 and 21st of June. All of you must have got that brochure. Please register as early as possible. On 20, there will be a workshop on AI. On 21st, there will be lectures on AI. So please register as early as possible. And Dr. Vinu, do you want to add?
There are renowned speakers from all over India, and Dr. Pale sir is trying for an international speaker for the CME also, and he is the main organizing secretary. The Cardiology Society and the Association of Physicians of Solapur both are organizing this CME, and there would be a broad topic for all of the specialties, and then the hall will be divided for subspecialties such as radiology, pathology, and every specialty will be involved in that. So we request all of you to register as early as possible, and for workshop there are limited seats, so better to register it early. Thank you.
Thank you, sir. We now proceed to the inaugural ceremony. May I now request the following dignitaries and speakers to kindly join us on the dais. API President Dr. Satish Godse,
Secretary API Dr. Pradeep Singhal,
Joint Secretary API Dr. S.M. Rudrakshi,
President SOGS, Dr. Sujata Kulkarni.
Secretary SOGS, Dr. Ketki Joshi.
Program Coordinator, Dr. Rohini Deshpande.
And our guest speakers, Dr. Geeta Dharmatti,
Dr. Madhav Prabhu,
Dr. Akshay Chalani,
Dr. Rohit Deshpande,
Dr. Aniket Inamdar,
Dr. Sunil Hilapure,
and Dr. Kiran Joshi.
We request the dignitaries to come forward for lamplight.
I request Dr. Kiran Joshi to please be on the dais.
We request the dignitaries to come forward for lamp lighting. I request President SOGS, Dr. Sujata Kulkarni, to address this gathering.
Respected dignitaries on the dais and off the dais, respected physicians, esteemed members of our Solapur OBGY Society, distinguished faculty, and my dear colleagues. सर्वप्रथम गुढीपाडवा, चैत्रगौरी, ईद यांच्या सगळ्यांना खूप खूप शुभेच्छा. हे नवीन वर्ष सगळ्यांना सुख, समृद्धी, शांती, समाधान आणि उत्तम आरोग्य लाभो हीच प्रार्थना. It gives me immense pleasure to welcome each one of you for today's CME program. Today's session is truly special for us as it is a collaboration for the first time with physicians for an academic initiative. This collaboration marks an important step forward in bridging specialties and working together for better patient care. At the end of the day, our goal is same: holistic, safe, and evidence-based care for our patient. Medicine is constantly evolving, and we need to update ourselves with current best practices. I sincerely hope that at the end of today's session, each one of us takes practical points what we can apply to our day-to-day practice. I would like to thank all our speakers, Dr. Geeta Dharmatti Madam, Dr. Rohit Deshpande, Dr. Akshay Chalani, Dr. Madhav Prabhu, Dr. Aniket Inamdar, Dr. Sunil Hilalpure, and Dr. Kiran Joshi. I would like to thank all our panelists and moderator also. I will be failing in my duty if I don't thank Dr. Rohini Deshpande and Dr. Rudrakshi sir, along with Dr. Singhal sir and Godse sir for arranging such a wonderful CME and including us to be a part of this CME. And last but not the least, I would like to thank all of you for participating in such a large number for the CME And I take this opportunity to thank our educational partner, Zorvia, for wonderful arrangement. Thank you so much. Keep learning.
Thank you, ma'am, for the enlightening talk. I now request Secretary API, Dr. Pradeep Singhal, sir, to address this gathering.
Good morning, respected dignitaries, esteemed faculty, members of API Solapur, members of Solapur Obstetric and Gynecology Society, and my dear friends. On behalf of API Solapur, it's my privilege to welcome you all to this joint CME program organized in collaboration with OBGY Society. Such interdisciplinary academic interactions are extremely valuable as they help us provide more comprehensive and holistic patient care. The collaboration between physicians and obstetricians and gynecologists is especially important in managing complex medical conditions in women where coordinated care makes a significant difference in the outcomes. I sincerely thank the OBGY Society for the joint effort, our respected faculty for sparing their valuable time, and all participants for their presence and active involvement. I am also thankful to the organizing team for their dedicated efforts to make this CME very successful. I am also thankful to our Zorvia team for helping us in arranging this CME. Thanks.
Thank you, sir, for your kind words. I request everyone present on the dais to proceed to their seats. We will now proceed further.
In an era moving towards precision medicine, personalized nutrition plays a vital role in preventing and managing diseases by tailoring dietary interventions to individual needs. I invite Dr. Geeta Dharmatti to deliver the keynote. I request our chairpersons of this session, Dr. Satish Godse, Dr. Sujata Kulkarni, Dr. Shrikant Page, and Dr. Meena More to grace the dais. Dr. Geeta is a senior clinical nutritionist and nutrogenomics counselor with over 25 years of experience in clinical practice, research, and academics. She holds a PhD in food science and nutrition from Nagpur University. She is the founder and director of Brita Nutri Heal Consultancy in Pune and serves as an adjunct associate professor at Savitribai Phule, Pune University. Dr. Dharmatti has held leadership roles including past president of the Indian Dietetic Association.
Very good morning. At the outset, thank you, Physicians, Obstetrics and Gynecology Society, Dr. Rohini Deshpande, Madam. Indeed a pleasure. I'm a nutritionist, an odd man out in this public here, but I'm glad that there's a lot of integration happening. We all are trying to understand various areas of our application-based medicine, therapies, where I think holistically we are all looking to work towards patient outcome. And that's why today I think I bring to you a different perspective of learning nutrition. Nutrition and diet, these two words. When you say, I'm on diet, what does it mean? It means I'm eating less. My diet var ahe. And when you say I'm being nourished, it means you're taking good care of yourself through nutrition. But today's world is all about confusion, social media. And I'm sure today here you are not to listen, kai khaila paije, kai nahi khaila paije. And each one of clinician here is more bothered about patients' questions on nutrition and diet than the treatment. And you all would like to say, batata khau naka, wazan kami kara, chalayla za. A general guideline what we say, which is very common. But patient demands time. Patient wants you to listen. Patient wants you to listen to what he eats, how much he eats, and he asks you all basic questions. And I'm glad I had a speaker before me who actually set the stage for me to talk about it. Because we are now entering into a very different world and dynamic world of nutrition. It is just not what to eat. It is more than that. It is the connect of your body with the environment. And food is one of them. I'm sure each one of you eat for happiness, taste, satisfaction, celebration, social. How many of us think of nutrition when we eat? Then you become orthorexic. If you say, ki, I'm counting my proteins, I'm counting my calories. And I've been taught from my childhood, पोट भरून खायचं, मन भरून खायचं, मोजायचं नाही. And all this, when it comes to diet, the prescription changes. And I'm glad the previous speaker mentioned about the evolution of us. Mediterranean diet is being studied a lot, but Indian diet has not been studied. So we are into integrated systems. Ayurveda adaptogens are in place. Ashwagandha has a lot of studies now. So why don't we integrate our own medicine, food, gut, hormones, and I call this as PNIE system. My body behaves entirely different with another. I'm very much personalized. What suits one cannot suit me. Coffee ani chaha alo hota. You had a preference, right? You didn't pick up what came to you. Somebody wanted tea, somebody wanted sugar-free tea, somebody wanted coffee. Why is this so? Why not a blanket way of looking at what we eat? Because food connects. Food gives me a lot of feelings. My sense organs tell me what I'm eating, why I'm eating. So my first question to my patient is, when you say, "Me breakfast kato," and I'm sure today you're going to talk about yourself here. When I'm talking to all of you, keep yourself in this situation and ask yourself, rather than looking at it as a theory knowledge. पहिला प्रश्न विचारा, मी का खातो breakfast? Because patient asks me, "Madam, 12ला खायला पाहिजे, का 9ला खायला पाहिजे, का रात्री लवकर जेवायला पाहिजे?" So many confusions, and they don't ask their gut. They ask the environment, they ask the doctor, they ask the dietitians, "मी कधी जेवायला पाहिजे?" But I think you can answer it yourself. Do I feel hungry for breakfast? How many of you do? How many of you feel hungry for breakfast? Then you need breakfast. Why do I eat breakfast? नाही सांगतात ना breakfast खायला पाहिजे, म्हणून मी breakfast खातो. So I think the thought process of understanding oneself is more important, and that brings me to you a new concept of application nutrition called personalized nutrition. Because today, as the previous speaker, Dr. Prabhu sir, tried to tell us, that the epigenetics has a lot of role to play. We all say, माझ्या घरात गोड फार आवडतं सगळ्यांना. गोड लागतंच, जेवल्यानंतर लागतंच लागतं. Then my question to them is, किती गुलाबजामुन खाणार तुम्ही जेवल्यानंतर? एक का दोन? Ask yourself. In the general population we don't, but you can ask. If the answer is, नाही नाही, एक किंवा अर्धा गुळाचा खडा पण ठीक आहे. It's beautiful, it is satisfaction, entertain it. Even though you're a diabetic, doesn't matter, that behaves well with you because your body is asking for it. But I can eat 8-10 gulab jamuns. This is environment. This is not sweet tooth. So the difference of learning what my gut is talking to me is your genes. It is the way your body behaves. That's just 10%. It can be the environment which influences you. If I'm brought up in an oppository environment, I'm sure gynecologists and pediatricians handling insulin resistance for pediatrics, adolescents, they don't know why they are eating, how much they are eating, when they are eating. It's a total confusion for a young boy to understand, kiti bhook lagte. So my, again, question to the patient is, "Titi pav bhaji khau shakto." Pav is very easy, it's a standardized. Indian food is highly diverse. Pori, chapati, fulka, paratha, very different. मग हातसळीचं तांदूळ, बिर्याणी तांदूळ, Food is very different. We cannot compare our gut microbiome with the Western gut microbiome literature. But then when you know that how much is your appetite and satiety, you have an answer for all that. You can ask yourself again, pav bhaji kiti khau shakto mi? Because outside food comes in a standardized quantity. When I go order, 1 plate pav bhaji dena. Standard 2 pav aata hai. Pot bhar lo, very good. That's 350, 400 calories for you. Extra jodi lagte mala. 600 calories. 4 ni kai hot nahi, 8 tari lagtatas mala. 800 calories. What is this? Is this happiness? Is it comfort? Is it appetite? It is poor satiety. What is not working in you? Is it leptin? Is it ghrelin? Or it is neurotransmitters? There's something environmentally influencing you. And that is why I think it's very important not to look food as mechanical application. Your AI can give you a diet chart. You don't need a dietitian today to tell you what to eat. And I'm not going to do that job now. Because if I enter, mala wazan kami karayche, my height, weight, it can give me a calorie intake. It means say green tea piya sakai, oats kha, and then you have salad. What is a diet in that? There's no diet in that. But consistency is very, very poor in that. And that is why I think we have to start looking no blanket advices for all and get into the cellular nutrition, molecular nutrition. How does my body behave with environment is what we are learning. And that is why the application is in. I am not doing anything different. I am a clinical nutritionist. I practice nutrition. I am not a researcher. I practice what has been researched. I practice what is being mentioned. And that's what I am going to give you today, the thought process of how a nutrition world is changing so dynamically. Because cell is an existence of all living thing. And your cell is made up of 16% protein, 40% fat. So it's all about nutrients. When the nutrient is derived in your cell and you're looking at your macros and micros highlighting you, then genomics, molecular nutrition plays a vital role. And hence I think we are ushering ourselves into a new world of omics. The omics is trying to tell me the decoding of my own self to know what I can eat. How much should I eat? Because a weight loss is a very simple management. You eat 2-meal pattern or you eat secondarily, it doesn't matter. If you eat less, you lose weight. Do you all agree with me? Energy deficiency gives you weight loss. My energy deficiency can be anyways. So, त्या dietitian वजन कमी केला का semaglutide वजन कमी खाल्लो म्हणून वजन कमी झालं. So, it's energy deficiency. But the energy is driven just not by the numbers. It is macros and micros contributing the energy. And every molecule of food which I eat is connected to me. So I should know what my body needs. And hence I think if I know a personalized approach, it is more better. My adherence will be better. Sustainability will be better. Because each one of us cannot have same metabolism. We all are different, and who knows this difference is you yourself, through your gut feeling, of course. But everything doesn't work on gut feeling, because gut feeling also is impacted by environment. Mala savay झाली आहे. I can eat 2 पोळी, पण माझ्या आईने मला एवढं खाऊ घातलं लहानपणी की सवय झाली आहे, मी 4 पोळ्या पण खाऊ शकतो. A mother feeding 10 glucose biscuit in a cup of milk is so common nowadays. 60 grams of sugar at one shot. But mother doesn't understand, the child doesn't understand. Satiety, hunger are missing links today. When I do ask everybody, काय खाता तुम्ही सकाळी नाश्ता? No answer. Maybe भूक लागली, maybe सवय किंवा घरच्यांचा आग्रह. अरे ब्रेकफास्ट शिवाय कसं जाणार तुम्ही? फूड इज एनर्जी ना, खातोय आणि त्याच्यानंतर काय करतोय मी? काहीच नाही करत आहे. किती खायला पाहिजे, काय खायला पाहिजे? Maybe we've never thought about it. And we are now driven with lot of literature which tries to tell me that you should eat amuk and teodas. But just take this 20 minutes out of the thought process and ask yourself. A typical diet plan says calorie, protein, fat, vitamins, minerals. Health outcomes is what you want to look at. Diabetes झाला तर साखर कमी करा, वजन कमी करायचं तर calories कमी करा. But one step ahead if I want to know a precise and a better nutrition. Now we have a concept of looking at A, B, C, D, E, F, G. And I'm going to come to each of that. हा सगळा इंटिग्रेट करून आपल्याला काही नाही करायचं आहे, AI सगळं करून देणार आहे आपल्याला. फक्त विचार करायचा की हां असं होऊ शकतं. So there's no complicated theory with AI telling you what to do. But giving the right question to your AI is more important. And hence I urge all of you to look, each one of us, you can start from yourself because nutrition is a very favorite topic in every conferences. Because सगळ्यात पहिले it starts from home. 4 लोकांना 4 वेगळा स्वयंपाक जमणारच नाही. एकच किचन, एकच स्वयंपाक, 4 माणसं वेगळी वेगळी. So how really do I really look into it? So there is now epigenetics, genomic studies, metabolomic studies, AI data driven fitness apps, HRVs, which personalizes my approach towards me individually. It's very, very important to learn for all of us that why my learning is pharmacogenomics for the clinicians here, which drug, how it behaves with me, and CGM. So let's take a small case example for next 20 minutes to connect what I'm trying to give you the inference. Let's take a typical PCOS. हे एक असं आहे की कळतं पण वळत नाही. So when mother says की हे करत नाही ते करत नाही, I always say की मग मी काय वेगळं सांगणार आहे. व्यायाम कर, कमी खा. So it's a very difficult scenario in a typical pubertal challenges where a lot of metabolic areas, cravings, poor lifestyle, and the outcomes is symptomatic. And clinicians and gynecologists treat them symptomatically by giving them a prescription. Maybe फारच त्रास झाला तर डायटिशियनकडे पाठवाल किंवा सायकॅट्रिस्टकडे पाठवाल. त्याच्या पलीकडे there is not much which you and me can do. So how do I look at a personalized approach towards this case? कारण हे सगळं कळतं, हे असंच करायला पाहिजे. And the previous speaker spoke about sleep. So if you look at it holistically, sleep is one of it. But there are n number of areas. I start with attitude towards food. How are you connected with food? का खाते? आई देते म्हणून खाते का भूक लागली म्हणून खाते का इच्छा झाली म्हणून खाते? This definition is different. किती वाजता झोपते, किती वाजता उठते? These questions are important for me because that's all holistically going to impact my patient's outcome of my personalized nutrition plan. I definitely start with energy. Energy कुठे जातच नाही. My first calculation is what is my energy requirement, my metabolism. So my metabolism says to the muscle fat किती आहे? Fat जास्त आहे, the metabolism hopeless. You have to build muscles to work on fat. व्यायाम केले की भूक लागते. So my step 1 is not ask her to go to exercise and to gym and pay the membership. It is never successful. So I ask her to go on first calorie deficit, small 20 minutes of activity. So we start very slow from exercise point of view. But calorie deficiency is my first goal. Now how to work on calorie deficiency is very, very personalized here. Micronutrient deficiency is the first thing we will address. Pathologically, you know B12, D3, but what about others? B complex, magnesium, so many micronutrients. And we just heard oxidative stress. Fat increases inflammation, gives you a lot of oxidative stress. Skin, hair, everything tells me that I have a hopeless free radical generation in my body. My sleep timings don't go. My एकात एक गुंतलंय हे सगळं. कुठून तरी तर सुरुवात करायलाच लागेल. So my ABCD says anthropometry, biochemical parameters, clinical, gut health, your dietary. I have to look at something to pick up first step of action, and environmental. So we call this a gene-diet interaction. Environment and me getting interacted with each other. So today we have metabolomics too, a real-time data of your enzymes. It's an expensive test. I'm not asking each one of us to go for it. I'm introducing this concept of personalized nutrition to this audience, where this is there, where you have holistic approach to understand what can work. Earlier it was only BMI. Now we have a bioimpedance machines to tell how much fat, how much muscle I have. Each wellness centers, nutrition centers has it. Then I have pathological report to tell me, okay, what foods I can give. Fasting insulin jasta hai ka, fasting glucose jasta hai, HbA1c, glycemic load of the food and all that. Then I have markers. So my diet today works more on body constitution, inflammation markers, visceral fat. So I concentrate on adaptogens through food to be a part of my prescription. So metabolic markers, metabolomics also are there to work on it. You also have a gut microbiome studies to help me. But today with a diverse Indian diet, Bacteroids and firmicutes, 90% is my biome. So I pick up only that and give pre-probiotic foods. Tandrachi ukkad, sabudanachi paste, panchamrut. So for a gynecology, because pre-probiotic. And believe me, it induces good satisfaction. Introducing a pre-probiotic in your diet gives you a good gut flora, enhances a good neurotransmitter generation. And that is the first step. मला फक्त त्यांना वळवायचं आहे, सगळं कळतं सगळं त्यांना. So I start looking at changes in micronutrients and gut microbiome. It's easy to take a prescription of multivitamins. It is easy to work on things. तुला काय खायचंय ते खा, पहिले हे खा. And I ask the preference, काय काय तुम्हाला आवडतं. So gut microbiome. Work on antioxidants, so much of oxidative stress. So glutathione parlors we still don't have here. Dermatologists have to prescribe that. Dietitians also cannot give. But we know glutathione is a combination of 3 amino acids only. So glutathione is a superoxide. Selenium is a super antioxidant. So my almonds, my food has everything of it. But I can do a test to understand my markers of GSH, MDA, SODs, free radicals are काय आहे तो metabolomics मध्ये test. It's an expensive test. We still don't do it here. There are 1 or 2 labs in India which does it. But genomics is done everywhere, and this genomics is preventive genomics. I show you how the diet chart looks. Amino acid metabolism is also something where you can pick up B6, B12, folate, which protein my body can digest. This is so personalized. And vitamin supplementations, genetic markers, which genotypes helps me to understand. And you have fitness app trackers, HRVs, exercise, VO2 max. Isn't this looking complicated? But this is precise, personalized, and this is there. If you see why Amitabh Bachchan is not anti-aging, why Hema Malini looks so beautiful at this age, A, B, C, D, E, F. They do all this. Now they were tracking the ribonucleotide, where the RNA, mRNA-based prescriptions are given. They are given the glutathione oxidase as an enzyme. The bioactive, bioavailable enzyme preparations, molecule preparations, they help you to have a better oxidative stress and anti-aging and longevity. So this is the way where a personalized approach towards macros and micros. So kiti carb, kiti protein, kiti fat पासूनच हा प्रवास सुरू होतो. Your macros are the first step. 30% fat or 25% or 40%. Your ApoE genotype, I would like you to read a book on ApoE genotype. It's a very beautiful book where you have understanding of that ApoE. One ApoE genotype will tell you so much about nutrition, your exercise, your circadian rhythm, which Sir was just talking about. This is how the genetic report looks. Again, I would say the SNPs are all studied in human genome studies. 10 years of human genome of 1990 to 2000 helped us identify the SNPs, and there are more and more SNPs coming out. The labs tell us which kind of genotype you have. I am not a genetic expert, but this is the report I get. And it tries to tell me, look, your obesity FTO gene is good. TCLF2, the carbohydrate support to your body can be modified. तो 2 पोळी 1 वाटी भाजी खाऊ शकते. If TCLF2 was bad, 1 पोळी 1 वाटी भाजी 1 वाटी डाळ. So the glycemic load of the food changes here. Adipogenesis. You cannot afford to eat 2 chapatis and sabji because extra carb in every meal will give you adipogenesis. So such a fine thought process. एकाच वेळेला खाल्लं तरी माझा फरक नाही पडला पण त्याला फरक पडला. Because eating a large meal is okay with him. His body is looking at the whole calorie. But eating a high carb meal for me is giving me adipogenesis because of PPAR, gamma, FTO or whatever. So this is one of the approach where I learn my micronutrient prescription, like Dr. Prabhu did definitely talked about the methylation, epigenetic modulation. And I'm going to talk about how the neurotransmitter and methylation are connected here. So the genes tell me what kind of approach I need to work on, micronutrient supplementation, and the metabolic approach towards the patient. What I need to prioritize. Now you can look at the clock gene here, the circadian rhythm gene. Sir is working on melatonin. I do not give melatonin prescription, but I do talk about what time of the day they should be exercising, because your focus, your energy levels is very high if you're an evening person. So if you look at the clock gene, because there was a talk before this, so I'm highlighting a clock gene. TT and TNC are your allies, so you can do both. You're a person who can adaptable to any type of day. Then I ask, तुम्ही अभ्यास करताना रात्री अभ्यास करायचा का सकाळी अभ्यास करता? Each one of us know what kind of circadian rhythm I have. And once you know I'm a night person, morning person, we shift your focus that 4 to 6 is your exercise time, especially muscle exercise where your body is unable to work out. So do it in the evening, your muscles are better because whole day your body warms up. So these are very small approaches where we can work. Look at the MC4R gene. This is melanocorticotropin receptor gene. Yeah. This is melanocorticotropin receptor gene. Immediately I can tell that bariatric surgery will be useful or not for you because bariatric surgery is all about eating less. But this MC4R gene, if I'm a snacking tendency, my approach is to look at food as happiness. I will keep on eating. त्याच्यामुळे मी एक पोळी कमी केली तर मी सारखं खात राहीन. Each one of us does. If you don't eat full meal with satisfaction, your mind is not happy and you keep picking up food. You can ask yourself, माझं पोट भरल्यावर माझा आवडता पदार्थ आला तर मी किती उचलणार? आहे त्या प्लेटमध्ये बिस्किट किती लोकांनी उचललं? भूक होती का नव्हती? So there's a very simple question which will trigger your understanding that why am I eating this? Is it mind, hunger? Hunger is a very rare phenomenon. We are not hungry at all today because we are overfed. We keep eating regularly, so there's no hunger. It is a neurotransmitter drive. And this is how we all look at it. Today, every sportsman does a genomic testing because he can work better. At the first point where he wants to enter which sport, तुम्हाला strength चांगली आहे, endurance चांगला आहे का कुठला चांगला, you can pick that up. Injuries, recovery, prevention, time of exercise, and supplementation. All this becomes very personalized. You can make out what kind of meal pattern you can eat, what kind of antioxidants, anti-inflammatory support you need. So nutraceuticals is a big market today. And what to pick up is a confused approach which each one of us have. Maybe if I personalized your approach, I will be exactly able to pick up nutraceuticals for you if needed. But remember, the RDAs, the recommended dietary allowances, is for ideal body weight. तुमचं वजनच 90 असेल तर तुमचा requirement पण वाढणारच आहे. So I always say one multivitamin for each one of us if you are having high amount of oxidative stress, if you are looking into a very highly inflammatory support, is not a problem at all. Because your body needs a lot of energy facilitators. Food gives me energy, but who facilitates the energy is my micronutrients. If you go back to your Krebs cycle, glycolysis and all, you realize how important is riboflavin, niacin for it. And that's why today niacin is a big market for us. So this is how I think we can personalize and understand what kind of meal I need. But people who have very strong mind, who are very contented, who have understood what to do, who have a better parasympathetic drive, who do yoga, meditation, sleep on time, system discipline, I think they have a better say. They did not get into so much of genomics. We're talking of people who are confused and who needs a lot of help to work on their lifestyle. And today we have that world of genomics and metabolomics to help us. This is how the report looks. I'm not going into detail because my job today is to introduce to the concept of genomics and personalized nutrition, precision nutrition. So look at the amount of what genes are done in each area. Omega-3 ALA, they'll do these 4 genes, give an algorithm tells me that what kind of approach should I have, do I need supplementation, food, gut microbiome, and accordingly, it will help me to work better on that person. Very simple example, मला दूध आवडत नाही, मला दूध पचत नाही, किंवा मला दूध पिले की त्रास होतो. So very clear understanding. So why is that so? I need calcium in my diet because lactose intolerance is very common for all of us. We are all trained to digest our own mother's milk, but we've trained ourselves through epigenetics to tolerate milk. Then one fine day when the environmental factors increase, you can't digest the milk. दही पचतं पण दूध नाही पचत. दही नाही पचत म्हणजे protein intolerance, मग ताक प्या तुम्ही. So the digestibility concept changes with the environmental impact. You will also realize that one fine day I was able to eat this, today I'm not able to eat it because of your gut microbiome and environmental impact. And this is how we are trying to personalize the way we look at it. I have last 4 minutes and I would like to highlight how a neurotransmitter and methylation is related, so that the key idea of learning this or understanding is nutrition has gone beyond science, where nutrients can play a role of bioactive components and facilitators to a lot of areas which we are looking at. To all the gynecologists here, methylation and folate is a very integral part of your prescription today. Homocysteine for the vascular health physicians is an integral part of understanding B6, B9, B12. I'm talking about neurotransmitters' role. We've picked up a case of PCOS and want to understand where can I work on. I can work on, and the previous speaker said, I want to work on tryptophan, tyrosine giving me serotonin and dopamine. This is the area I want to work, and I know that how anti-HFR plays a role here. And what is helping me to learn is betaine tetrahydrofolate to betaine dihydrofolate here. Now what is this betaine? Why does runners take beet juice? What is this betaine all about? So betaine is nothing but trimethylglycine. Glycine is an amino acid, a non-essential amino acid, and TMG supplements are in the market. So this betaine is nothing but a trimethylglycine, which is also a part of your glutathione, which is a part of your neurotransmitter tryptophan and serotonin generation, and look at the process, what it works. So if I have to look at this case of PCOS, I will give her a TMG, give her a B12, B6, B9 support, give her a pro-prebiotic support. I won't talk to her about kai karaycha, kai nahi karaycha, vyayam karaycha, amuk tamuk. But I will look at these small areas to work on, and then call her after 15 days and see how the body is responding. And then we work on calorie deficiency and mindfulness and intuitiveness. This is how the prescription is now changing. We are looking at functional nutrition at the same time, like functional medicine, functional nutrition, understanding the root cause. So I have A, B, C, D, E, F, food allergy, and G, gut microbiome and genomics. So finally, it is an interplay between the environment and yourself. We are here to learn, understand what your body is demanding. Through application-wise, there are a lot of tests in the market, but this, our alternate medicine always did by asking a lot of questions to us, by finding out which prakriti and which nadi we were. I think similarly is what I'm trying to say, that this is how I think the science is evolving, and we are trying to learn through the test. A stool examination, you have a lot of gut microbiome. Genetics is one-time test, but gut microbiome is every 6 months, 3 months test. They try to understand your gut microbiome. They try to give you your Bacteroid by Firmicide ratio. They'll try to identify the bacteria which your body is not having. And they try to give you food list. But I still have a doubt on this, because Indian food is very diverse. We have a lot of gut diversity. A North Indian and a South Indian and a Maharashtrian will have a different gut. So Indian studies are not there. So I don't know whether it's a process of putting it as a test. I do not prescribe this. I think my pre-probiotics in food work better. Dahi bath after food works better. Sabudanachi paste works better. Resistant starches work better. So what I'm going to do is, you will come with that soon. You will have a nutritionist at your desk, a health coach at your desk, call it what you want. She has to integrate all this. She has to just put the patient's details, the food habits, the environmental impact, the gut microbiome report, the pathological report, the genomic report. All this, she will put that, and maybe you get a diet plan. You get a nutrition, let's not say diet, let's say nutrition prescription, which will help you to identify what is the first area of application your body demands. Rather than imposing a diet on you, let the body tell you what nutrition protocols you need, and that definitely welcome. So welcome to the era of systems biology. Nutrition system biology talks from soil to plate. The micronutrients of my soil comes to my food, food to my body, and the bioactiveness of the micronutrients is what I would like to work. So your type 5 diabetes is all about micronutrient deficient diabetes now. So are we now, I'm done. Are we now looking at something which is trying to give me a prescription which is beyond my imagination? It is looking at soil health, it is looking my plate health, it is looking the gadgets, it is looking the genomic report. So welcome to that area, don't get confused, but somewhere There are a lot of still challenges in our country, but in tier 1 city, I belong to Pune, we are doing this. We have metabolomics, we have genomics, we have gadgets, we have AI which is integrating it, and companies are coming up. It's a dynamic, changing world. So definitely ethics in counseling, not getting carried away with the nutraceutical prescriptions. Dietitians are here not to write medicines, they are here to give counseling. With AI coming in, only thing which is left to us is the root cause counseling. These are two things I think coming, which is important. And I think we need to be training the dietitians and health coaches for that. So thank you very much for your patient hearing. It's been a long day for you and it's still going to be a long day. But I hope I have given some kind of conviction to you that food is not about diet. Food is about nutrition. Thank you very much.
Thank you, Geeta, for a lovely talk. I heard about this before, but you made it very simple and very nice to understand. I think OBGY people can implement this in their consultation for the new babies. They will improve their genes and it will help a lot.
Remember, this is preventive genomics, not predictive genomics. So somewhere, counseling should not be that you will get this area. We don't even say tumhala diabetes hona hai. You may get into insulin resistance. This is what I think is the way we put forward, not giving anxiety to the patient about prediction.
Madam, it was very wonderful lecture and some other aspect you have shown about genetic. If there is one genetic test what we can do for a patient, like some PCO comes with obesity, then what it will be? And something about APOE you said. Yeah. These are the terms I have heard for the first time actually.
No, like pathology lab, there are a lot of nutrition genetics lab coming up. There are many, you can Google it or you can find out that many labs have come up for preventive genomics. They tailor make the genetics as per your requirement. They come to you with a prescription. They give you a package of dietitian supplements and everything. So you can have I can send it to you if you want 1 or 2 labs. You can explore them, you can learn about them. But you need a good counselor to connect that lab reports to the patient. It is direct to consumer test. Doctors don't prescribe it also. Maybe patient will come to you with a genetic report and he says, I've done this report and I want you to counsel. So somewhere that also is important to learn. Have I confused you all?
Thank you, ma'am, for emphasizing the power of individual care through nutrition. I request the chairpersons to felicitate our speaker. I request Dr. Vidya Karvekar ma'am and Dr. Karvekar sir to felicitate our chairpersons.
We will now proceed with a panel discussion. Till the arrangements are made, I request Mr. Alad Mahajan, Sales and Marketing Director, Zorvia Healthcare Limited, to say a few words.
खाली 7 नंबर.
Namaskar, good afternoon. On behalf of 1,350 employees of Zorvia Healthcare, we sincerely thank Association of Physicians of Solapur and Solapur Obstetrics and Gynecological Society for giving us an opportunity to be associated with this wonderful academic feast. I would like to thank Singhal sir, Rudrakshi sir, Nirmal Tapadia sir, Godse sir, Sujata Kulkarni madam, Rohini Deshpande madam for giving us an opportunity to be associated with this program. A little bit about Zorvia. Zorvia Healthcare operates into area of gynecology, diabetology, respiratory medicine, nutraceuticals, and pain management. So these are the areas of focus of Zorvia. This organization stands on 3 principles of trust, innovation, and accessibility. And just to highlight a couple of things, that we are the first company to introduce empagliflozin at a never before price, an epic price of 4 rupees 60 paisa per tablet. Our brand name is Emplic and Emplic M. We are also the first company to launch a combination of levocarnitin with magnesium with veg vitamin D3, maglectin with vitamin B6. So we are going to focus on nutrition aspects which have been covered. And for the first time, we are going to launch a brand of oral albumin, veg oral albumin, G-Cell, which would be launched by next month, which is going to be our own manufacturing and marketing arm. Having said this, we would be more than pleased to be associated with such academic feasts and programs. We stand for science, and therefore we would request you to strengthen our hands through your prescription so that we can be associated with more such programs. Thanking you once again. Best wishes to each one of you on behalf of Zorvia. Thank you very much.
Good afternoon, everybody. We thank API Solapur and OBGY Society Solapur for giving us this opportunity, especially me and Dr. Karande. We warmly welcome all the panelists of today's discussion on peripartum medical emergencies. This was designed for treating critical maternal cases along with trying to maintain the fetal well-being. So these are our respected and esteemed panelists of today's discussion. Okay, so we start with the session.
Good afternoon, everybody. I'll welcome you all for this panel discussion. Coming to the background, first we'll go to all the physiological changes that occur in the pregnancy before understanding how to handle and investigate the complications of obstetrics and medical disorders in pregnancy. Approximately 6 to 15% of the pregnancies involve serious potential life-threatening complications or high-risk emergencies required special intensive care. According to 8% have complications that can harm to the mother and the baby. And about 3% all the emergency department visits made by pregnant patients have these complications. We'll just shortly go through all the physiological adaptations that a pregnant woman goes in the pregnancy, because this is important while managing and investigating the patient, and you should know these changes while coming to these conclusions. There is approximately weight gain of 12.5 kgs, uteroplacental circulation increased by 450 to 650 ml per minute. The systemic blood volume increases 40 to 50%, and this puts the extra load on the mother's heart. The red cell mass increases only by 20%, so this adds for the physiological anemia that occurs in the pregnancy. And there is decrease in the hematocrit by the 15%. Coming to the clear reading clearance, it changes by 50%. Cardiac output increases by 30 to 50% to compensate for the uteroplastinal circulation and all the physiological changes in the pregnancy that was occurring. Heart rate increases by 10 to 15% beats per minute, and diastolic pressure increases is about 10 to 15 millimeters of mercury. There are some changes, adaptation occurs in the physiological changes also in the lung that Dr. Nirmal Tapde will cover up.
So coming to the respiratory system, basically we have increase in minute ventilation that is understood because of higher oxygen demand for the mother. Tidal volume increases by 30 to 40%. Peripheral vascular resistance decreases in order to increase the blood flow. Expiratory reserve volume decreases because in pregnancy the diaphragm is elevated by up to 4 centimeters towards the lungs. Respiratory rate, there is no change. Forced vital capacity, it is slightly decreased. As you can see, inspiratory reserve volume and tidal volume increases, but the residual volume and the forced respiratory capacity, functional residual capacity, it decreases in pregnancy. All this is just to adjust the abdominal pressure and give more oxygen and blood supply to the mother as well as the fetus. Moving on to our first case of discussion today. A 24-year-old primate at 39 weeks gestation came with history of premature rupture of membranes with prolonged labor with severe abdominal pain during contractions, tachycardia, excessive PV bleeding, hypotension and fetal distress. Her uterus was tonically contracted and hard. Bedside USG showed abruptio placenta. Investigations were sent, blood products arranged, and she was immediately taken for LSCS, but the patient collapsed during anesthesia. CPR was started immediately by the anesthesia team and code blue was activated. So our question to our anesthetist, Dr. Santosh Kalchatti, how will you resuscitate this patient after overcoming the physiological and anatomical challenges in them? What are the recommendations of CPR in pregnancy and modifications to standard ACLS?
In this patient, we will be dealing with two lives. One is a fetus and other is a mother. Okay. And there is other problem because of huge uterus, there is aortocaval compression, and the uterus has pushed the abdomen, diaphragm has upward, the heart is pushed upwards. So our main will be have to start chest compression immediately. So we should have chest compression, we should place our hand 2 to 3 fingers above the episternum. Normally we keep 2 fingers, we have to put little bit higher. And our chest compression should be 2 per second. It will come around 120 compressions per second. And aortocaval compression we can manually displace by hand with or 10-degree wedge below right hip. Okay. So we should start compression. The other person will take care of airway. We recommend intubation. As this patient has come with abruptio placenta, we give it only, we do it cases under GA only. So we give 100% FiO2. And the staff will continuously give adrenaline every 3 to 5 milligrams. Every 3 to 5 minutes we should keep. And other thing we can add is once you put the endotracheal tube, you should see the ETCO2. ETCO2, if it is more than 10 mmHg, there is early chance of return of spontaneous circulation. Okay. So we should monitor ETCO2 also. And next thing, as we have, everybody has ultrasound machine in OT, obstetricians they have, and in intensive care units also we have this ultrasound machine. We can do just the focus. Okay. So this is the abruptio placenta. We can see IVC. IVC should be empty. If heart is contracting or not contracting. Okay. If it is contracting, we can increase the vasopressure. We can increase the volume. We can give blood also, and we can do. And we should continue CPR, chest compression. Okay. We need at least 3 compressors. So each compressor can give only 200 times or for 2 minutes. And after 2 minutes, we can reassess the patient. Just see the focus, just see the rhythm, whether it is a pulseless or If there is a VT, we have shock it. If it is, there is no, if it is a flat line, just give adrenaline and continue CPR. Okay. So with this modern era, we should make use of focus, with ultrasound machine. We can see fetal heart rate also. So after 4 minutes also, 4 to 5 minutes also, we can go for perimortem. What we say, perimortem cesarean delivery. We can do it. We can deliver the fetus. We can deliver the fetus, and once the patient is delivered, the return of spontaneous circulation chances are high.
Two changes in this. You should note the time of pulselessness, because after 4 to 5 minutes you have to proceed for PMCD. And second is left uterine displacement and tilt of the mother to around 15 to 30 degrees, not more than 30 degrees, because it can shift the heart towards the left side and your effective sternal compressions can be hampered basically. So these are the changes when we resuscitate a pregnant patient who has collapsed somehow. Return of spontaneous circulation, the CO2 or end-tidal carbon dioxide expiration should be at least more than 20 millimeters of mercury at least after 8 to 10 minutes. So that is an indication of a good ROSC. Next question.
My next question is to Dr. Dabde, sir. The anesthetists are resuscitating this patient. Side by side, how you prioritize the maternal resuscitation versus fetal well-being in the few minutes critical that are going on? And can you elaborate on the 4-minute rule and its practical challenge in this real world?
Yeah. Before I embark upon this case of abruptio placentae, let me just add, because the anesthesiologist is here, the operating surgeon should be washed up and ready before they start inducing the patient, whatever, whether it's general anesthesia or spinal anesthesia. I am happy that our anesthetists, they don't give anesthesia unless the chief surgeon is there in the operation theatre. But it may not happen in the private setup, because the anesthetist has to attend the next call. So, Madam has seen the patient, not related to my wife anyway. Madam has seen the patient in labor room, convinced that she is for cesarean section, and she goes back to the OPD. Okay. By the time the assistant would come, arrange the trolley, the anesthetist would come. Now, because the anesthetist has to go to the second call, okay, he would not wait for the gynecologist to enter the theatre, he will give spinal anesthesia and wait for the band. As soon as spinal is given, if the patient has not been properly preloaded or the wedge has not been given, the patient will land into shock in no minute. So if the chief surgeon is ready and washed up, the only indication, before even that 4-minute rule is, forget about that 4-minute rule. As soon as the anesthetist says that the pulse is not palpable, forget about draping and painting, just to take the incision directly and get the baby out. As soon as the baby is out, everything is going to settle immediately. That's point number one. Second, as in this case, because she was an abruption, yes, as Dr. Kalshetty has said, that 2 wide-bore needles, proper IV fluid replacement is mandatory for these patients. And see, any patient, for that matter, if Dr. Girish Kumthur is there in the crowd, he says, every patient is a potential litigator. So what I say, that every patient who is in labor is a potential bleeder. Okay. Yeah. So she may not have any predisposing factors. So we should be arranging at least 2 FFPs and 2 PCs for all patients in labor. The relatives will not mind. They will be more happy if it is not used. Okay. But if that is ready, I think the problems of resuscitation can be taken care of.
So this can happen in an operation theatre where all things are ready basically. We have the team working. But what if a patient collapses in the ward, in the room basically?
Or in the labor room, casualty.
Yeah. Earlier it has been described that wherever the patient has collapsed, whether she is on the bed or on the labor room, at that place only the baby should be brought out, which is practically not possible. But then there is a concept of what is called as crash cesarean section. Okay. The obstetrician shouts and gives the command. This patient is for crash cesarean section. Crash means when the patient is immediately shifted to the operation theatre, I'm sorry, pointing to you, the anesthetic should not ask, "Kiti vasta jevle, tula kai goळ्या चालू आहेत का?" No, nothing. Crash cesarean section is cesarean section. Whether consent has been taken or not, that is obstetrician's problem. Immediately the patient has to be delivered. That is crash cesarean section.
Yes. Now my next question is to Dr. Bakul Jagirdar. What preventive measures are necessary in an anticipated prolonged or a complicated delivery?
Anticipatory measures should start way before this catastrophe. That means during her antenatal period only. So I think there should be 3 levels of triages in our antenatal OPD. First level should actually kick in when the patient comes for the first antenatal visit, which will define her medical disorders, previous histories, especially like preeclampsia, obstetric related histories, like especially preeclampsia, if she had a deep vein thrombosis, if last time she had a bad obstetric history. All these patients, extremes of age group, then assisted reproduction, obesity, diabetes. This has to be labeled as a high-risk patient at the first visit itself, so that she can be segregated and followed separately from the other patients. The second level of screening again should happen in a low-risk category, who were from the first triage had come as a normal low-risk patients. The second triage should occur at around 30 to 34 weeks, where they will be again evaluated because preeclampsia will come up, GDM will come up, so many anemia will come up, so that normal group will also show some high-risk patients.
Yeah, very
so
true.
there has to be a severe, what we can say, we should be completely suspicious of her normality unless proved otherwise. So another trial should be when she actually comes in labor, and that the MEO score will, all of us are following that MEO's protocol.
Yeah.
So the score will give us her physiology at that point of time. But till then, it's when we actually diagnose that she is of score 4, 6 and above, it means that we have failed in her antenatal period so that she has reached to this stage.
Yeah.
So I think this monitoring will prevent them from landing up in a complication. Second thing is, say from the history, as obstetricians we have miserably failed, and such a delay should never occur from our part.
Very true.
Coming to further course of the patient was successfully resuscitated, LSCS was done and shifted to ICU on ventilator. She received the triple regimen, augmentin, dialysate with metronidazole. 24 hours later, fever developed and she became mild tachypneic. Initial ventilator settings were normally set. Fever continued with ensuing signs of sepsis, tachypnea, tachycardia, hypotension. WBC raised to 24,000 and there was 10% bandemia. Our next question goes to Akshay Chelani sir. How do we proceed with this case? What investigation should be sent and how do we find source of fever and choose the precise antibiotics?
Yeah, now how do we proceed with the case? I assume the cause of, when I treat this patient, I need to know she has a cardiac arrest actually. So what is that cause of a cardiac arrest? Whether it is shockable or unshockable. If it is shockable, the cause of cardiac arrest must be because of heart or something like that. If it is non-shockable, then we need to know what is the background that she has a cardiogenic shock or cardiac arrest. That is the first thing. Now this is almost after 24 hours after that.
Yes.
The counts are going high, she had a hypotension, tachycardia, tachypnea, that means something somewhere is miserably going wrong.
Yes.
So first, whether she is bleeding from somewhere, that I rule it out. I assume that the source is under control. Other things will rule it out, there is no infection, source is under control, the cause of cardiac arrest we know, and then we'll escalate the antibiotic actually. And this is septic shock actually, if you ask me, because she requires inotrope to control the blood pressure. Obviously, lactate is high, you have already sent the 2 blood cultures, 2 set of blood culture, that means we need to send the 4 bottles of blood, 4 bottles of blood culture. Routine investigations, I'll be a little more comfortable to send the procalcitonin and do the X-ray, do the CT, USG abdominal imaging to find out whether I have not kept anything in the uterus. And when we talk about this high WBC count leukocytosis, sometimes you don't know whether this is reactive because of the post
LSCS or whether it is post-cardiac arrest, post-CPR, or whether really infection. But given a choice that point of time, I will escalate the antibiotic. Now, which antibiotic you prefer, it depends upon in which scenario or in which hospital you are working, referred patients, how your flora is, whether virgin or either a lot of CR in your hospital. I'll be more comfortable to go with meropenem, and I'll add ticoblanin in case MRSA or something is high in my hospital where I work actually. Because she developed issues in the hospital after 24 to 48 hours. So whatever the hospital acquired, by and large I feel this ampicillin, gentamicin, clindamycin is good for which comes to the community. But once you develop hospital acquired, I'll either go for meropenem or any carbapenem like imipenem and doripenem.
Some guidelines have been given when to start BLI and carbapenems. Basically, if it is mild to moderate, you start with beta-lactam inhibitors. If it is severe, with carbapenems. Immunocompetent, BLI. Immunocompromised, carbapenems. Site of infection, if it is urine, SSTI, surgical site infection, intra-abdominal infection, with good source control, you can give a BLI, or otherwise severe bloodstream infection, shock, pneumonia, multi-organ failure, you better start with carbapenem, as sir has rightly said. Organisms, if it is E. coli, BLI. If it is CRE like Klebsiella, Enterobacter, then straight away start with carbapenems. MIC2 piperacillin tazobactam should be noted. If it is less than 8, considering UCAS break point, then BLI. If it is more than 16 or you have a borderline case with signs of resistance, then you better start with carbapenems. Along with this, you give supportive treatment, fluids 30 ml per hour, crystalloids basically. Sir, nowadays I think there is more emphasis on personalized resuscitation strategy, which have come in our recent trials basically. Classic and Clover trials. Urinary output target is around more than, at least more than 5.5 ml per kg per hour. Fluid status can be monitored by dynamic parameters like pulse pressure variation, systolic pressure variation, IVC, IBP. Checklist for post-LSCS spine, sepsis, sorry. Mean arterial pressure target should be 65. Perform passive leg raising before increasing fluids. You have to assess the fluid increase or cardiac status. Track lactate clearance every 2 to 4 hourly. It should be a decreasing trend, and capillary refilling time should be less than 3 seconds. Few years back we had in ICU that any patient who goes into shock and requires more than 1 or 2 vasopressors, we used to put an arterial intra-arterial line basically invasive for those patients to monitor. But the recent trial in November in NEGM Everdac trial, it shows that invasive BP monitoring has no mortality benefit, though in some selected cases you may try.
My again question to Dr. Dabde sir. Now this patient has settled down. Now in the post-operative period, she has developed a surgical site infection. And how would you control it, and what other thing would you have done in the perioperative period so that the patient would not have landed up in this surgical site infection?
Yeah, I presume that the surgery was finished fast, because when this patient, we have to save the fetus also, so going fast and come out fast.
Yeah.
So, but what happens when during surgery, lot of amniotic fluid and the blood, it goes into the paracoelic gutters.
Yeah.
Amniotic fluid, the best culture medium. If a human being can grow, any organism can grow. Okay. And it is impossible to drain out entire amniotic fluid from the peritoneal cavity.
Yeah.
But the paracoelic gutters must be lavaged or cleaned with the mop so that you keep as less as possible the blood or the amniotic fluid inside. And second is, when these patients, you know that they are likely to land into sepsis. So it is better to keep the abdominal drained before
that is
you
very
close
true.
the abdomen. Yeah. And as far as ICU's care is concerned, I would not raise a hemoglobin more than 8.5 or 9. Giving transfusions and achieving the target hemoglobin would make her more worse rather than be beneficial.
Yeah, that's very true.
One question to Anupam sir. After resuscitation, do we have to do immediate, we have to keep a probe and assess the cardiac status, because most of the time there is severe cardiac dysfunction. How much time in a normal patient does it require for the cardiac status to come up, or basically to normalize, and how should it be interpreted?
Nowadays in most of our ICUs, we have echocardiography. That is the best non-invasive way of measuring your ejection fraction or diastolic dysfunction, or you can even rule out pulmonary embolism. So this is the best way. Monitoring your pro-BNP levels has its own fallacies, because D-dimer and pro-BNP, because it gets altered in various conditions. So simple and most effective way of monitoring is by cardiac LV function itself.
Okay, so now we move on to the second case. This is a 30 years old female with 8 months amenorrhea. She presented to emergency department with acute onset of cough, chest pain, mild fever, breathlessness since one day. On examination, she had tachycardia, blood pressure was 140/90, right arm supine, RR was 40 per minute, saturation was 88% on room air. She was mildly febrile and she had mild pedal edema. No any medical disease previously. So what should be the approach to diagnose and manage such cases in a pregnant patient presenting with acute onset of dyspnea suddenly, no other previous history is there, and patient comes with this presentation? Over to you, Dr. Akshay Chelani sir.
Acute onset dyspnea in the pregnancy is whether it's cardiac, non-cardiac, pulmonary or non-pulmonary, or whether there is a renal issues actually. First you do a 2D echo, ECG, see whether there is a cardiac issues, whether sometimes it's possible pregnancy on 7th, 8th month you realize that there is rheumatic heart disease or mitral stenosis or something like that. 8 months I think I'll be do X-ray to see whether there is a pulmonary issues. If chest is normal, cardiac is normal, lung is normal, we rule out whether there is diabetic ketoacidosis or kidney failure, which will make acute onset breathlessness. So by and large, 2D echo, routine investigation, X-ray, ECG, anti-pro-BNP and other things, I'll rule it out to find out what exactly the cause of breathlessness.
Okay, so we do the basic investigations and we add focus to this, because nowadays it is very important to have a USG guided look. Question to Shah sir. What are the cardiac differential diagnoses to be considered in such patients? And please elaborate management of pregnant patients having valvular heart disease, especially severe mitral stenosis.
Patients who come with shortness of breath, the cardiac issues which we need to consider are, especially when the patient has good blood pressure, it is very less likely that it would be massive pulmonary embolism with a patient having a saturation of 88%.
Yeah.
Patient is febrile. So the other possibilities is peripartum cardiomyopathy is one possibility, because she had tachycardia. Peripartum cardiomyopathy anywhere occurs after 7th, 8th month. Previously it was called as postpartum cardiomyopathy, but now it is, last many years it is named as peripartum cardiomyopathy. That is one thing we should consider. Then the next thing which we consider is especially obstructive valvular heart diseases. Obstructive valvular heart diseases like mitral stenosis, aortic stenosis, hypertrophic cardiomyopathy, especially mitral stenosis is very commonly missed in the early part of the pregnancy. Either missed or the patient knows about the disease, and because of the family issues, they don't tell the doctor as well as the other family members that they have this issue. Valvular heart disease really carries very high risk, especially stenotic valvular disease. Now coming to particularly mitral valvular heart disease, if patient by echocardiography shows it is a mild stenosis, mild mitral regurgitation, hemodynamically stable with no pulmonary hypertension, then these patients can be managed conservatively. But if it is moderate stenosis, these patients are likely to go into pulmonary edema, especially in stages of labor or pre-pregnancy as the cardiac volume increases in second stage of labor. Regurgitation lesions do not produce so much of problem as valvular stenotic lesions. Mitral stenosis, if it is moderate, if it is severe mitral stenosis, especially if you detect in first trimester of pregnancy, don't do anything. especially give small dose of diuretic and if beta blockers if severe tachycardia is there or digoxin. If patient is ready, or we have to convince the patient to get ready, and if the valve is suitable for balloon mitral valvotomy, in second trimester of pregnancy, we have to do balloon mitral valvotomy, which has been one of the most life-saving procedures in many of these individuals. Here I want to tell you, we might have done many balloon mitral valvotomies during pregnancy. Sardesai madam presented a paper also in one of the conferences where we did plenty of patients and the survival is almost 100%. We did not lose a patient during pregnancy. And one case especially I will tell you, probably madam also may recollect. We did balloon mitral valvotomy. After 2 or 3 hours the patient delivered. Just immediately after balloon mitral valvotomy, patient was shifted downstairs and it had delivered. I think probably you also may recollect. So this is one of the most rewarding procedures done by individuals who have really good experience, because among all the cardiology procedures, one of the most skillful procedure is doing balloon mitral valvotomy.
Third trimester pregnancy, during delivery, if you diagnose mitral stenosis, how will the delivery be conducted? Basically, would you like to try for a normal?
No. See, basically, if it is mild mitral stenosis, you can go for normal delivery as well. If it is more than moderate to severe mitral stenosis, if valve is suitable for balloon mitral valvotomy, she has to undergo. If it is not suitable, if patient has mitral stenosis as well as mitral regurgitation, or patient has suspected LA clot, then the issue comes. Then these people mostly land up on ventilator and then we may have to deliver by cesarean section, and these patients after the delivery needs corrective treatment for valvular heart disease.
So we have the most common differential diagnosis in such patients. Patient can have sudden onset with pleuritic pain. The most likely probable diagnosis, if it is pulmonary embolism, you should go for a CTPA, 2D echo and D dimer values. Start low molecular weight heparin if the suspicion is high and there are risk factors. Fever plus productive cough, you suspect pneumonia. You can, in the last trimester, you can have X-ray with shield, CBC, sputum for culture sensitivity, safe antibiotics and supportive treatment. Hypertension plus edema plus crackles, pre-eclampsia or heart failure, you can start treatment accordingly and check blood pressure, urine protein, 2D echo. Wheeze plus history of atopy or known case of bronchial asthma, COPD, acute asthma, X-ray, ABG, clinically you have to assess and judge the patient. You have to do the staging basically. You can give salbutamol nebulization and prednisolone is safe. There are no contraindications. And if patient during delivery or just before delivery suddenly collapses and there are rupture of membranes, then you suspect amniotic fluid embolism. Now this is purely a diagnosis of exclusion, and you have to do the coagulation profile as well. You manage by 3C, that is CV support, control hemorrhage and correct coagulopathy in these patients. We go quickly through amniotic fluid embolism basically. It is a diagnosis of clinical suspicion, sudden hypoxia, hypotension and coagulopathy, and ruling out other catastrophes like pulmonary embolism or myocardial infarction. Hallmark is a rapid catastrophic consumption of clotting factors or DIC. Coagulation profile, fibrinogen is low, APTT, PT are markedly prolonged, D dimer is extremely elevated, and you can take help of Rotem or TEG if it is there. CBC, look for HB and platelet drop. ABG, profound hypoxia and metabolic acidosis because of collapse and shock. TROP-T may be elevated due to RV strain. ECG, echo, acute RV dilation and failure, severe pulmonary hypertension and D-shaped LV. X-ray may show non-specific bilateral infiltrates. CVC blood sampling, aspiration of blood from CV catheter may show squamous cells or debris of fetal origin. Sudden cardiorespiratory arrest over DIC and clinical onset during labor or within 30 minutes of delivery. No other explained cause, should suspect amniotic fluid embolism. The treatment basically is by the AOK protocol. Atropine is given to treat bradycardia and massive vagal response. Ondansetron to block the serotonin receptors. Ketorolac 30 mg IV to inhibit production of thromboxane and inflammatory mediators, as well as you have to prepare and give massive transfusion protocols along with fibrinogen replacement, cryo, tranexamic acid and prothrombin complex concentrate. Question to Dr. Akshay Chalani. Role of echo, basically these patients are very catastrophic, the mortality is very high, normally ventilation is very difficult in such cases. ECMO. So what is your experience in treating such patients on ECMO?
So whenever there is a cardiac arrest actually, in spite of now suppose you assume this is a fat embolism, pulmonary embolism, you did everything, but in spite of that the CPR is going on, in spite of that the patient is not doing well. So one of the options what we can explore is a VA ECMO actually. So what exactly it is done is extracorporeal therapy. You take out the blood from the heart, put into machine, till you recover, till to bridge to something. So till the bridge to recovery, till the bridge to the transplant, or till the bridge to something definitely you are going to do. Till that time you need to support. One of the options is a VA ECMO. So what exactly you do? You put a catheter, one is a femur, one is an artery and one is a vein. Take out the blood, oxygenate and send it to the body till the original system or original disease takes control. So that is a little bit not costly affair, but this is tedious affair. You require a skillful person, you need to insert the cannula, and costly affair. But if you see in last 6 to 7 years, particularly post cardiac arrest patient, this option has been explored, and in proper setup in the center where you do routinely ECMO. What routinely ECMO? You are doing more than 15 to 20 ECMO per year. You have skilled manpower. You require only contraindication is absolute. You require a lot of blood, a lot of anticoagulation while giving the VA ECMO. So if there is no coagulation issues, platelet count is reasonably okay, PT is reasonably okay, that point of time you can explore the option and you can save a lot of life actually. So in the context of acute fat embolism, massive pulmonary embolism, cardiac arrest, cardiogenic shock, you can explore option to use VA.
So AFE if not treated or not seen in or not diagnosed in time has a very high mortality, we all know. We move to the next case, case number 3, 8 months ANC female came with history of fever, headache, vomiting and altered consciousness. Since 2 days, admitted in casualty. During treatment, she developed seizures. General examination findings, patient was confused and disoriented, irritable, tachycardic, tachypneic, blood pressure was normal, saturation was slightly decreased 96% and mildly febrile. So question to our neurologist Dr. Pritish Agarwal, what neurological peripartum diseases can occur in such patients? What are the differentials and management strategies in such patients in view of very common presentations like CVT, eclampsia or PRES?
This is an 8-month pregnancy with fever, headache, altered sensorium and then convulsion. So the most common we would see peripartum cerebrovenous sinus thrombosis with a history of fever and an infective etiology in the form of meningoencephalitis should also be considered. I presume that it's a normotensive and not a PIH case. So stabilizing in the form of airway breathing because she had a convulsion in ER. So stabilizing her in the form of airway breathing and circulation, managing the fever part, and the imaging modality would be MRI brain with a cranial angio with a venogram. The beauty of this imaging modality is that it doesn't need a contrast. It is safe for the fetus, unlike the CT, which would have a radiation hazard. Only thing is that the patient needs to be cooperative, and in some very uncooperative patients, we would still plan for a CT head with a shielded abdomen, but MRI brain with this angio and veno remains the imaging modality of choice to evaluate these patients. Yeah, this patient underwent an MRI, there's an ill-defined lesion in the left posterior parietal lobe which is showing diffusion restriction. It is iso to hypointense on T1 and heterogeneously hyperintense on T2 and flare. and shows blooming on the GRE sequence, suggestive of a venous hemorrhagic infarct. And correspondingly, the lower panel middle image shows a MR venogram. Again, I repeat, it's a non-contrast study. It is a 3D time of flight images, which is available in all MRIs. So it's a non-contrast study which shows paucity of the left posterior parietal cortical veins. The pointer showing the same thing, suggestive of a venous hemorrhagic infarct due to a thrombosis of the parietal cortical veins. So treatment would be anemia. Pregnancy, we all know, is a hypercoagulable state. Anemia, dehydration, infections can definitely trigger these vascular events in the form of arterial strokes as well as venous strokes. So treating with IV fluids, and she had headache and vomitings and altered sensorium, denoting a raised intracranial pressures. So we'd like to manage that with keeping the head end about 30 to 40 degrees and anti-edema measures in the form of mannitol and anti-epileptics in the form of levetiracetam. The drug of choice is low molecular weight heparin, which needs to be started immediately. Even if it's a large hemorrhagic infarct, the guidelines recommend giving low molecular weight heparin, and it is preferred over the unfractionated heparin because it is not teratogenic and easy to administer.
Which anticonvulsants can be used safely in pregnancy?
Levetiracetam is the drug of choice, and after that lacosamide and sodium valproate with this 8 months pregnancy.
My next question will be to Dr. Dabde sir. At this point, what is the role of the gynecologist in monitoring the patient and fetal well-being and preparing for any eventualities?
Yeah. 8 months, 30 to 34 weeks.
Yeah.
Our neurophysician has settled the patient, put the patient on low molecular weight heparin.
Yes.
So I would not continue her pregnancy with this high dose of heparin she is receiving, because she could pose other problems for the placenta and the baby. So I would like to deliver her. Now, but she is already on low molecular weight heparin. So I would request him to shift to short-acting heparin.
Yeah.
Okay. And if it is possible for him, then unless there is an obstetric indication for C-section, I would deliver her.
Deliver normally?
Yeah.
Yeah.
Even though the neurological condition is stable?
Sorry, sir?
Even if the neurological condition is stable, we should go for delivery immediately in such cases?
In such cases.
So the per se CVT is not an indication for C-section. We would go as per the neurological status and the obstetric scenario at that moment. So a vaginal delivery can always be attempted in patients who are stable CVT, who are neurologically stable, and the obstetric criteria is good.
Only thing is that I would not ask her to bear down forcefully.
Yeah, exactly.
Yeah, I would shorten the
second stage of labor,
with either vacuum
and
or forceps.
if need, go ahead with some instrumental delivery also.
So in such cases, always we have differences of opinions. That is why we have a multidisciplinary approach. And the intensivist is a center in...
I just want to make a point.
Sure, sir.
Low molecular weight heparin, if you stop the dose 12 hours, 8 hours before also you can deliver.
Yeah.
The problem with conventional heparin is it is unpredictable.
It is very
APTT monitoring is required. When to stop? See what happens, you give heparin now. Unless it is on continuous infusion. You give conventional heparin and 0.4 BD dose. In many of the patients who have undergone wall replacement, we use it. There are so many number of patients we use it twice a day, and we have not found any problems if you stop 12 hours before. Major surgeries also, all the major surgeries anesthetists do just stopping 1 dose prior. That should be enough.
Yeah, but Dr. Agarwal has to permit me that long time period without...
Yeah, that is true.
Permitted, sir. Permitted.
I want to ask Anupam sir, because here we are using a therapeutic dose of low molecular weight and not the prophylactic. So do you think with that dose also cesarean section would be safe?
Yes. While major surgeries are done, all major surgeries are done by just stopping 1 dose.
Yeah.
And immediately after surgery you can start. All the surgeons, orthopedic surgeries are done It may be just a prophylactic dose, but still we can give it in patients with pulmonary embolism. Many times we give one dose, stop one dose, and then we can do the surgery and restart immediately after surgery.
Next question to Dr. Akshay Chalani. Yeah, sure.
Yeah, see, that's what I said. How long to continue the pregnancy is the question to be answered. But if the pregnancy has reached 34 weeks, fairly good enough for the fetal point of view. So there is no point in continuing the pregnancy beyond that, rather than inviting the problems of she being put on EPIN for a long time.
So, but patients anyway of say IVF or anything, they are on low molecular weight heparin. So I will just per se the patient having a CVT and giving the patient treatment for CVT per se shouldn't be an indication for termination of the pregnancy or getting the patient delivered if the patient is not in labor. Why can't we just manage the CVT of the patient? Say routinely has like.
No, what I mean to say, we have to take the patient to a salvageable gestational age as far as the fetus is concerned.
If this was 7 months, then
the guidelines also say that we can continue the pregnancy if there is no hemorrhagic event. In this case, clear cut, there was a hemorrhagic event and there was a venous infarct. So I think in such cases, it would be very dangerous to continue the pregnancy. Another thing is that when we go to MATMODs, maternal mortality meets, at that time, if somebody asks us a question, the panel asks us a question, why did you continue the pregnancy in such a scenario? We should be able to answer it correctly with a good literature backup.
Question to Dr. Akshay.
Role of intensives in treating. So you saw just now in our open
This is,
actually.
I think you have closed ICUs in Mumbai basically. It's here all open ICUs are there basically. Everybody comes and he gives his opinion. ये करना है, ये नहीं करना है. Intensivist is the center. है ना वो सब.
So by and large, when the things are very black and white, there is no problem that what we need to do. Now the question that what was asked. Now suppose the same lady who has 33 weeks and 35 weeks. 35 weeks, life is easy. After 34 weeks, you can do. Now, but before that, sometimes when there is a gray zone, what exactly you do, whether it is open ICU or closed ICU, we reach a consensus. So we do multidisciplinary team, we involve other people, like in addition to here, we'll involve neurosurgeon also because we don't know when he or she will be required. And at any point of time, to answer your question, when there is a, when the opinions are different actually, we take senior most person's opinion and ultimately at the end of the day, we all reach on the same page that this is the plan of action.
So further this patient deteriorates on day 3. GC is below 8. She is intubated and ventilated. Repeat scan shows bleed with midline shift of more than 6 mm. Patient worsens in next 24 hours with left pupil starting to dilate and decision of urgent decompression is taken.
So the question goes to Dr. Bakul. How should the pregnancy manage in such situation?
If she has not been delivered 3 days
till
back.
then, and if the fetus is normal or any other signs of fetal distress, whether you go for normal delivery or a C-section.
I think Damle sir has already discussed this issue. And if we are talking about this particular case, I don't have any interest of continuing this pregnancy because our neonatal unit is good enough to salvage this baby. So I don't want mother's systems to be put under a lot of stress.
Yeah.
Done. Question to Dr. Akshay. What are the ventilation strategies to be used in a pregnant patient?
When we ventilate the pregnant patient, first of all, the numbers what we treat for normal and non-pregnant and pregnant difference. Generally, we expect 92, 93 saturation in patients who are not pregnant, but in the pregnancy, we are more careful about both the bachu and mother, so we keep around 95 to 96. While mechanical ventilation, you have to be very sure that you anticipate the problem, diaphragm is going up, there is a edema around the airway, so you need to be, you just call the senior most person around who will put the tube in. Other than that, PCO2 we want around 35, not low, not less, not more than that. And you have to be double sure that while doing mechanical ventilation or putting the tube, there is no significant hypotension or any untoward event.
Okay. Weight gain, respiratory tract, mucosal edema and engorgement are there in pregnancy. So you should try to put a low number tube, 1 number below. Diaphragm is displaced upward by 4 cm and that reduces the FRC. Higher pressures to drive tidal volume are required to decrease chest wall compliance And lung protective ventilation with permissible hypercapnia has to be used very cautiously, especially the CO2 pressure should not cross 50 or 55. PO2, FiO2 should be maintained at all cost more than 150, because this gives us a SpO2 corresponding saturation of 94 to 95%, and RV protective approach in pulmonary embolism will come to that. Question to Dr. Santosh Kalchetti. What are the pharmacological profiles and safety considerations of various sedation agents used in pregnant patients?
I think this sedation patient on ventilator or off ventilator?
Obviously, on ventilator.
Okay, sir. So on ventilator,
Off, we know it.
Okay, we require patient should be calm, cooperative, and he should tolerate that endotracheal tube, and he should not fight with ventilator. Okay, so my first choice will be fentanyl and midazolam combination. Midazolam should be 2 to 5 milligram per hour we can give in Solapur these patients. Okay, fentanyl we can go up to 100 mics per hour. Fentanyl, and if patient is still hypoxic, very hypoxic, we need to knock him off with atracurium. Atracurium we can give 25 milligram per hour, 20 to 25 milligram per hour. Okay, you can give in constant infusion dose. And nowadays we are having new very short acting remifentanil also. We can use, so we can use 1 milligram diluted, 1 or 2 milligram diluted 50 ml, we can use 5 to 15 ml. So literally when we switch it off, the action goes within 20 minutes. So it is very good analgesic, we can have very good control. We are using it.
And we can use the agent which we are comfortable with this, because yes, according to A2B trial, all agents, any agent does not have an advantage over other. Yes, Dr.
Only issue I prefer little propofol because of this patient has continued venous thrombosis. To reduce the ICP little help, that is only advantage of propofol charges.
Right. So this is our last case, and we will try to finish it off quickly. A 36-year obese female underwent LSCS and discharged 10 days back, presented to ED with complaints of shortness of breath, chest pain, hemoptysis, palpitations and dizziness. She also had swelling of her right lower limb and tachycardia. Saturation was 76% on room air, chest was comparatively clear. She was in hypotension, ECG showed RV strain with ST depression, V1 to V4. Now this is, I think, a straightforward case. So how do we manage this probable case of pulmonary embolism? First question to Dobde sir.
Sir, how do you think the risk of thromboembolism can be mitigated pre-delivery? Can you recognize the high risk factors and how would you manage that?
Yeah, those who are at risk, we do give them prophylactically aspirin and low molecular weight heparin. So those obese patients, those patients with preeclampsia, before preeclampsia, before the onset only was started aspirin. Once the
considering the high risk factors, yeah.
If she is high risk, then I would. But once because pregnancy is a hypercoagulable state. Okay, so patient need not have any risk factor, but she can still present with such a finding of leg pain and all these features.
Second question to Anupam Shah sir. Outline the comprehensive management protocol for a patient with suspected pulmonary embolism in pregnancy and otherwise also.
Pulmonary embolism occurs in patients, pregnant patients, especially it is more common during last trimester, It is known in first and second and postpartum period up to 3 to 6 weeks because of the Virchow's triad. The fetus compresses the vena cava, there is a thrombosis, hypercoagulable state is there. So all the factors predispose them to develop pulmonary embolism. In this patient, its most likely diagnosis is pulmonary embolism. Now, fortunately, in most of the setups, we have echocardiography. All critical care people are doing echocardiography, intensivist people are doing echocardiography. So the diagnosis is very obvious if it is a massive pulmonary embolism. If we have massive pulmonary embolism with RV dilatation, RA dilatation, severe pulmonary hypertension, the diagnosis is almost obvious. Then we get some blood tests done in the form of D-dimer and troponin T. The best investigation in this case, and most of the setup where now most of the reasonably bigger setups it is available, is CTPA. VQ scan is not so easily available. CT pulmonary angiography, even in last trimester of pregnancy, is the investigation of choice. If the patient has massive pulmonary embolism, like in this case, patient has severe hypotension, shock with RV strain, with tachypnea, shock and failure, circulatory failure. These patients we have to thrombolize. There are two types of thrombolytic agents. One is fibrinolytic sensitive and other one is streptokinase, urokinase, which we use. Because of the speed with which fibrinolytic sensitive agents like tenecteplase, altiplase acts, it is better to give these type of drugs. There will be always definitely an increased risk of bleeding, but this is a life-saving procedure and we have seen many patients recover immediately.
Sir, while doing echo, which is the best sign to see for pulmonary embolism, or there is no such single sign?
See, you have to take all the things together. When you are doing a bedside echo, you may not have tissue Doppler imaging, you may not have many things. The best thing is look for RA-RV dilatation, D-shaped LV and calculate the pulmonary artery pressures. It gives you almost a reasonable diagnosis of pulmonary embolism. Now, pulmonary embolism can be divided into different grades, low, intermediate and high risk. High risk also is again divided depending on the shock. If patient has shock, we have to give thrombolysis to these patients.
So this is the treatment protocol as sir has rightly mentioned. We have scoring system also, BOA score for P related, PACES class for all cause mortality, and depending on the severity and raised cardiac biomarkers and RV dysfunction, you have to decide the treatment. So treatment strategies for acute severe PE, you have rescue thrombolysis, class 1 recommendation, surgical embolectomy. If that fails, class 2A recommendation, treat severe hypoxia and hypercapnia, treatment of RV failure by optimization of RV preload, pulmonary vasodilation and vasopressors. Noradrenaline is preferred in such cases. Mechanical ventilation, RV protective ventilation with low tidal volume, plateau pressure of less than 30 and moderate PEEP, or in pulmonary embolism PEEP is not required basically, and limit the transpulmonary pressures.
Just one thing I want to add to this. Mechanical embolectomy, like catheter based embolectomy, is another treatment of choice which few years back it was not recommended. Now to prevent bleeding, we can take a pulmonary artery catheter and aspirate, and the results are showing very good results. Possibly in next few years we may have much better catheters which help us to aspirate all the thrombus, and that will be given as a class 1 indication.
Right, sir.
We are doing in our setup regularly.
Right. Thank you, sir. VT is associated with high risk of recurrence after discontinuing anticoagulants. Recurrence rate of 30 to 40% in patients who stop anticoagulation within 10 years after an initial event. Males 41 and females 29% as per meta-analysis. So persistent thrombus imaged on CT scan does not predict recurrent PE. Patients with an estimated recurrence risk of less than 3% per year should receive time-limited and anticoagulation therapy, and those with more than 3 to 8% risk should continue indefinitely, or if there is a second event of pulmonary embolism, those patients are also candidates for. Sir, can you comment on IVC filters? I just skipped this.
Yeah. See, basically IVC filters, many of them use left and right, but IVC filters has its own problems. IVC filter is a foreign body in the inferior vena cava. There are two definite indications to put IVC filter as per all scientific data and even ACC recommendations. One is patient you cannot give anticoagulation, or patients who are on anticoagulation in spite of that is having recurrent pulmonary embolism. The third indication is you can use IVC filters transiently for life-threatening situations, like patient has fractured femur, he has fully loaded thrombus, you put IVC filter, you have to remove within 3 months. If you don't remove within 3 months, you have to give lifelong anticoagulation, and there are some patients, couple of patients whom I have seen, whom they have put IVC filter or we have put IVC filter, and they have developed IVC total filter thrombosis and they have developed bilateral pedal edema. So IVC filter has to be used judiciously when required, and retrievable IVC filters have to be used in specific situations.
So with this, we finish the panel discussion. We are open to any questions or any add-on suggestions.
I want to ask Anupam Shah sir, many of the times we don't get such full-blown picture. Many of the time we don't get patients with such a full-blown picture of DVT. In pregnancy, because she's already having edema, she's already having some pain, crampy pain in the lower limbs, it is very kind of a tricky situation. But if she shows some signs, say she has fever, she has tenderness, she has pain, but she does not show any thrombosis on the ultrasound or any diagnosis is not done by any investigation, only on suspicion should we start her on
No, if we have documentary evidence. See, now if you take the incidence of pulmonary embolism in patients on pulmonary embolism and you do Doppler, 40% or 50% we will not have deep vein thrombosis because already thrombus would have gone up. And if clinically and Doppler wise there is no evidence of thrombus, scientifically we are not justified just for swelling giving any anticoagulation because that doesn't serve the purpose. You are increasing our risk by giving anticoagulation. If you have documentary evidence, then only we should give it. If we suspect intermediate or low risk of pulmonary embolism, then these are the situations. If your clinical suspicion is strong, if there is no DVT also, you can give anticoagulation.
So DVT in present pregnancy, the patient has been treated. If the patient also had a pulmonary embolism, so what precautions now should we start empirical treatment to the patient in the next pregnancy?
Yes, that's very important and pertinent question. Suppose a patient has pulmonary embolism in the previous pregnancy or DVT. More likelihood that as such pregnancy increases the risk threefold of developing DVT and pulmonary embolism. Once already patient has history of pulmonary embolism, next pregnancy the risk increases significantly. So we have to give low molecular weight heparin for these patients, prophylactic dose, not a therapeutic dose, continuously because the risk increases definitely.
Okay, I think we conclude. So thank you everyone.
That was truly a dynamic and practical discussion. I request Dr. Pratiksha Patil ma'am, Dr. Ramchandra Bindu sir, Dr. Sujata Kulkarni ma'am, and Dr. Ketki Joshi ma'am to felicitate our moderators and panelists. Those physician members who have yet to collect their life member certificate can collect it from the counter. I request everyone to proceed for lunch and we can reconvene for the afternoon session at 2:30 p.m. I request everyone to proceed for lunch.
We now move forward with the afternoon session. Sarcopenic obesity is an emerging and often under-recognized condition, especially in Indian women, combining reduced muscle mass with increased fat, leading to significant metabolic risks. I invite Dr. Aniket Inamdar to deliver this session. I request our chairpersons of this session, Dr. Anjali Jamma, Dr. Nitin Rane, Dr. Anjali Shivpuje, and Dr. Nishikant Maski to grace the dais. Dr. Aniket Inamdar is a consultant physician at Samarpan Clinic, Maharashtra with MBBS DNB, MNAMS, FIACM, FISCM qualifications. He has presented over 51 original research papers at international conferences and has won several awards, including the RSSDI Rising Star Award and ACP India Educator Award.
Yeah, good afternoon. After the delicious lunch, let us move on to some serious and important topic. In our day-to-day clinics, what we are seeing, what we are treating is not just the obesity. We are treating something more serious, something more difficult. We have patients and we see the patients who are overweight, but they are malnourished in terms of muscle. So let us delve into this entity of sarcopenic obesity, where fat is slowly replacing the strength and it is creating a metabolic crisis that our Indian women are facing today. So what is sarcopenic obesity? Sarcopenia is a word Greek origin where sarcos means flesh or muscle and penia means loss of function. So sarcopenia is a loss of function, muscular function, loss of muscle strength and muscular performance. And when it is combined with obesity where there is excess adipose tissue deposition, then this concurrent term is called as sarcopenic obesity. So what is the global epidemiology says? The prevalence is rising tremendously. So adult more than 65 years of age, rising prevalence is there. Studies have shown almost 10 to 15% of the people are having this condition, sarcopenic obesity. Particularly in our region of the Asia Pacific, where women particularly more vulnerable to this entity after the menopause because of so many hormonal disturbances that they undergo. We will go to these hormonal changes in subsequent slides. So what is the different and unique Indian context? So we call this as a YY paradox. Yabnik and Yudlik has described in Lancet paper 2004, where two people having similar BMI, where they have the similar 22.3 and 22.3, but they have different fat composition and different muscle composition. So have the same BMI, but one is having so much of muscle mass and very less amount of body fat, but the same person with the same BMI is having high amount of body fat, but very less amount of muscle. So that is called as YY paradox. Why? Because Indians, as South Asians, we have unique the Indian phenotype, that we call it as a thin fat phenotype, where we have a tendency to deposit excess amount of adipose tissue still when we have lower BMIs. So at a lower BMIs, we tend to deposit higher amount of fat, which is metabolically dangerous. So if you see what is the global context that shows that 2023 meta-analysis has shown the prevalence of sarcopenia 10 to 16%, whereas if you see the Asian studies and recent 2024 Indian studies, the prevalence is almost 28%. So you can imagine how much this typical concurrent entity like loss of muscle mass and loss of muscle strength along with obesity is there prevalent in our Indian population. So sarcopenia is prevalent almost 10 to 43% in elderly patients, and rural area is again more, you can see the difference compared to urban areas. People in women in especially rural areas, they are more having this clinical entity, and almost 25% of the sarcopenic patients have obesity. So why it is a silent metabolic crisis? You have sarcopenia on one side and you have obesity. So loss of muscle and excess of adipose tissue. This is again a concurrent combination for causing insulin resistance. And when you have high amount of insulin, that is again catabolic in nature. And what it causes oxidative stress on the body, especially on the muscle. Mitochondrial dysfunction occurs. So many inflammatory cytokines release into the body, and that is again causing the metabolic crisis that we have. We see a lot of high amount of insulin resistance, high amount of fasting, impaired fasting glucose, metabolic syndrome, diabetes, and all sorts of cardiovascular diseases. And we often attribute these common changes to the aging. So sarcopenia is not the disease of aging. It is, sarcopenia is now classified under international classification of diseases. It is a separate muscular disorder. It is not just the normal aging process. So don't just think that patients are getting wasting on the muscles. They don't have that much of muscles. Just don't blame it to the aging process. That is the problem of poor dietary choices and less of muscular strength exercises that they undergo, especially in the later period of life. So women are specifically vulnerable to this particular entity. So why? Because women face unique challenges, especially when they attain menopause. There are certain changes, hormonal changes that occur at the time of menopause. So there is decrease in amount of estrogen, progesterone, growth hormones, and insulin-like growth factors. They decrease typically after 45 years of age, and they start causing lot of adipose tissue deposition in the body, and these adipose tissue again release inflammatory cytokines that again contribute to the metabolic crisis that our women are facing today. And the second most important point, when you compare men with women, especially after 45 years of age, women do have a greater tendency of great fat mass increase with age compared to the men, and where they also have lower baseline muscle mass compared to the men, especially in later part of life. So what are the risk factors for sarcopenia? Again, advancing age, early menopause, and we all see as physicians, gynecologists, we do often see now the patients with early menopause, there is a higher prevalence of early menopause in Indian women, and a lot of factors are contributing to it. Again, vegetarian diets, high carbohydrate diet, poor in protein, again is one of the contributing factor for the sarcopenic obesity. Rural residents, again highly prevalent in India. Post-menopausal status, as I said earlier, that hormones predominantly contribute to the muscle loss which is happening at the time of menopause. Physical inactivity, hardly we do any kind of physical activity in today's life. And these are the factors that cause loss of muscle strength and mass and excess adipose tissue deposition, especially in the 45 to 50 years of age. And these factors again lead to loss of muscular strength and muscle mass. You know, muscle is the strongest regulator of glucose metabolism in the body. And we hardly use this glucose metabolizer. So we need to use it. You know, we just had a lunch, and what is the most significant glucose regulator in the body after, especially in the postprandial state? That is the muscle. Muscle causes glucose uptake almost 80 to 85% in postprandial state when they stimulate the GLUT4 transporters in the muscle. So that is the only single most important factor to reduce your glucose levels postprandial state. So use it. We hardly use muscles. We should start using muscles. Let me show you how to use muscles just by sitting. You are all just sitting. Start doing soleus push-ups. You can do it. You can do it. And once you activate that soleus push-ups, you hardly take any time, but you will increase your muscle mass, muscle strength. You will utilize this biggest metabolic regulator in the body, and you can immediately drop your blood sugars down. You can start using it daily. So this is one of the biggest factors. We must start using muscles regularly and consistently. So what is sarcopenia? So this is a healthy muscle mass where there is a bone in the center and which is surrounded by the muscle and fatty tissue. Very less amount of fatty tissue is there. But when it is lost in sarcopenic patients, we see great amount of fat adipose tissue deposition, very less muscle. So muscle is going on decreasing and the bone remains the same. So it is again the muscular dysregulation, chronic low-grade inflammation which is caused by interleukin 6 and TNF-alpha, and mitochondrial dysfunction, which is again because of mTOR pathway, which is again very significant. So as I said earlier, during the menopause, what happens? The estrogen comes down, the progesterone comes down, and even the testosterone comes down. And that leads to reduced satellite cell proliferation, impaired muscle regeneration, and ultimately it leads to increased visceral fat deposition. So it is a chronic inflammatory state. Sarcopenia is not just loss of muscle. It leads to state of chronic inflammation and oxidative stress, which again put our Indian women to a very high risk of cardiometabolic diseases. So really what happens in this case, whenever you have excess amount of adipose tissue, it leads to pro-inflammatory cytokines, increase in leptin, decrease in adiponectin, and that leads to again mitochondrial dysfunction, increase in the oxidative stress, and ultimately what it leads to decreased metabolic rate and visceral fat accumulation, ectopic fat accumulation, and insulin resistance. And insulin itself, when we have lot of insulin on one side and there is no insulin acting because of insulin resistance, you go into the state of catabolism, and that again creates a state of muscle loss and muscle atrophy. So the biggest factor which is responsible for sarcopenia, the first is decreased physical activity, then inadequate protein intake, under eating, inadequate calorie intake. If we don't have the balanced amount of diet, vitamin D deficiency is almost universal in Indian patients. Again, release of pro-inflammatory cytokines that I just discussed, especially the TNF-alpha, interleukin 6. Metabolic acidosis is there because of low-grade chronic inflammatory state, and decreased amount of certain hormones like insulin-like growth factors, and especially the growth hormone. So that again leads to sarcopenia, and certain other factors like long-term glucocorticoids use, decreased testosterone use, and broader spectrum, we are calorie dense but nutritionally poor people. So poor choices, poor dietary choices are again leading to this condition of sarcopenia. So what are the metabolic consequences? Once you have excess amount of adipose tissue in the body and less amount of muscle or muscle mass, then it creates a perfect combination for a great storm like metabolic and cardiovascular diseases. So those people who have the sarcopenia have a higher chance of type 2 diabetes, almost 3 times higher chance of type 2 diabetes mellitus. Insulin resistance is very much there. Dyslipidemia, again the typical Indian phenotype where we have the high amount of triglycerides and low amount of HDL, and they are again very much prone to the metabolic syndrome. You just know, once you have the sarcopenia with obesity at around the 45 to 50 years of age, what it does, so a lot of visceral fat is there because of excess amount of adipose tissue, and when you have excess amount of visceral fat, that leads to endothelial dysfunction. So endothelial dysfunction will occur in each and every vessel of your body, and that leads to again cardiovascular diseases, especially through the mechanism of atherosclerosis. And sarcopenic obesity is the strongest predictor of CV events in Asian women. See, this is, and we can modify it. It is a preventable risk factor. It is a modifiable risk factor where we just have to start doing some kind of exercise, especially the strength training along with the good dietary choices. We can prevent this dangerous combination, which is the strongest predictor of CV mortality in Indian women. So what is exactly happening? Let us see. So you have because of lack of exercise, you have obesity and poor muscle mass that leads to insulin resistance. You have on one side you have excess amount of insulin because of hyperinsulinemia, and you have insulin resistance. So what is it causing? It is causing a catabolic effect on the muscle, ultimately leading to the muscle atrophy. Muscle breakdown is there, and that the excess amount of adipose tissue, which is generating the lot of inflammatory cytokines like TNF-alpha and interleukin 6, that is again causing increased amount of muscle breakdown, again muscle mass, and that is again leading to the lack of physical activity, again obesity. So this is a vicious cycle. You need to break it somewhere, and once you understand this, we can definitely break it. So how the patient present with the clinical symptoms? Patients usually say, I can't walk upstairs, I can't walk even 10 stairs, I can't walk far long, I can't carry weights. They complain of fatigue. So these are the common symptoms. We need to identify the symptoms and screen them and then start treating them. So what are the functional impairments? The increased amount of risks and fall. You can see the fractures. People often complain that I don't have any problem, but she suddenly fell down. It is not a sudden episode, it is slowly and gradually building the loss of muscles and excess amount of adipose tissue that is making them poor in the strength, and that is what is causing the risk of falls and fractures. So physical disability and frailty, reduced quality of life, and ultimately it leads to loss of independence in daily activities. And the patients who have the sarcopenia are actually having lot of anxiety, depression, and other psychosomatic disorders. A lot of my gynec friends and colleagues, they often have experienced a lot of mental health issues, especially during the period of menopause. And it is not just because of the hormonal changes, it is because of the loss of muscle strength and muscle mass. Because once you have good amount of muscle in your body, that muscle releases myokines like irisin, which is a potent anti-inflammatory, antioxidant, and again it boosts your psychology also. So once you lose muscles, you don't tend to have poor mental health. So poor mental health is not just related to the hormones, it is related to the muscle also. We need to understand this. So what is the clinical screening approach? So we understood now how it causes, what are the risk factors, and what are the pathophysiology. Let us see how to screen them. So we can use this SARC-F questionnaire. I will elaborate in subsequent slides, and then routine measurements like BMI, waist circumference, calf circumference, and finger ring test. So this is the latest algorithm in 2024, which shows that how to screen. So whom to screen? Again, all people above 60 years of age, all patients with chronic comorbidities, especially diabetes, hypertension, obesity, with patients with chronic inflammations. How to screen them? You can have this digital handheld dynamometer, muscle mass, calf circumference, you can measure it, and some tests like 5 times sit to stand test and gait speed we can do. DEXA is the gold standard in screening, and we can use now the bioimpedance analyzer, which is very effective, and use it, and then we can go on treating them. So this is the way we can screen them. What is the SARC-F questionnaire? It is about strength and high sensitivity in Indians, so difficulty in lifting up 4.5 kg, assistant needing difficulty in walking across the room, R for difficulty in transferring from the chair, rising especially, climbing difficulty in climbing 10 stairs, and falls. What are the number of falls in past year? So how do we assess this SARC-F questionnaire? So again on the scale of 0 to 2, you have to ask all 5 questions, and if the score is more than 24 or equal to 24, the patient is diagnosed to have sarcopenia. So this is the again Indian cutoffs for sarcopenic assessment. Gait speed less than 0.8, grip strength again different for men and women. 5 times chair stand test, where we have to see what is happening. What is a chair stand test? It is a simple test where we just have to ask the patients to sit, cross the arms, and ask them to sit 5 times. So in how many minutes that patients can demonstrate this activity, it tells how much muscular strength they are having, especially in the lower limbs. So again, the diagnostic assessment, with, as I said earlier, the DEXA and the BI is usually used, and muscle strength with the hand grip we can use it, and physical performance. Diagnostic, again, obesity we know, BMI, but BMI is difficult to distinguish between the lean mass, lean body mass, lean muscle mass, and adipose tissue. So just don't use BMI for all sorts of testing. We need to have BIA for a critical assessment. So this is Asian working group criteria, which tells us how to diagnose it. So screen it with the SARC-F questionnaire, and if the positive probable sarcopenia is there, then assess them with the help of muscle strength, grip strength, chair stand strength that I described. So if the muscle strength is low, then suspected sarcopenia. Radiological confirmation again by the muscle mass, measure it. Again, the muscle mass is low, it is a confirmed sarcopenia, and confirm the severity with the gait speed, and then we have to treat them accordingly. So what are the management principles? One side you have to have muscle strength or resistance training, and other side you need to have balance the carbohydrate with the protein. So that is the must, that is must for everybody. So it's a multimodal approach. Resistance training is must, adequate protein intake should be there, and it should be individualized. Indian woman, the traditional Indian woman, what we used to do, hardly anyone does that. So these all sorts of activities are were involving strength training, so grinding. See, all traditional Indian women used to have some kind of strength training in earlier days. But as we advanced, as our modern kitchen has totally transformed the women, so it has totally made them poorer in muscle. And that is one of the significant factor for sarcopenia. So we need to intervene with the exercise, especially the progressive resistance training 2 to 3 times a week. Flexibility and balance training should be there, 15 minutes. And why the resistance training works? Because it works, you can just use the elastic bands, body weights, major muscle groups that to be involved, legs, back, chest and arms, 8 to 10 repetitions and 2 to 3 sets per exercise. Again, the nutrition is very important, where you need to increase the protein intake, especially 1.2 to 1.5 kg per kg body weight protein intake should be there, and distribute the protein across all meals. People often make mistake of just eating breakfast rich of proteins. Don't do that. You have to have protein distributed equally among all your meals that you are going to have. And essentially, amino acids, especially the leucine. Leucine is very important because it is a branch chain amino acid and which increases the mTOR pathway in the muscle and which ultimately increases the muscle synthesis and decreases the proteolysis. So that is the importance of leucine, and leucine is there rich in our vegetarian diets also. So don't ignore the leucine. We can use the paneer, Greek yogurt, milk, soy-based proteins are good enough, legumes, dal, chickpeas and lentils, and in terms of non-vegetarian diet, eggs, chicken, fish or non-vegetarian foods also we can use. So we need to have a balanced diet of proteins, essential amino acids which increases the muscle mass. We just don't neglect the vitamin C, omega-3 fatty acids and probiotics because it produces short-chain fatty acids, amino acids, which regulate the muscle homeostasis in the skeletal muscle. This is one of my recent paper where we compared head-to-head meta-analytical study, and this has been published in a Spanish international paper where we debunked the paradox about the vegetarian protein, where vegetarian protein is often blamed for poorer protein content, but it is not. If we combine, if we eat good amount of vegetable protein, it is non-inferior to the animal protein. So what we need to do? We need to do the resistance training which decreases the body fat, increases the muscle mass, protein and exercise, both should be combined together, and that leads to ultimate our goal. So what are the key takeaways? Sarcopenic obesity is growing silent crisis in India, and we need to start screening all women above the age of 45 with central obesity. Screen them, test them and advise them good healthy diet. Women particularly vulnerable to the post-menopause. Combined protein-rich diet and exercise, especially the strength training, is the most effective, and early screening and intervention is crucial. So this, we just had a good amount of good, delicious lunch. And lunch is made by, again, Annapurna. In our Shastras, it is said that Annapurne Sadapurne Shankara Pranavallabhe Jnana Vairagya Siddhyartham Bhiksham Dehi Cha Parvati. So our mother, our wife, our sister is Annapurna. We need to transform her from Annapurna to Stri Shakti Swarupa. Jayanti Mangalakari, Bhadrakali Kaparni, Durga Kshama Shiva Dhatri, Swaha Swadhanumastate. So we need to transform our Stri Shakti from Annapurna to Shakti Swarupa, to proper balanced diet with lot of proteins and strength training. And this is what we need to build our divinity in our society. Thank you for patient listening.
Thank you for this eye-opening talk. I think we should include sarcopenic surveillance or survey for every menopausal women.
Yes.
And one more question I want to ask, what is the role of ALM, appendigeal lean mass, to calculate sarcopenia?
So actually, what the guidelines right now say, the Asian working woman, so you screen them. You can simply use this questionnaire, and when you use this questionnaire, then we can go for a muscle mass testing, especially in terms of the DEXA scan and BIA. So that will tell you the lean body mass, what you exactly said, muscle mass, because the BMI hardly distinguishes between, BMI will tell you the wrong assessment of mean muscle mass. So that will not tell you whether this particular muscle, the patient is having good amount of muscle or not. Just having good amount, normal weight, that doesn't mean that that patient is having good amount of muscular strength. So we need to assess this mass in terms of the BIA test or DEXA scan, and that is the gold standard for assessing the muscle mass.
Maximum muscles are in
Yeah.
appendages only.
Yes.
You rightly said Annapurna should become Stri Shakti.
Yes.
Thank you for it.
Thank you.
I think so with the advent of these new drugs, weight loss drugs that we are taking now, the analysis part is very important, because when a person walks to your OPD and you give them an analysis that so and so is your fat percentage in your body, or the fat mass in your body, the protein mass in your body, and you can easily target the protein content, and you can give them a clear pathway on the way that what amount of fat loss is expected in you. So that becomes easy, and the grip strength analysis is a simple OPD procedure. You can just tell them when the patient comes for a follow-up, like it's like getting the sugars or hemoglobin of the patient done. So a quantitative assessment helps in evaluating the patient, and the patient is also kind of motivated to do those things. So that is also very helpful to get a routine BMI, the analysis of the scan done, impedance, that helps very much for the patients.
Sir, as you said rightly, because we are living in an era of GLP-1 receptor agonist where weight loss is a significant factor. But what happens, because even step 1 study with the semaglutide has clearly shown that even with weight loss, there is a modest amount of muscle loss which is happening in these patients. So whenever you are putting patients on GLP-1 receptor agonist, we have to advise them to good amount of protein and strength training. If they don't do it, then higher amount of chances that they will lose the muscle. I will just tell you the simple test. You can measure whether you are having good amount of muscle or not. So are you interested in that? Just 1 minute test. And just by walking you can do that. So that is called as finger ring test. You have to just sit and do like this. And put your both in a straight 90-degree angle position and measure the thickest part of your muscle. Just do this and on the top thing. Measure it. Thickest part of the top. If your top muscle, the circumference is less than the finger ring, then you are having poorer muscle. And if it is snugly fitting it, then you are having adequate amount of muscle. And if you are having more, it is very hard to press those calf muscles, then you are having good amount of muscular strength. So do it so you can increase the muscular strength, because muscle is the strongest metabolic and regulator in our body. Thank you. Thank you. Thank you.
Thank you, sir, for bringing attention to this silent metabolic concern. I request the chairpersons to felicitate our speaker. I request Dr. Sharmila Gurram and Dr. Mukund Ray to felicitate our chairpersons. I now invite Dr. Sanjay Deshmukh from Pandharpur, who is contesting the MMC elections, to kindly address the audience.
गुड आफ्टरनून एव्हरीवन. मी काय तुमचा जास्त वेळ घेणार नाही आहे. तर अकॅडमिक्सबरोबर पॉलिटिक्स पण थोडंसं इम्पॉर्टंट आहे, कारण आजकाल तुम्ही बघताय की प्रॅक्टिस करणं एवढं सहजासहजी इझी राहिलेलं नाही आहे. तर MMCच्या इलेक्शनसाठी मी उभा आहे यावर्षी. गेल्या वर्षी इलेक्शनमध्ये तुम्हाला माहिती आहे 3 एप्रिलला इलेक्शन झालं होतं, परंतु सुप्रीम कोर्टाने त्याला स्टे दिला होता. तर यावर्षी 26 एप्रिलला इलेक्शन ड्यू आहे आणि हे सगळ्यांना वोटिंग VM मध्ये जाऊन करायचं आहे. 2 गोष्टी तुम्हाला या निमित्तानं सांगायचं आहे की MMCमध्ये आपल्याला कन्फ्युजन बऱ्याच लोकांचं असतं की MMC आणि IMA. तर दिस इज नॉट ॲन IMA इलेक्शन, दिस इज MMC इलेक्शन, महाराष्ट्र मेडिकल काउन्सिलचं इलेक्शन आहे. आणि ही बॉडी जी गव्हर्नमेंटची बॉडी आहे त्याच्यामध्ये आपले डॉक्टर रिप्रेझेंटेटिव्ह जे आपण रिप्रेझेंट करतो ते काहीतरी आपला माणूस असणं गरजेचं असतं. कारण तुम्हाला प्रत्येकाला काही प्रॉब्लेम येईलच असं नाही, पण ज्यावेळी येईल त्यावेळी MMCमध्ये जर तुमचा स्ट्रॉंग किंवा जवळचा माणूस कोण नसेल तर इट इज व्हेरी डिफिकल्ट. तिथं बऱ्याच गोष्टींना आपल्याला त्रास सहन करावा लागतो. आणि आता सध्या मी MMC रिप्रेझेंटेटिव्ह म्हणून सोलापूर डिस्ट्रिक्ट निग्लिजन्स जो कमिटी आहे त्याच्यावर मी सध्या कार्यरत आहेच. आणि आता रिसेंटलीच माझी PCPNDTची लीगल ॲक्शन कमिटी जी आहे त्याच्यावर पण निवड झालेली आहे महाराष्ट्र स्टेटची. तर मी VM मधूनच पासआउट झालेला आहे. 85ची माझी बॅच आहे आणि साऊथ झोनमधून मी एकटाच रिप्रेझेंट करतो या इलेक्शनमध्ये, MMC इलेक्शनमध्ये. साऊथ म्हणजे सांगली, सोलापूर, सातारा आणि कोल्हापूर. तर सगळ्यांच्याकडून मला वोटिंगची फार गरज आहे, कारण या वोट्सवरच म्हणजे ह्या साऊथ झोनच्या वोट्सवरच मी इलेक्ट होऊ शकतो. तरी सगळ्यांनी मला वोट करावं आणि तुमचा माणूस एक आपला माणूस VMचा माणूस म्हणून मला MMCला पाठवावं एवढीच विनंती करतो. 26 तारखेला VM मेडिकल कॉलेजमध्ये वोटिंग आहे. सगळ्यांनी जावा आणि प्लीज वोट फॉर मी. थँक्यू.
Thank you, sir, for your kind words.
थँक यू. जस्ट मिनिट. मी डॉक्टर सुदेश जोशी, ऑब्स्टेट्रिक गायनेकोलॉजिस्ट, पंढरपूर. मी इलेक्शनला उभा नाही आहे. मी देशमुख सरांना गेली 30 वर्षापासून ओळखतो. तर आपला माणूस जिथं असणं गरजेचं आहे त्यासाठी डॉक्टर देशमुख अत्यंत योग्य व्यक्ती, अजातशत्रू व्यक्तिमत्व आहे. आणि आपण डॉक्टर म्हणून, अकॅडमिक्स म्हणून आपल्याकडं खूप क्वालिफिकेशन्स असतात, परंतु जिथं MMCला जावं लागतं तिथं फक्त नुसतं डॉक्टर असून चालत नाही. त्यासाठी लागणारे जे गुण अवगुण जे काही लागतात ते सगळे त्यांच्याकडे आहेत, त्यामुळे त्यासाठी ते योग्य माणूस आहे.
Now we move on to a panel discussion on the recent treatment modalities in pregnancy. With constant advancement in medicine, staying updated on these strategies is crucial to ensure evidence-based and safe care during pregnancy. I invite our moderators, Dr. Sujata Kulkarni, Dr. Ketki Joshi, and our panelists, Dr. Ravindra Gundeli, Dr. Harshal Kakre, Dr. Deepak Gaikwad, Dr. Lata Patil, Dr. Vijay Pawar, Dr. Mukund Ray, and Dr. Nitin Rane on the stage.
Good afternoon, everyone. After delicious meal and superb lecture by Dr. Inamdar, we are at the last segment of our program. We welcome you all the team. Today we will focus on real OPD scenarios and how multidisciplinary approach helps us to manage them better in daily clinical practice. Our goal is simple: practical solutions and clear take-home messages. So let's move from theory to real life practice. Let's start the first case.
Good afternoon to all. I welcome all the panelists today. These are the people we always think of when we face difficulties during the practice. So they are there to help us every time. So the first case is, this is a primigravida with 6 weeks of pregnancy, and she presented with TSH of 0.01 on her routine investigation. Usually during the first visit, we do a routine CBC and TSH, and it was around 0.01. So I would like to ask Dr. Lata, should we label her hyperthyroid?
Before labeling her hyperthyroid, we should do free T4 and TSH levels so that if it is more, then we can label it as hyperthyroid.
Kakade sir, your opinion?
So the TSH is definitely suppressed, but the TSH report should not be read alone. It should be read in conjunction with T3 and T4. So the report should be complete. It is T3, T4 and TSH. And to label as hyperthyroid, we need to have elevated T3 and T4 value with suppressed TSH. So that gives us a state of hyperthyroid. But again, every hyperthyroid is not abnormal in pregnancy. In more than 95% cases, it is transient gestational toxicosis. That is more common phenomena seen in 1 to 3% of the cases. This phenomenon is limited to first trimester and it recovers by the 16th week of gestation. It is mediated by beta HCG. It doesn't require any treatment and it has to be distinguished from grave disease and which definitely require antithyroid drugs. So to distinguish between these two conditions, what we need, if the previous pre-pregnancy thyroid report, if it is available and if it shows the normal TSH value, then it suggests that whatever the changes happen in TSH that are of recent origin, so it supports the gestational toxicosis, presence of severe nausea, vomiting, abdominal pain or positive ketone body, all these are mediated by hyperemesis gravidarum. Again, they are mediated by gestational toxicosis. On physical examination, if the ophthalmopathy is present, presence of goiter is there and high elevated T3 and T4 levels are there, it supports grave disease. But many times there is a confusing picture and to distinguish between these two conditions, the most important test is TSH receptor antibodies, that is TRAP. If the test is positive, then it supports the diagnosis of Graves, and if it is negative, then it suggests the gestational toxicosis.
So TPO antibodies, they have a role in this?
TPO antibody has no role because even in Graves, 80% patients do have that TPO positivity. TSH-RAB is the best test to distinguish and whether to start treatment to give antithyroid drugs between these two conditions.
Okay, so next two I think you have answered. So how do we go about the treatment of this patient? Which drug, now she is in her first trimester, that is organogenesis. So which drug should we start her on?
So previous thought was that PTO is considered to be safe drug and neomercazole or carbimazole is teratogenic. But the recent data is coming that both are teratogenic drug, but the severity of the PTO causing teratogenicity is definitely less than the neomercazole. So the use of PTO is restricted to 12 to 16 weeks of pregnancy in lowest possible amount, and after 16 weeks we can use neomercazole. But by treating this disorder, we have to undertreat the disorder because the fetus is considered to be more sensitive than the baby, and even if the slight thyroid hormone excess is there, that is well taken care by the placenta, which is able to deactivate the thyroid hormone, but there is no protective mechanism to block the antithyroid drug. So the serious side effects like covenous atresia or fetal aplasia cutis, omphalocele, they are more common with neomercazole, and preauricular sinuses or neck and head cysts, they are common with PTU. But again, the side effects or the anomalies with PTU are less severe as compared to carbimazole.
So you would agree like PTU to be started in the first trimester. But is there any need to shift her later to mercazole or to continue with PTU?
PTU has got black box warning because of the hepatotoxicity. So it is better to shift after 16 weeks to neomercazole. But again, while treating, we have to use the minimum dose of the drug so that the target T4 or FT4 should be at upper limit of normal range or slightly above it. So we are under treating the hyperthyroid state and we are optimally treating the hypothyroid state during pregnancy. That is the basic.
And how frequently do we monitor her? Means what tests to be done and with how frequently?
Again, T4 and TSH both are required. We monitor once in every 4 weeks throughout the gestation. And postpartumly, there is, as autoimmune disease flare up during postpartum stage, there is increase in dose. So we have to increase the dose as compared to prepartum stage.
Dr. Pawar, what do you feel effect of pregnancy in hyperthyroidism?
So in hyperthyroidism, there will be effect on the mother as well as on the baby. So in the first trimester, increased chances of abortions are there. And again, because of hyperthyroidism, as sir has rightly pointed regarding the hyperemesis, so increased incidence of nausea, vomiting, especially if it's a twin pregnancy, then the chances are more, or if it's a molar pregnancy, then hyperthyroidism do occur more commonly, but maximum times what we see more of cases of hypothyroidism. Then in the second and the third trimester, fetal growth restrictions is very common, and in the third trimester, severe preeclampsia, early onset IUGR, early onset preeclampsia, these are the problems that can occur, and of course preterm labor. So those are the problem, and if the patient is on anti-thyroid drugs, after the delivery, the baby sometimes can go into hypothyroidism. So chances of NICU monitoring is also more, and neonatal morbidity can sometimes be increased. So these are as far as hyperthyroidism is concerned.
And postpartum during the breastfeeding?
Breastfeeding, as sir has mentioned, that we have to monitor the thyroid levels, and sometimes the requirement may increase, but what we have seen is that many times the patient's hypothyroidism sometimes gets, the dose required reduces, and accordingly we have to manage, and after every 6 weeks we have to call the patient again and check for the levels of TSH, T3 and T4. And accordingly we have to manage these patients. Most of these cases of hyperthyroidism later on land into hypothyroidism. So this is a lifelong monitoring that has to be required for these patients. Yeah, and as far as the contraception is concerned, if she's a the family is complete, then of course you don't have to forget the husband. Vasectomy is the approach, and for the mother, tubal ligation can be done, or if she's a first para delivered, then we can think about Mirena or progesterone only pills can be given, and of course barrier contraception is also important. Yeah.
I would like to make a point. First important is pregnancy per se is a kind of a hyperthyroid state, because the beta HCG, the receptor level. So when we get a TSH value of less than 0.01, we need to see T3 and T4, because every TSH need not be treated. The patient might have just an underlying, a subclinical hyperthyroidism also, and everything need not be treated. It's a physiological thing to have a lower TSH when we see a patient. So that needs to be seen properly. Otherwise, treating every patient would again, because the patient pregnancy itself is an indication that the TSH might come down. So that is one important point.
Kakade sir, one last question regarding this. Means after the delivery, when should we test the baby?
Day 5, because
Day
it
5.
takes around 72 hours to clear the maternal hormone and the physiological changes that are happening on the babies. So we normally check on day 5 FT4 TSH of every baby, hypothyroid both.
So the take home message from this case, PTU is the drug of choice as we have discussed. We can shift to carbimazole in the second, third trimester. We have to monitor TSH along with free T4, as sir has already said. Fetal monitoring, we have to be very vigilant, and the disease may worsen postpartum, so we have to keep a record even postpartum and ask the patient to visit us, and then we can monitor accordingly.
Yeah. Coming to our second case, actually this is just a revision of the first which we have an intrahepatic lecture. But we thought that this is very important for us because this just one symptom, when we discuss the case, we'll come to know. So she was a second gravida with 32 weeks of pregnancy, comes with a history of severe itching since 5 days and which was worsened, now disturbing her sleep. She has no other significant complaints and her vitals were stable, but she had only scratch marks all over the limbs and abdomen. So, sir, I would like to ask Gundeli, sir, what investigations need to be done in this case?
As you already told, madam, it is discussed once. And it is usually 32 means second trimester. It's classical a case of ICP means intrahepatic cholestasis of pregnancy, which classically presents with the itching, especially more in the night time. And it is reversible because it is pregnancy related. Once the pregnancy is over, the itching will be gone. So it is, and it is not associated with other rise in bilirubin, LFT derangement, coagulopathy, or other reversal failure. So it is I think it is a classical case of ICP.
So the gold standard test, as we had discussed in the morning, will be the bile acid levels. And Dr. Pawar, can you tell us the cutoff values for bile acid level?
So we have to classify it into 3 groups: mild, moderate and severe. If it is less than 40, 40 to 100 and more than 100 micromoles per liter. So if the levels are less than 40, then it is milder form of disease. But if it's moderate or severe, then you have to intervene and monitor these patients, and especially if it's a severe, then you have to terminate the pregnancy. So that is regarding the...
So the main question is, what is risk to the baby, doctor? You can take, Dr. Pawar. Risk to the baby.
Raised bile acid levels may lead to fetal anoxia, which may cause arrhythmias and sometimes fetal intrauterine death.
So this IHCP, most of the times when as a obstetrician, when we see these patients, only itching, if it is only itching, or is there any other, because it will be confused with acute fatty liver of pregnancy, other hepatic disorders, severe preeclampsia. So when such patients come to us, we have to, as an obstetrician, we have to first rule out the other causes which are more common. Those things, especially severe preeclampsia, acute fatty liver of pregnancy. So all these things have to be ruled out. And then we diagnose this, and then because milder cases we have to conserve in these cases. But if it's a case of acute fatty liver of pregnancy, or if it's a severe preeclampsia, proteinuria is present, then those patients, the management will be totally different.
Okay. Sir, we have seen in the morning the drug of choice is UCDA. What else you can add?
Many drugs have tried but still there is no any convincing reports that it will help, because basically it is a bile acid sequestration, accumulated bile acids in the tree, which are not excreted because of high levels of progesterone and estrogen, other hormones. So some drugs like rifampicin is added sometimes because it induces the hepatic enzymes to digest. Sertraline, other FAX inhibitors sometimes I read, but all these drugs are under trial. Still the gold standard treatment is ursodeoxycholic acid with a 300 mg BID or TID depending upon the weight. That is 15 milligram per kg per day. All other symptomatic treatment is more than. If itching is there, some local emollient, antihistaminics and other drugs. Otherwise, no any definitive treatment is there, because once the pregnancy is over, secretions will be better, that bile acids level will be less, so symptoms will be going automatically.
True. So, Dr. Lata, are there any indications for early intervention in this patient?
If bile acid levels more than 40, we can think about first giving steroids for fetal maturity, then induction of labor we can try. And if more than 100, then after giving steroid, we can immediately deliver that patient.
So we just wanted to see that...
If it is less than 40, you can deliver it at term. So, and if it is more than 40, then maybe depending upon the gestational age. If it is above 100, definitely immediately you have to terminate the pregnancy.
That is what the take-home message we want everyone to take, that bile acid is the gold standard and you have to monitor the bile acids. And if persistently, if the patient's bile acidity is rising, she's deteriorating, then you have to intervene. Thank you.
So we move on to the next case. Now this is a 24-year primi gravida presented with 8 weeks of pregnancy with history of rheumatic heart disease, and she had undergone a mitral valve replacement with a prosthetic valve 5 years ago. She has regular checkup and she is asymptomatic at present and is on warfarin. Now we all know that warfarin crosses the placenta and it has own side effects on the fetus. So Dr. Lata, can you say something about warfarin embryopathy?
Warfarin is a teratogenic drug. It may lead to abortions and fetal malformations like NTDs and cardiac anomalies. So these are teratogenic effects over the embryo.
You want to add?
So basically it's a whatever vitamin K dependent development, especially the cartilages and the bones. So skeletal dysplasia will be more with warfarin related because it crosses the placenta. So it is definitely contraindicated in the first trimester of pregnancy, especially between the period of organogenesis, that is 6 to 12 weeks of pregnancy. So after the 12 weeks of pregnancy, you can safely put the patient on warfarin, but the dose should be the minimal, less than 5 milligram. Depending upon the INR levels, you'll have to adjust the dose.
Yeah, so as you rightly said, mainly the skeletal abnormalities. Now this patient is already exposed to warfarin, she's 8 weeks pregnant. So first thing what we need to do is counsel the parents that she is already on warfarin, embryopathy risks are there. So after counseling the patient, now we come to you, sir. She is on warfarin, and what next now? What should we do?
As sir rightly said, warfarin have an embryopathic effect and it crosses the placenta. So basically, as we already know, she had undergone mitral valve replacement. So before, just to add one another point, once she conceived, we need to do a 2D echocardiography to see the valve prosthesis is adequately functioning. All the gradients are within normal range, and there are no the walls, the prosthesis is adequately functioning. Her PA pressures are within normal range, and there are no comorbidities associated, or there are no secondary changes related to the mitral valve prosthesis. Second, as sir said, the warfarin, it crosses the placenta. So doses, the main target is to maintain the INR within the target range because it can cause thrombosis and then prosthesis related issues. If the INR, target INR for mitral valve, once mitral valve replaced, our target INR is between 2.5 to 3.5. If we can able to achieve that target INR levels with the doses of warfarin less than 5 milligrams per day, then the guideline says it is permissible. But usually some patient requires higher doses of anticoagulation. In that particular scenario, we need to change our strategy. And second, the conventional or a standard practice is to switch the warfarin in first trimester of pregnancy. So we need to give the alternative anticoagulation doses, and then from second trimester onward, we can again switch to the low molecular weight or either unfractionated heparin.
So what dose of heparin is recommended?
Once you switch from warfarin to heparin, so low molecular weight heparin is usually advisable because easy to administer, and monitoring is also relatively easy. So low molecular weight heparin usual doses we recommend is 1 milligram per kg of her body weight. So accordingly, we need to give the doses. Secondly, just administering the LMWH is not sufficient. We need to check the some blood parameters, whether we have achieved the adequate anticoagulation. So for that, we have anti-factor 10A levels in the blood. We need to check it regularly to achieve the adequate anticoagulation effect of that LMWH.
So how to monitor this patient means how frequently, what investigations to be done as her pregnancy progresses?
Investigations wise, as I said, blood markers, anti-10 A levels in the blood. So we can check it. Usually guidelines says more frequently, but our practical experiences is that patient don't comply that much. So at least weekly or twice weekly once we can check anti-factor 10A levels. Second, clinical symptomatology is equally important. If the patient is having worsening breathlessness or she is having intermittent tachycardia, arrhythmias are very common with MV prosthesis in situ. So we also need to look for any arrhythmic episodes. So clinically we need to assess whether there is any worsening parameters clinically, and second, some blood parameters we need to assess regularly, and these patients require more individualized follow-up as compared to the other regular pregnancies. So anyways, even if we give adequate protection against the thrombotic events, so risk is still very high with these prosthesis in situ.
Dr. Pawar, now this patient has reached term. Now, how would you preferred mode of delivery, or during labor, what would you think of taking care of?
So basically, if the patient is on warfarin, we'll have to shift her on to heparin. So that is one thing. So if she is on warfarin to heparin, then you have to, there should be an overlap of 48 hours. So 2 days she will be on warfarin plus heparin, and then gradually we have to shift to heparin. Or if she is on heparin, she'll continue that dose. And if she the indications for cesarean section will be the obstetric indication. There is no per se indication for, because she is a case of valve replacement, to do a surgery. So she can deliver vaginally, so there is no problem. As far as the labor analgesia part is concerned, if we are planning to give epidural analgesia, then we have to consult with the anesthetist regarding the, because she is on heparin, so maybe 24 hours gap should be there, that should be planned if we are planning for epidural analgesia. During the first stage of labor, fluid intake has to be restricted. So IV fluid, I mean, orally she can take, there is no problem. So pain management and fluid management is important. Propped up position, oxygen has to be there, and of course the delivery has to be conducted in a tertiary care setup where we have the cardiac backup and ICU backup. That is important. Then we have to give bacterial endocarditis prophylactic antibiotics have to be given. Then minimum per vaginal examination should be done. In the second stage of labor, you have to cut short the second stage of labor. So that is the more favorable will be forceps application, because it will not take maternal efforts. But there is again controversy. Some do prefer to use vacuum for the second stage of labor. As far as post labor is concerned, we have to give again put the patient on heparin for at least 10 days, and then we can shift her back to warfarin. Patient can be kept for breastfeeding, the patient can be kept on warfarin. There is no absolute contraindication as such. So postpartum patient can be on warfarin again. And as far as contraception is concerned, you can use Mirena or progesterone only pills, or DMPA is a good contraception that can be used. And of course, again, don't forget the husband, vasectomy.
Also, IV administration of Lasix to prevent cardiac overload is very important.
Yeah, on this I would like to ask Dr. Gaikwad also. If she lands into a LSES, now regarding her fluid intake, IV fluids we have to give. So just one line on her fluid intake, choice of antibiotic, and any role of furosemide.
Choice of antibiotic is for infective endocarditis prophylaxis. So standard antibiotics, whatever ceftriaxone or these things we can use. There is no special thing for that. Second, as far as IV fluids are concerned, IV fluids should be used judiciously with monitoring, hemodynamic monitoring. If you feel that there is a signs of fluid overload, then we need to use the loop diuretics, potent diuretics, injectable. And there is a chance due to pain and sympathetic overactivity, there is a chance of arrhythmia during that peripartum period. So we need to monitor for that. If it is a supraventricular arrhythmia, the most common is atrial fibrillation or a flutter. If it is because it can destabilize the hemodynamics, because once arrhythmia sets in, there is a high chance of she will land up in a pulmonary edema. So it should be addressed as early as possible with the help of antiarrhythmic drugs, and if necessary, we need to prepare ourselves to manage the pulmonary edema.
One practical scenario I would like to add, because these patients won't be electively admitted every time. So if the patient is on warfarin and comes to you in labor, then at that time you need to check the INR of the patient on admission. And if the INR is on the higher side, and if you are planning a normal delivery, sometimes you might need to keep the FFPs also ready. If there's a lot amount of bleeding, sometimes giving vitamin K at the time is also important. And if the patient is on heparin, I think so we had the discussion prior also. If the patient is on low molecular heparin, single dose we would be acting for at least 8 to 12 hours. So the timing needs to be planned accordingly.
Yeah, so in this case, definitely it is a multidisciplinary approach which we have to keep in mind.
Moving towards our next case. So she was a 29-year-old woman presented with 8 weeks of pregnancy. She was a known case of rheumatoid arthritis on methotrexate and NSAID, and at present she was asymptomatic. So I would like to ask, she has come to Dr. Lata, so I would like to ask what is the potential risk of methotrexate exposure?
Methotrexate is a folic acid antagonist, so it hampers the growth of the fetus, and also it has teratogenic effects also. So it is very a risk for the fetus.
So you would like to advise her termination of pregnancy?
No. Other modalities.
You will counsel her. Yeah. Okay. Then you have counseled her, and she said she wants to continue the pregnancy. So you have referred her to Dr. Iser. So we want to know that how this rheumatoid arthritis will behave during pregnancy, sir.
In fact, she is already on methotrexate before conception. So it is a high-risk pregnancy, and complications, especially embryopathy, involving face, skull, limbs, that can be detected and explained to the patient that this is high-risk pregnancy. Another effect it can have, methotrexate can affect cardiac tissues. So that is another severe risk. So in spite of this, if they want to continue pregnancy, rheumatoid arthritis usually undergoes remission during pregnancy and may flare up in postpartum period. So if there are minor flares during pregnancy, because of you discontinue methotrexate, put her on safer doses, medicines like hydroxychloroquine or sulfasalazine, which are allowed in pregnancy in full doses. Till that time, if there is flare, till these drugs take over, you can add low dose prednisolone, minimum doses, to keep arthritis in remission. Aspirin in these patients is not indicated if there are no other indications like thrombosis, previous thrombosis, or if they are negative for SSA antibodies and SSB antibodies.
So we will basically give her hydroxychloroquine and
sulfasalazine,
steroids or sulfasalazine.
SOS, visolone,
Okay.
prednisolone.
And if there is a postpartum flare, what would be the drug of choice then?
Usually these patients flare up in postpartum period, and babysitting is difficult for them. So for immediate tide over, you can use high dose steroids prednisolone, and then make the life easy. And along with that, you continue or adjust the doses of sulfasalazine, hydroxychloroquine. They are safe in lactation also. Methotrexate and mycophenolate mofetil, they are not safe during postpartum period or lactation.
Dr. Pawar, what will be the effect of RA on the fetus?
So basically it's an autoimmune disorder. So again there is increased chances of preterm labor, fetal growth restrictions, and if the patient is on methotrexate, obviously already mentioned regarding the, because it's a folic acid antagonist, so all neural tube defects, all embryopathies are also there, and increased chance of abortions will be there in the first trimester.
So I think she had a normal delivery, and after that we can again restart her methotrexate after what time, sir, actually?
During lactation, methotrexate is not advocated.
Okay.
So you have to control her with hydroxychloroquine and sulfasalazine. Okay. If they can afford TNF inhibitors, you can start TNF inhibitors if indicated.
Okay.
One point I would like to make, if such patient comes to you on OPD basis and wants to plan pregnancy, so in that case we need to counsel the patient that the patient needs to be off methotrexate for at least 6 to 8 weeks period. So that is the drug washout that is needed. So you need to counsel them that the drug needs to be off for particular duration and then plan the pregnancy. So it's just not that you discontinue the drug and the patient gets pregnant in the next 2 weeks. So that would be detrimental. So that 8 weeks or 2 months washout is needed in between.
That is a perfect take-home message. So actually the crux of all our medical disorders of pregnancy is the preconceptional advice what we give to the patient that ensure that the disease is well controlled before conception. And these are the points we have already discussed, so we will move to the next case.
Now this is a elderly primigravida, an IVF conception, and now she is a twin pregnancy in her second trimester. We did her USG and we saw that the fetus is macrosomic. She has got polyhydramnios. Now this is her first visit. No other investigations till now she has done. Now when we see this on sonography, we think of GDM. So now in her second trimester, sir, what would you prefer? Like, should we go in for an OGTT or her fasting PP levels? What exact test should we do since we suspect GDM and second trimester?
So it is not gestational diabetes because this pathology happened in second trimester and it is of milder form. The sugars are never below 200. Looking at this case, this is a case of pre-existing diabetes that is missed and the window of opportunity that is present preconceptionally, that is missed and the patient presented late. Now for first time it is better to do OGTT because it is more sensitive than HbA1c because the HbA1c during second trimester give falsely low value considering increased plasma volume and increased RBC turnover. So HbA1c tend to be low by 0.5%, hence the gold standard to diagnose is OGTT. It is already 230, so already it is type 2 diabetes that is diagnosed during pregnancy or pre-existing diabetes that is diagnosed during pregnancy.
Okay, so now can we try her medical nutritional therapy exercise or we directly put her on oral hypoglycemic agents?
So it is combined with MNT plus exercise plus directly insulin plus minus OHA because we have limited window and we have to control the sugar as early as possible. Major risk of that teratogenicity because of high sugar that we have already missed. So what we are preventing by treating her is macrosomia, neonatal hyperinsulinemia, whatever the effects are there, shoulder dystocia or hypoglycemia, that we want to prevent. And for that we don't want to waste time. It is better to treat her with insulin, MNT and exercise should be combined with the insulin.
And preferred insulin?
The Preferred insulin is basal bolus regime, means 3 times rapid acting insulin plus 1 long acting insulin.
And how frequently do we need to monitor her sugar levels?
Generally, what they advise, they suggest a 6-point table, that is breakfast, lunch and dinner, before and after. They advise all 6 sugar for tight control, but what we generally do, 1 sugar every day, means on day 1 we advise before breakfast, on day 2 after breakfast, day 3 before lunch, day 4 after lunch, day 5 before dinner, day 6 after dinner. And if the fasting is not getting controlled, we advise 2 am sugar once in a month to adjust the nighttime insulin. And the before sugar should be below 95, 1 hour sugar around 140, 2 hour sugar below 120. That should be the cutoff.
And with insulin, if she is maintaining these sugar levels, so can we shift her to oral hypoglycemic or to continue with the same insulin?
Already looking at her value, and as pregnancy progresses, there is rise in insulin resistance. It is unlikely that she will get the optimum level on oral tablets. So it's better to continue her on insulin throughout the pregnancy.
Dr. Pawar, is there any need for her LSCS, or what would you suggest, like when to take a decision regarding her delivery?
So if the sugars are well controlled, we can go up to term pregnancy. So around 38 to 39 weeks of pregnancy, we can induce the induction of labor can be done. If the baby is macroscomic, so the Western textbook will mention 4.5 kg, but in Indian context it will be different. So it will be around 3.5 kg plus. Again, you have to do the pelvic assessment, and every case will be different. So if the pelvis is not adequate, then elective cesarean section at around 38 to 39 weeks. And if the sugars are controlled, definitely under the cover of dexamethasone, it has to be done for these patients. And ultrasound parameters, you will see the biacromial diameters, so to predict the shoulder dystocia if you are planning for a vaginal delivery.
Kakade sir, during her postpartum period, how frequently sugars to be monitored and the dose adjusted accordingly?
Initial assessment should be done on day 3, then after 1 week, and around 6 weeks we have to do OGTT again to see the glycemic status, because the HbA1c changes that will, because of pregnancy, takes another 2 to 3 months to restore, but we have to do OGTT, and the chances of future diabetes are around 40 to 50%. And the most important factor that determines the future diabetes risk is post-pregnancy weight gain. So she at a constant risk, it is better to monitor her throughout the next 4 to 5 years, once in every 6 months with HbA1c and fasting PT.
Many times we see that when the patient delivers by LSCS or normal delivery, the insulin requirement is drastically reduced. So that is more important, that risk of hypoglycemia is significantly high in the postpartum period. So many times we try and try to skip the dose or lessen the dose early, anticipating that there would be hypoglycemia in the patient. So that point needs to be taken. Second is whenever we start insulin, the counseling of the patient as well as relative is important, because that is a young patient and we are counseling them for an injectable to be taken 3 times a day at home. And many times compliance goes down, or if the patient doesn't take it, the patient directly lands in complication and comes. So counseling them, it is very important that it's a needed thing that needs to be done and needs to be monitored. And you prescribe a glucometer on the first visit itself, give them a chart and tell them that you need to keep in touch with me, or give some personalized test so that they don't lose that confidence in you, or they don't understand that the disease is important, the control is also very critical to be done as early as possible.
Yeah, so patient education is very important regarding self-monitoring of sugar levels. So move on to the next case.
So she was a 26-year-old primigravida with 6 weeks of pregnancy. She was diagnosed with SLE and she presented in the OPD. She was a patient who had really come to our hospital, and At that time, what the history she gave that she had put some acid to clean the bathroom and her nails and everything palms has become blue at that time, 6 months back. And then at that time her RA was positive and she was treated with IV rituximab 4 doses and IV steroids. Now when she came to OPD, she was totally asymptomatic and she was on this prescription. Tablet diltiazem 60 milligrams, tablet HCQ 200 milligrams, tablet pregabalin 75 milligrams, tablet azithromycin 50 milligrams. So we did her ultrasound and the baby was live, doing good. So we referred the patient to Dr. Rai for further management.
Already a known case of SLE, features being vasculitis more prominent. Other features are not mentioned. The drugs which she is receiving, they are pregnancy safe drugs. There is no problem with these drugs. HCQ is safe. Azathioprine can also be given with monitoring. And diltiazem, I don't think is that safe as compared to what we use is nifedipine for vasculitis, short acting, and then pregabalin can be used during pregnancy. So if her vasculitis is controlled, she is symptomatically better, these drugs should be brought to the minimum doses. And SLE activity should be monitored throughout pregnancy. For this monitoring of SLE, we have clinical parameters like the worsening of symptoms, if is there like hair loss, stomatitis, then skin rashes, and arthritis or arthralgia. If she had early any of these, whether they are in remission or they are worsening, that is one thing. Then she needs evaluation with investigations like complete blood count for cytopenias. Urine examination is necessary, and which is the most important investigation during pregnancy to know proteinuria and active urinary sediment like fragmented RBCs and granular cast, which are very important to detect in fresh urine sample. You cannot send urine and await the report. You have to tell the pathologist to examine within an hour so that the active urinary sediment doesn't deteriorate and it can be detected very well. Other parameters which are used to monitor in SLE are ESR is not significant in pregnancy, but CRP you can monitor. Then C3, C4 levels if not done earlier, because complement levels are important for activity of the disease. In pregnancy they go on increasing. If you know where C3, C4 levels previously, comparison becomes easy. And then if you find any abnormality in the urine, proteins or active urinary sediment, you have to do serum creatinine levels. These are very important. Monitor her blood pressure. And another thing is dsDNA levels. Anti-dsDNA is very important. That gives an idea whether she is progressing for lupus nephritis, because dsDNA is specific for lupus nephritis activity along with C3, C4 levels. So all this every trimester you should monitor, and if it is active disease you have to monitor it very frequently. This will also help in differentiating from preeclampsia of pregnancy, because though proteinuria is found in both conditions, you will not get active urinary sediment during preeclampsia. Hypertension may be found in both.
So prophylactically, can we start her on aspirin and low molecular weight heparin?
If antiphospholipid is positive, antibodies are positive, and if her previous pregnancy, she is primary or multivara, I don't know.
Primary, sir, primary.
Primary. And there is no history of vascular thrombosis previously. And APL is positive. You can put her on aspirin. But if there are, if in cases where there is previous vascular thrombosis or previous bad obstetric history, in those cases you need to put her on aspirin and heparin as well.
So Lata, what are the maternal complications anticipated in this case?
Maternal complications related to vasculitis are pruritus or rash, and related to arthritis and pleuritis, pericarditis, and renal complications like proteinuria and renal urinary cast, and neurological complications like seizures, psychosis, and hematological disorders like hemolysis, leukopenia, thrombocytopenia, and other complications related to anti-nuclear antibodies and anti-smooth muscle antibodies. Like
Right, she's at a high risk of PIH also actually. So that's why we have started her on diltiazem, or we can continue with depin or start with lababet. Not lababet, but depin actually, should we start her on depin? Because she is high risk for PIH. No?
Okay.
So how will you manage this patient?
Just a minute, I would like to add, these patients, especially as we are discussing rheumatoid arthritis, patients with collagen vascular disease should also be evaluated for presence of SSA and SSB, anti-Ro and La antibodies, because this will project whether the infant will be affected with cardiac issues, especially complete heart block, which is very rare, but you have to monitor, and whether patient neonate will develop lupus erythematosus, neonatal lupus. So that SSA, SSB monitoring and evaluation is important.
You would like to add?
Yeah, so these patients will be at high risk for venous thromboembolism, so, and severe preeclampsia. And as sir mentioned, if they are positive for anti-RO antibodies, then these patients generally the baby can land with sudden intrauterine demise at around 36 weeks of pregnancy. So if they are RO positive, then you have to deliver them early. So that we have to remember. And it's a multi-systemic disorder, so it will require disciplinary approach, and don't try to deliver these patients in small nursing homes.
Yes, so it has to be an institutional delivery. So just I'll read the take-home messages. You have to plan pregnancy. Preconceptional counseling is most important. Multidisciplinary care is must. It is definitely a high-risk pregnancy, so need expert monitoring. Anticipation of maternal risk like flares, preeclampsia, and thrombosis. Fetus is also at high risk of IUGR, preterm birth, fetal loss, neonatal lupus. No drugs which are safe in pregnancy. Use aspirin and heparin when indicated. Delivery should be individualized. Risk of flare in postpartum and contraception advice is must. Thank you.
One more point. SLE in postpartum period, flare, can be very severe with lot of complications, especially thrombosis. Postpartum preeclampsia can also develop, and this is called as fourth trimester. So you have to be very particular in monitoring and keeping the disease activity down, controlled.
Actually, all the immune-mediated diseases, they have a postpartum flare-up kind of picture. So every disease need to be monitored accordingly and look for flare-ups. But immunomodulation in pregnancy is a known component, so we know about it. Just how the disease process behaves in individual is different. So it's not necessary that every patient will develop it, but we need to keep a close eye on it.
Thank you everyone. Are there any for the wonderful panel discussion? Are there any rapid fire questions we can take, one or two? Yes, sir.
It's about postpartum thyroid monitoring in the baby, neonatal. As sir rightly said, that the thyroid level should be monitored on the day 5 for the baby, neonate. So at present, I'm doing a little study in my own hospital. I'm doing cord blood TSH for the babies. And what I found in literature that the levels which we need to act on are different at different times. For the cord blood level, they said that even if the TSH levels are beyond 20, then only you do after 1 week. For 48 hours, they said the level of TSH was around 10, and as the standard levels are on day 5. So even if we do cord blood TSH or day 2 TSH or day 5 TSH, as sir said, we need to adjust the levels on which we have to act accordingly. Thank you, sir.
Thank you all the panelists. Thank you.
I thank our experts for sharing these updated and practical approaches. I request Dr. Sudesh Doshi, Dr. Satish Gorse, and Dr. Rohini Deshpande to felicitate our moderators and panelists.
Rudrakshi sir, please join us. आणि विनू सर, या सर. मुंडेली सर आहे तिकडे. आणि सिंगल सर. गोडसे सर आणि यांना आम्ही बोलवूनच ठेवलंय.
I request Dr. Tapadia sir to join the stage.
स्नेहल येऊन जा. I would like to give a round of applause for all our Master of Ceremony, Dr. Anshita, Dr. Anushri and Dr. Randhir. Please come on the dais. We would like to felicitate you. It was such a smooth encounter that everyone asked us whether you have hired some professional people for this program. I request Godse sir to please felicitate all our Master of Ceremonies. Can we have the bouquets, please? Very, very nice. Oh, would like to invite Zorvia Pharma, Mr. Allat Joshi and Mahazani, sorry, and entire team to please come on the stage. They were so cooperative from first day. We would like all of you to come on the stage. And I request Godse sir to, as a token, to give one. Rudrakshi sir, as a token of appreciation from all of us. Yes, thank you so much.